हाँ सर, चल रही है सर। ये सर खड़े हैं सर, एक मिनट बोल रहे हैं। कैसी सर इसकी रिकॉर्डिंग मैं करूँगा कहाँ पे डाउनलोड? सर वो वैसे ही हैंग करता है रोज, 5 बजे नेटवर्क जाता है यहाँ पे रोज। कल अलीशा के टाइम पे भी गया था, परसों भी गया था, और उस 5 बजे जाता है, फिर ये बंद करना पड़ता है तब आता है, पता नहीं क्या चक्कर है।
तेरा ये वाईफाई है? अच्छा उस, ठीक है।
आ रहा है ना? इधर देखो, उधर चल रहा है. Okay, good afternoon everybody, and welcome to the 5th day of the course, and we are going to start today with a approach to X-rays for anesthesiologists, and the talk to be taken by Dr. Zafar Niaz. Dr. Zafar Niaz is professor in Department of Radio Diagnosis at SGPGI Lucknow, and he has been awarded University Medal in during his undergraduate. Then he has been Radiation Safety Officer here in SGPGI, and he is a course coordinator for BSc Medical Technology course that we started in SGPGI, and he is having more than 76 publication to his credit. So I am, and the chairperson for this session is Professor Haider Abbas, sir. Professor Haider Abbas is professor in Department of Anesthesia earlier, and now he is heading Department of Emergency Medicine at KGMC Lucknow. And Professor Dinesh Singh, who is also the Professor Department of Anesthesiology at KGMC Lucknow. Maybe till they join, I will request to Dr. Zafar to please start his talk. Resume slideshow. स्लाइड से शुरू कर देना भैया, 1 मिनट बस आप बैठिए, उठेंगे तो एंटीसेप्टिक लगा लीजिएगा. इसको शेयर कर दो, वो ऑफ कर सकते हैं. कर्सर आप यूज कर सकते हैं एक्सरे को. नीचे हरा वाला है.
A very good afternoon to all of you. First of all, I would like to thank Dr. Sandeep for giving me opportunity to present this talk here. I'll be discussing very basics of chest radiography in the 45 minutes to 60-minute time. It's very difficult to cover the whole of the chest radiography, but some of the essentials of the chest radiography I'll be covering. And before going into the lecture, I'll be showing some cases, and what is the abnormality? So on the chest X-ray, first of all, I would like you people to spot the abnormality. I don't expect the diagnosis, but at least what is abnormal on the chest X-ray? I mean, first of all, we should try to make out whether this chest X-ray is normal or abnormal. So this chest X-ray is very pertinent in the present time. So what we are seeing some haziness in the outer portion of the middle and lower zone bilaterally. And this kind of geographical increased opacity area on chest X-ray is called consolidation. And so the joining back. Okay. So, okay, let me start again. So this is a chest X-ray, and what is abnormal here? So as we can see, there are areas of increased opacity in the outer portion of the middle and lower zone, both sides. So a kind of geographical area of increased opacity. We also describe it as radiologically as a consolidation. So bilateral peripheral consolidations, and this chest X-ray is very pertinent in today's time. This is a case of COVID pneumonia. Another chest X-ray, what is the abnormality here? We see lot of crisscross lines. And this pattern is described as reticular opacities. So we are having lot of crisscross lines in the chest X-ray, and the common cause is interstitial lung disease. I'll be going into that in further detail, but I'm just showing some interesting cases before getting into the talk. What is the abnormality here? We see multiple small nodules scattered over both lung fields, and these nodules are not having any predilection for fissures or for subpleural location. Almost all areas of the lungs are equally affected. This is an example of miliary opacity. A classical example is miliary tuberculosis, although some other cases like fungus and some rare kind of metastasis can also produce similar picture, but the classical example is miliary tuberculosis. So now I'll be going into the talk. So what is a chest X-ray? Basically, in chest X-ray, we put the patient between an X-ray tube and a receptor or the cassette, and we expose the patient with the X-ray beam. The X-ray beam passes through the body, and depending on the attenuation of the X-rays, a shadow is produced. And this shadow is made up of multiple shades. Some are blackish, some are whitish, some are grayish. So depending on what structure the beam is penetrating, whether the beam is penetrating the lung, the beam is penetrating the bone. So different opacities appear on the chest X-ray depending on the anatomical organ. And a very common terminology which we use on chest X-ray is the radiolucent and radiopaque. So anything which is more blackish is radiolucent. Anything which is more whitish on chest X-ray is radiopaque. So this is a very common terminology which we use on chest X-ray. Now coming to the Röntgen opacities, there are 4 basic Röntgen opacities. One is the air opacity. Air opacity is the black opacity, which we can see on this chest X-ray, like the lungs and the air around the body. These are blackish areas. They are produced by the air. As you know, air offers very little resistance to the X-rays. X-rays pass easily through these structures, and they produce a black shadow. Whereas if we see the bone or the metal, these structures are very dense structures. They stop the X-rays or they absorb the X-rays, and a whitish shadow is produced where these structures are, like the bones. We can see the bones, especially the cortical bones. Now, some of the organs like heart, liver, these organs, they are of water density. I'm not saying they are entirely of water, but in front of X-ray, they behave like water, and they produce, they also produce a white kind of opacity, but not that dense of bone or metal. So this is a soft tissue or water opacity. So these solid structures like liver, liver, heart, they produce soft tissue opacity. And fat, although fat is fat is solid compared to the water, but it offers less resistance to X-ray compared to the water, and it is more lucent than the water or the solid organs. So fat is grayish in shades. In some of the areas we can see fatty shadow here in between the muscular planes, not everywhere. So fat is somewhat grayish. It's not totally black, but it is grayish. So these are some of the basic opacities on the chest X-ray. Now coming to the technique of the X-ray, very brief about this. So in the patients who are able to walk, who are able to sit, we always prefer a PA view film. And in PA film, this is called posterior anterior film, the X-ray beam is directed from behind and the cassette is in the front of the patient, and we ask the patient to take deep inspiration and hold the breath in the deep inspiration, and this X-ray is called PA film, PA view erect film, and this is the ideal film. But lateral view also, nowadays we don't do that much lateral films because now CT scan is available, and if we see any abnormality on a PA film, we always go for CT scan rather than going for lateral view. In the past, this view was more commonly taken. Now, especially in sick patients or the ICU patients, these patients cannot sit down. They are mostly in the lying position. So we can't take this PA film, PA erect film. So mostly a AP anterior-posterior supine film is taken. And the cassette is placed behind the patient and the X-ray beam is focused from the front. Now this film compared to the PA film has certain disadvantages, like the heart and the great vessels, they appear magnified. The clavicles are projected higher, scapula sometimes overlies the lungs, ribs appear horizontal. But still it provides useful information in these sick patients, and we have no choice but to do this kind of supine films in the ICU settings in the sick patients. Now coming to the reporting part or the interpretation part, before going into interpretation of individual organs, we should try to see some of the technical things on the chest X-ray, and most important of it is identification and the date. So you should first always match whether the X-ray belongs to the patient by comparing some CR number or some unique ID number. And also the date is also very important. So we should try to see if there are multiple X-rays. It's always a good idea to see them in a chronological orders, and then only you will be able to appreciate the changes which are happening over time. Now coming to the technical things is the marking, whether the right and left is marked correctly or not, whether the X-ray has been done in adequate inspiration is not. I mean, some of these points will not hold, will not apply to the sick patients or the ICU patients who are unable to take adequate inspiration. But at least in the patients who are like walking and talking, they can do where we can get a good inspiratory film. So after seeing the marker, we see for whether the X-ray has been done in the adequate inspiration or not. Then we see the rotation. I'll be explaining further about this, centering and the exposure. So these are some of the technical things on the chest X-ray, and we should see whether the quality of X-ray is good or not by seeing these technical parameters. After that, everybody should develop its own algorithm or a paradigm how he is going to interpret the chest X-ray. Some people prefer to go from center to outside. Some people prefer to see the X-ray from outside to inside. So this is, you should develop one way, but at least everybody should try to make some protocol so that he may not miss important things, and he or she has paid attention to each and everything on the chest X-ray. So now this is one scheme which I am following, but everybody can develop their own pattern or their own scheme. So first I see the trachea, then I see the heart and mediastinum, hilum, lung and hyla, pleural recesses, diaphragms, below diaphragm, bones, soft tissue and hidden areas, some of them I'll be showing them. So first thing I'll be talking about the exposure. So exposure is the adequate amount of the radiation. So everybody is having a different body habitus. Some people are thin, some people are obese. So every patient needs adequate exposure depending on his body habitus, and then only we'll be getting a good quality X-ray. So here are three X-rays. The top X-ray is of a good quality, and how we tell that both lungs are nicely seen, and the penetration is good means the intervertebral disc spaces are visible, only through the top half of the heart shadow, but not visible in the lower half. Whereas the bottom X-ray, one of them is underexposed, means although the lung is seen, but everything else is totally wiped out. No details can be obtained about other things. And the another one on the bottom is totally blackish. It is overexposed, more amount of radiation has been given, and lungs are totally blacked out. No details can be obtained about the lung. So an adequate exposure is very important. Now coming to the effect of inspiration. So first of all, how we look at the inspiration. So if there is a chest X-ray, so we either count the anterior rib or the posterior rib. If we are counting the anterior margin of the ribs, then at least we should see 5 to 6 ribs above the diaphragm. Okay, then only we can say this is a adequate inspiratory film. If we are counting the posterior margin of the ribs, like these are the posterior margin of the ribs, then at least 9 to 10 ribs should be visible above the diaphragm. Then we can say that this X-ray has been taken in adequate inspiration. And this X-ray is this X-ray of the same patient, but here the inspiration is inadequate. So you can see the heart appears magnified. In the lower zones, there is some haziness, which we might misinterpret as some consolidation. The pulmonary vascular markings are quite prominent. So it is important to obtain a good quality inspiratory X-ray. Now coming to the rotation. Rotation means whenever the patient stands, the cassette should be equally touching the both sides of the both right and left side of the body. If the patient is somewhat oblique or tilted, then one lung may appear more lucent, the other lung will appear whitish, one hyla may appear small, the other hyla may appear large. So both sides of the body should be in proper contact with the cassette without any rotation. And how we see the rotation? Generally, we see a midline structure like the spinous process. We see the spinous process of the vertebra, and we see the medial margin of both the clavicles. So on both the side, the distance should be equal. Then we can say that there is no rotation. However, in the lower X-ray, there is gross rotation. One side of the clavicle is far away compared to the other side. So again, this can lead to misinterpretation. And this thing about magnification, as I already mentioned, that in ICU or settings in sick patients, generally anterior-posterior X-ray is obtained by a portable machine. And here there is a magnification of the heart and vessels. So the mediastinal structures appear about 15% wider or 50% magnified compared to the PFL. So this is important whenever we are commenting on cardiomegaly on a AP film. Now coming to the interpretation part, as I already mentioned, that everybody should develop its own unique scheme or unique pattern of seeing everything. So I am going from center to outside. Somebody might prefer to go from outside like soft tissue, then chest wall, then inside. So it's your preference. So first structure, I'll be seeing the trachea. Normally, trachea should be in the midline, and it divides at the carina, which is almost at the level of T4 or 5 vertebra. Or if you see the ribs, then at the level of the 6th rib, posterior margin of the 6th rib. Trachea may be slightly on the right side because of the aortic arch, but there should not be significant deviation of the trachea. And of course, before commenting on the tracheal deviation, we should see whether there is rotation or not. So if there is a rotation in the film, then trachea might appear deviated. And some of the important causes of tracheal deviation are like tumor, pneumothorax, major atelectasis. So these are the causes of mediastinal shift, and they can also cause tracheal deviation. After seeing the trachea, we can see the heart. So heart, in addition, there are two things we see in the heart. The first thing is the size of the heart, and another thing is the morphology of the heart. That is also important. So in the heart, we see the size. So normally, a heart should be less than 50% of the internal thoracic diameter. There are some exceptions like in neonate and athletes. And in the serial films, especially in ICU patients, if on serial radiography, there is an increase in the diameter of the heart by more than 1 centimeter, that can also be considered as a cardiac enlargement. So this is how we see the diameter of the heart. So we take the widest diameter of the heart, that is heart width, and then we take the internal thoracic diameter, the maximum thoracic diameter inside the ribs, inside the margin of the ribs, and we take this as an internal thoracic diameter, and the heart width should be less than 50% of this internal thoracic diameter. Now, after seeing the heart, then we see the hilum. So what is hilum? Basically, from the heart, the major pulmonary vessels, that are pulmonary arteries and veins, they supply the lung. So they form opacity in the center part of the lung. These are called hilum, and the main components of these hilum are pulmonary vessels, bronchi, and some lymph nodes, which are usually small, not large. And usually the left hilum is slightly higher than the right hilum, and they are usually equal size and equal density, and outer margin of the hilum should be concave. So these are the features of a normal hilar shadow. I'll be talking about abnormalities later on. Now, after seeing hilum, we see the lung and the pulmonary vasculature. So in the lung, we see both the lungs. We see presence of any nodule, any opacity, anything abnormal in the lung. And in addition, we see these pulmonary vessels. So in some conditions, these pulmonary vessels may be prominent, may be dilated, and some of the way by which we can tell, like in the peripheral 1/3 of the lung field, in the outer 1/3 of the lung field, normally we should not see any vascular markings. Another way of telling is that in the first intercostal space, if we see a vessel more than 3 millimeter diameter, that is also suggestive of dilated pulmonary vascular markings. In addition, we can also see the diameter of the right descending pulmonary artery, and normally it should be 10 to 16 millimeter in males and 9 to 15 millimeter in females. So now, so far we have seen lungs, pulmonary vascular markings. Then we see the costophrenic angles or costophrenic recess. Seeing this recess is very important because in case of pleural effusion, normally in erect patient, the pleural fluid collects here and it causes blunting of the CP angle. So that is also very important to comment on the CP angle. After seeing the CP angle, that is costophrenic angle, we see the diaphragms. Normally the right diaphragm is slightly higher than the left diaphragm. In most of the cases, sometimes they are at equal level. So if there is any discrepancy of more than 3 centimeter in both the diaphragms, that suggests an elevated diaphragm, and we have to investigate that, what is the cause of that. Now, in addition to the diaphragm, we also have to look below the diaphragm for any abnormal air shadow like pneumoperitoneum or any abscess or absence of normal gastric bubble, and for any abnormal calcification. So we also have to look below the diaphragms. Now, after seeing all these things inside the bony cage, we also pay attention to outside the bony cage. And what we have outside, we have these ribs, the clavicles, scapula, and the soft tissue, that is chest wall and breast shadows. So we also pay attention to these things. Sometimes there may be bony lesion, like in this case, you can see there is a lytic expansile bony lesion involving one of the ribs on the left side. This is a case of fibrous dysplasia. So once in a while in chest X-ray, you might see some bony abnormality also. So it's a good idea to pay attention to the bones as well. And in some time, patients have mastectomy. So those observations also have to be made. Now, there are certain areas on the chest X-ray which are described as hidden areas. Why these are called hidden areas? Because these areas are usually congested. These areas have a lot of overlapping shadows, and abnormalities may be missed inside in these areas. So it's a good idea after you have reviewed the chest X-ray, pay a second look, give a second look and pay attention to these hidden areas. And these hidden areas are the apices. So we should look carefully in the apices. There are a lot of bones overlapping over here. And you also know that tuberculosis is very common in this location. So we should pay attention to the apex around the hila. In hila, usually there are a lot of vessels. So sometime opacities may be missed. In the retrocardiac location, part of the lung is not visible because of the heart, but you can have subtle signs of abnormality if you look carefully over the heart shadow. And also under the diaphragm. As you know that diaphragm is not the lower limit of the lung. Lung goes way beyond the diaphragms because the diaphragm is a dome-shaped structure. So a good amount of lung parenchyma is hidden behind the diaphragm. So we should also try to look behind the diaphragm. Sometimes lung opacities may overlap with the diaphragm and can produce opacity over that. So these are the hidden areas and we should pay attention to these areas. Now I'll be reviewing the normal anatomy, whatever we have learned so far. So as I told you, we see the trachea. This is a central lucent tube and it divides at the carina. Then we see the mediastinum. In the mediastinum, we have the heart. This is the heart shadow. Then we have the aortic knuckle, aorta. And from the mediastinum, both sides, we have hila. Hila are pulmonary vessels. So we have right hilum, left hilum. As I mentioned, both hilum should be of equal size, equal density. And the outer margin should be concave. Of course, the left hilum may be slightly higher than the right hilum. Then we see the lungs. We see both the lungs and the pulmonary vessels in the lung. We also pay attention to the costophrenic angle on both sides. Then we see the level of the diaphragms, the right diaphragm, the left diaphragm. Then we see the areas below the diaphragm for presence of any abnormal air shadow, to look for the normal location of the stomach fundus or the gastric bubble. And then we pay attention to the bones which are visible, like the vertebra, the ribs, the clavicle, the part of the humerus, the scapula, and the soft tissue shadow of the chest wall, that is the muscles and subcutaneous tissue of the chest wall. So after reviewing all this, we can say we have completely evaluated a chest X-ray. Lateral film, as I told you, nowadays very less commonly obtained because of the availability of the cross-sectional modalities like CT scan. However, if we have a lateral film, at least we can make out that the anterior-most part of the sternum, this bone is the sternum, and the posterior-most bony structure visible are the vertebrae and some of the posterior margin of the ribs. And in between, we can see this shadow, anterior shadow, a large shadow. This is produced by the heart. And from the heart, we can see the aorta, arch-like tubular structure from the aorta. And then we can also make out bronchi and the hilum. And lower down, we can see both the diaphragms overlapping over each other. And of course, the rest of the lucency is formed by the lung parenchyma. So this is how we can look at the lateral film. However, very infrequently it is obtained nowadays. Now coming to some of the abnormalities. So on a chest X-ray, either we have a abnormality which produces decreased lucency, decrease its opacity, means more lucency, or it may cause opacity, means more increased whiteness. So like in this example, what we see, there are a lot of lucent areas in the chest wall. In the chest wall, we can see a lot of mottled kind of lucencies which are extending into the neck along the lateral chest walls. Even we can see fibers of the pectoralis muscle. So this kind of appearance is seen in cases of subcutaneous emphysema, usually secondary to trauma or secondary to chest tube insertion. So sometimes we see it in ICU setting or in trauma settings. So this is an example of subcutaneous emphysema. Pneumothorax, a very important entity. And what we see in pneumothorax, of course, lung is also air-filled structure, and pneumothorax is also a pneumophile abnormality. So sometimes the difference is not that obvious. So we have to look carefully. What we see, we can see a very thin outline of the lung, because when the pneumothorax collects, it pushes the lung medially, and we can see a very thin margin. And if we pay attention to the pulmonary vessels, these vessels don't cross this line, and they don't cross and go into this area of pneumothorax, because this is the margin of the lung. So that is how we can comment on the pneumothorax. And of course, if the pneumothorax is very large, it can cause collapse of the entire lung, depression of the diaphragm, and may produce a tension pneumothorax kind of picture. But as you know, that when we have the supine film, these findings on which are very simple to interpret on erect film, they are very difficult to interpret on a supine film, because on the supine film, the air collects anteriorly. The air does not collect laterally and pushes the lung medially. Here, rather than collecting laterally, the air collects anteriorly, and posteriorly we have an inflated lung. So the vascular markings are seen through this area of increased lucency. Like in this case, the only finding is that there is increased lucency over the right lung compared to the left lung, and we can see these pulmonary vascular markings, because here the air is collected only anteriorly. So there are some subtle signs to detect pneumothorax on supine film. Of course, nowadays people have learned doing ultrasound on the chest, and they can make out the difference between a normal lung and pneumothorax. But some of the important findings are, one I have mentioned is the increased lucency of the involved site. And we can also see there is a deep sulcus sign, that is the costophrenic angles appears quite deep on the affected site. There is increased sharpness of the diaphragm and the lung, and sometimes you might have a double diaphragm sign because the anterior costophrenic sulcus may be visible, or the right diaphragm may be depressed somewhat. So these are the subtle signs, and the diagnosis of pneumothorax on a supine film is not that straightforward. So it's important to have a high degree of suspicion in these cases. Now, similar to the air, sometimes pleural fluid collects in the pleural cavity, like in cases of pleural effusion or in cases of empyema. And once we have like 200 ml of fluid, then only the CP angle blunting is appreciated on a PA or AP film. If the amount of fluid is like 50 to 100 ml, it's very difficult to detect on chest X-ray. However, ultrasound can detect them easily. But to detect pleural effusion on a chest X-ray, at least 200 ml of fluid is required on a PA or AP film. Then only it will produce blunting of the CP angle. So the acuteness of the CP angle is lost here. However, as the fluid increases in amount, it produces opacity. Like in this case, we have increased density over the left lower zone, and this margin of the fluid, as it merges with the lateral chest wall, it forms a meniscus or a rounded shape rather than a totally horizontal shape. So this is a appearance of the pleural effusion on a erect film. Now again, on the supine film, if we have effusion, it does not produces opacity like that of the erect film. Here again, what we see, there is increased haziness over the middle and lower zone on the both lungs, and there is no like increased opacity in one area and meniscus formation. So supine film are really difficult, and here the pleural effusion will layer down on the posterior part of the lung, behind the lung, rather than collecting in one area, and only the only sign will be a slight increase in haziness on the chest X-ray. Sometimes this effusion may be loculated, like in cases of empyema and loculated effusion, and they will be producing opacity, which are pleural-based opacities or the chest wall-based opacities, and they can also be seen. Now coming to the collapse. Collapse is a very important entity, and if you are not familiar with it, they are difficult to diagnose. What happens once the lung is collapsed? It occupies a very small place. Like in this example, you see the entire right upper lobe has collapsed and there is only a small opacity in the right upper zone, which is based towards the mediastinum, and rest of the hemithorax is filled by the other lobe. So the other lobe develops compensatory overinflation, and it fills up the rest of the space. So actually the collapsed lung just occupies a very small place. So it does not produces a big opacity. Okay. Like in this case, this is an example of right upper lobe collapse. Here, there is a wheel-like or wedge-shaped opacity which are overlapping with the heart. So behind the heart, we have a triangular opacity, and this is the collapsed left lower lobe. The entire left lower lobe has collapsed and occupies a very small space, and rest of the hemithorax is filled by the overexpansion of the left upper lobe. So this is a collapse of the. So in individual lobar collapse, generally you will not appreciate that much mediastinal shift. So until unless like there are more than one lobes are affected on the same side, you won't appreciate mediastinal shift and marked increase in opacity. Now coming to the consolidation. So in opposite to collapse, in collapse the lung loses volume. In lobar consolidation, the lung retains its volume and the alveolar spaces are filled by some material like fluid or pus cells or blood or tumor cells. So in consolidation, the lung volume is maintained. The alveolar spaces are filled by fluid, exudates, blood, tumor cells, and they will produce opacity. So in this case, what we see, there is an increased opacity in the right upper zone. So this is a consolidation of the right upper lobe because right upper lobe occupies most of the lung in this portion. In addition, you might also see air bronchogram. So what happens, although the alveolar spaces are filled by some material, the airways may be patent. There may be air in the airways which might produce linear lucencies. So these linear lucencies, like in this case, we see a lucent linear marking. These are called air bronchograms. So air bronchograms are sometimes seen in cases of consolidation. And again, consolidation may be lobar, means it might occupy one lobe, or in some time the consolidation may be patchy. It might be involving both lungs in a patchy fashion rather than a lobar fashion. And in this case, what we see, there are multiple small patches of increased opacity, and although we can say them nodule, but the outer margins are not well defined. They are very fluffy kind of opacities, and in some places these opacities, they coalesce, means they join each other and they form a bigger opacity. And this is a kind of this pattern of consolidation we label as alveolar infiltrates, and it can be seen in cases of bronchopneumonia and some of the other entities also. So consolidation is not always lobar, it can be in a form of alveolar infiltrates as well. So as I mentioned that the cause may be inflammatory exudate, blood, aspiration of the gastric content, water in case of pulmonary edema, proteinaceous material in case of ARDS, and rarely tumor cells also. So there are many causes of consolidation, and you should not think that consolidation is always because of the infection. Infection is of course the most common cause of consolidation, but non-resolving consolidations which are persisting for long, you should also consider other things. Sometimes even malignancies can appear as consolidation. Now coming to the interstitial infiltrates. So what are the interstitial infiltrates? Generally we have two kinds of interstitial infiltrates. One is the reticular opacities. The first example I have shown, where we have, I think the second slide. So we have this multiple linear opacities. So they are formed by the thickening of this our interlobular septa and this interstitium, and they produce lot of crisscross lines, mostly seen in case of interstitial lung disease. And sometime we can also have nodules superimposed over these reticular opacity, and then we call it as reticulonodular opacity. Okay. The causes are like in sarcoidosis, we have both nodules as well as linear opacities. Like in case of lymphangitis and sarcoidosis, silicosis, we have a combination of nodules and interstitial markings. So then we call them as reticulonodular opacities. In this example, we have some nodules and some reticular markings, and this is an example of reticulonodular opacities. Now, another abnormality, sometimes we have these rounded areas of opacities, and if they are smaller than 3 centimeter, we call them as nodules. If they are larger than 3 centimeter in size, we call them as masses. So there are many causes of these opacities, nodules and masses, ranging from benign tumor, benign entities to malignancies. So I'll not be able to go into the detail of the causes of these nodules and masses, but some of these nodules and masses, they may cavitate. The internal part of this opacity may liquefy, and you can cough out this material, and only the wall of then it forms a cavity, and only the wall is opaque. Like in this case, only the wall is opaque. The internal part has become lucent. So we have this abnormality also, like cavity, nodule, and masses. Now coming to the pulmonary edema, again in pulmonary edema, there are many causes, and not all things you will see in a single patient. This X-ray is an example of acute pulmonary edema. This pulmonary edema has developed over a short period of time. So we see a lot of these patchy opacities in the perihilar region, or in the central part of the lung. Whereas other findings, what we see more commonly in pulmonary edema is the prominence of upper lobe veins. So these pulmonary vessels, pulmonary veins, which are supplying the upper lobe, they become prominent, which we also call this finding as cephalization. There can be lot of lines which are curly A and curly B lines. So curly B lines are multiple horizontal lines which are due to congestion of the lymphatics. I'll be showing you some example of curly B lines, and this wall of the bronchi, they also appear thickened, which are called peribronchial cuffing. And you can also have pleural effusion and lung opacities, like one florid example I have shown you in this case, but you won't find similar picture in all cases. Very rarely you will have this kind of perihilar opacity in case of pulmonary edema. Mostly you will have this cephalization and this crisscross lines, curly B lines. So these are curly B lines. You can see small horizontal lines touching the lateral chest wall. These are due to congestion of the lymphatics. These are curly B lines, and the wall of the bronchi may appear thickened. This is called peribronchial cuffing. So these findings you may also see. Now coming to the ARDS. So ARDS also produces consolidation by filling of the alveoli by proteinaceous material, but there is a pattern of appearance of these opacities, and there is a typical setting. These patients are sick ICU patients, and there are many causes of ARDS, but these opacities start developing gradually. So initially you will have some patchy areas of the increased opacity, and over a period of time, most of the lung will be white out. So this is a typical pattern of the ARDS, and there is a progression of the ARDS depending on which phase of the ARDS you are dealing with. Like in this case, you have bilateral lungs almost white out. Now coming to the some of the causes of hilar enlargement. So we can have unilateral hilar enlargement or bilateral hilar enlargement. Most common cause of unilateral hilar enlargement is a neoplasm, sometimes because of the tuberculosis also. Sarcoidosis classically produces bilateral hilar enlargement. Very rarely it can produce unilateral hilar enlargement. Other causes of bilateral hilar enlargement are lymphoma, again because of the lymphadenopathy. Sometimes if the film is not taken in proper inspiration or the film is expiratory, again the hyla appear prominent, and hyla may also appear prominent in case of pulmonary hypertension. So these are some of the causes of bilateral hilar adenopathy. Now coming to the lines and monitoring, as you people are dealing with a lot of sick patients, and there are a lot of devices which are put in these patients like chest tube, endotracheal tube, Ryle's tube, tracheostomy tube. So in addition to seeing the abnormalities, it is also a good idea to check at the position of these lines and monitoring devices. So what happened in this case, the X-ray is not very clear, but let me explain. The endotracheal tube has been inserted too far and it is going into the right bronchi. So what's happening? Only the right lung is aerated. The air is not entering into the left lung, and the left lung is totally sort of collapsed and white out. So the endotracheal tube should be 2 to 5 centimeter above the carina, or in the neonates it should be at the level of the clavicles. Similarly, tracheostomy tubes should also be 3 to 5 centimeter above the carina. Like in this case, this is the tracheostomy tube, this is the lower end of the tracheostomy tube, this is the carina. So it should be 2 to 5 centimeter above the carina. It should not be going too much deep, too much down. Nasogastric tube, it's very important to verify the position of the nasogastric tube, because many times we give feed through this tube, and if the tube is in incorrect position, then the patient might aspirate. So the nasogastric tube should be properly in the stomach. It should not be in the airway, or it should not be in the upper esophagus. Like in this example, the tip of the tube, it is going towards the right side. So there's no way esophagus does not courses in this way. Esophagus goes straight down, and before joining the G junction, it turns to the left and then joins the stomach, and then you have the stomach fundus. So the Ryle's tube should come straight overlying the vertebra, then it should turn to the left side and should be lying in the stomach somewhere here. It should not be going on the right side. Central catheters, I think you people must be knowing better where it should be. Some of the examples which I have, I'll be showing, but I don't know that much. There are so many types of central catheters nowadays being used. But this is a central line. So normally it should be kept at the junction of SVC with the right atrium. So it should be in the SVC at the level of the carina. It should not be too much into the heart, neither it should be too much high up. So it should be almost at the margin of the SVC with the right atrium, approximately at the level of the carina. So I'll be summarizing my talk. I have covered some of the very basic aspects of how we interpret the X-ray, how we take the X-ray, what are the fallacies of the X-rays in ICU patients, what are the difficulties of recognizing pneumothorax and pleural effusion in supine film, and there are many different kind of opacities, so we should be familiar how consolidation looks like, how atelectasis looks like, how reticular marking should be looks like, how miliary opacity should look like, what are different types of nodules and masses, and what is the appearance of pneumothorax, pleural effusion. So these are the common things, and we should obviously review it. So to summarize, chest radiograph is an important tool in managing critically ill patient. And although a limited information is obtained, but it is still a good quick test to detect abnormality. And sometimes CT, of course, gives us a lot of information, but we can't get the patient down to the CT every time, and there is an associated radiation exposure. So X-rays are, at least, even if not fully diagnostic, they can be very helpful in following these patients. And we should try to identify the pattern of abnormalities which I have mentioned, So if we know the pattern, then we can give a differential diagnosis. Like if there is a consolidation, then we know that this may be infection, this may be aspiration, this may be ARDS. So there are some important causes we can narrow down our differential. So thank you very much. If there are any questions, I'll be happy to answer that. Thank you very much.
वेट कर सकते हैं 2 मिनट
I'll wait. ये चोटी सर का फोन था, बात कर लूँ.
मैंने कहा भी लेक्चर ले रहा हूँ 3 बजे का
चलो बोल दिया था.
So we are open for questions. I think very well explained by Dr. Jafar, because he has shown us also in X-ray the markings. Otherwise, it's very difficult in a not a bad quality X-ray to. But now we can understand different structure and correlate them. And we will send also the PPT after the course. So if anybody has right now questions, most welcome.
I think it's difficult unless somebody has prepared it. ठीक है सर.
चलो,
Okay, boss. Thank you again.
Thank you, boss. Thank you, Dr. Jafar. Thanks a lot for your precious time. And now we can, if we don't have questions, we can go for next session. I request Dr. Devin Gupta को बना दो co-host. Yeah. Next session is by Professor Devin Gupta. He will speak on pulmonary function test. After the chest X-ray, how the chest can be interpreted physiologically. After the anatomical consideration of chest X-ray, we can go to for physiological consideration. And we have chairperson, my dear friend. Yeah, sir, you are visible. You can share your slide, sir.
Yeah, okay. I'm audible also?
Yeah, you're audible.
Hello.
We can see you, but right, yes, sir. Please share your slides. You are audible. Okay, slide is also visual. So, sir, you have 10 minutes extra in this because we have earlier 1 hour, but now 1 hour, 10 minutes you can take. The chairperson for this session, I like to introduce Dr. Sumit Kumar, who is Associate Professor, Department of Anesthesia at RML Institute of Medical Sciences, and Dr. Suraj Chaudhary, who is also working as Associate Professor, Department of Anesthesia at RML Institute of Medical Sciences. And I would like to introduce Dr. Devin Gupta, who is a professor in Department of Anesthesiology at SGPGI Lucknow, and special interest in neuroanesthesia. And he is a very good teacher. Even he is my teacher. He has taught me in PDCC, and we are very good relation. Whenever even we are fighting together since our student or teacher time, and also we fight together till now after so many years of working together. So hope, sir, never mind all this because this all is professional. So it's over to you, sir.
Good afternoon, everyone. Thank you, Dr. Sandeep Sahu. And I really appreciate his wonderful effort to continue this PG assembly program, which is actually very useful to the students who are going for the exam, especially the MD students. And this is also attended by so many, the second year and first year also. And this is some consolidation of their knowledge and the aptitude towards the anesthesia. So he has given me the responsibility to teach you the pulmonary function test. Just to tell you about this pulmonary function test. Unfortunately, it has never been discussed or taught very thoroughly during our MD courses. I just remember that during my MD courses, it has never been taught to us. Okay. And just to share you this topic, I came to know when I have become a assistant professor in SGPGI, and the pulmonary function test lab has been given me for some time, for 2 to 3 years, and I didn't know about anything about this pulmonary function lab. And then during these 2 to 3 years, I just read thoroughly about this pulmonary function test, and at that particular moment I thought that why not to make some presentation so that I can reciprocate this thing, deliver to to our MD students or our juniors. So I am dealing with the pulmonary function test today. So I have divided my topic into the indications, basic test, mainly the recognition of pulmonary function test and the severity of the disease, and finally interpretation, and something in very short, how to answer the PFT questions. Just to tell you about the PFT questions, the PFT is not only important as far as practical point of view, but during the theory exam, there is a lot of short notes are there, like a dynamic pulmonary function test, diffusion test, how to interpretation of the pulmonary diseases, preoperative evaluation of the patient as far as pulmonary function test is concerned. And in the practical exam, there is a lot of spots are being given to the students and ask them to identify the loops. What is the diagnosis of this loop? So I will try to cover most of these things so that you will not have any problem in answering these type of questions about the pulmonary function test. So practically speaking, nowadays we have a lot variety of the patients, in starting from obese patients, the malnourished patients, the COPD patients, the smokers, the chronic liver disease patients, bronchial asthma patients. Most of them are having some kind of the pulmonary dysfunctions. What we have when we go for the preoperative evaluation or during the PAC, we do have only the X-ray chest for the pulmonary evaluation during the PAC. But for just to remind you that the X-ray chest is a very bad assessment as far as the pulmonary function is concerned. As far as the pathological lesion is concerned, X-ray can tell you, but most of the time we get the normal X-ray, but they're having a gross pulmonary dysfunctions in the patients. So what is the ideal pulmonary function test? The ideal pulmonary function test should be objective. That means it should be given in the numbers, and it should be standardized. That means if it's done in the one place or one lab, the same should be reciprocated, or same should be in a other lab also. So it provides the objective and standardized measurement for assessment of the presence and the severity of respiratory dysfunctions. So whatever the test we do, it should be same in the different labs, and it should be same with the person who are doing it in the same patients. So this is actually the definition of the pulmonary function test. What is the goal of doing the pulmonary function test? First of all, the goal of doing the pulmonary function test is to assessment of the functional nature of the disease. Then how much the severe disease is and the progression of the disease. That means progression means that if you do the pulmonary function test today, and if you think that this patient is having an obstructive lesion, you give the bronchodilator therapy, and after some time of giving this by bronchodilator therapy, you repeat this test and you see whether the pulmonary function test is the same or it has improved, and then response to treatment is the same thing. just identify who are the patients who is at the high risk during the intraoperative and perioperative course. And with this clue, we can actually prognosticate the patients and their relatives about the pulmonary function test is concerned. Am I audible again? Hello? Hello? Sandeep? Hello, Sandeep, am I audible?
सर आपको आवाज आ रही?
Hello, Sandeep, am I audible?
Yes, you are audible, sir.
Okay.
Okay.
So, okay. Okay. So, what are the indication for this pulmonary function test? Doing the pulmonary function test perioperatively. So, this guideline was published in 2006 in the Annal of Internal Medicine by the American Association of Physicians, and they divide doing the pulmonary function test into 3 main categories. And you just remember it also. If somebody asks you or examiner asks you what is the indication of the pulmonary function test, you can very easily say that pulmonary function indication of the pulmonary function test can be divided into 3 parts. One is the patient-related risk factors, other is procedure-related risk factors, and third is when the patient's serum albumin is less than 3.5 or 35 gram per liter. And as far as patient-related risk factors, those patients who are having a COPD, number the old age patient, like the patient are having a more than 60 year of age, the SA grade 2 or more, functional dependent patient. That means that if the patients are dependent of for their routine activity on others, then they are functionally dependent. Suppose they need some help for their routine activities, then these are the functionally dependent patients, and the patient with the CHF. So this is the patient related risk factor. Procedure related risk factor, that means if the surgery is more than 3 hours, or we can say there is more the prolonged surgeries, abdominal surgeries, especially upper abdominal surgeries, in all cases of thoracic surgeries, whether it is a sternotomy or it is thoracotomy. The neurosurgery, especially the cervical spine surgeries, head and neck surgeries, vascular surgeries, aortic aneurysm surgeries, because this is one of the most complicated surgeries as far as surgery is concerned, and many of the emergency surgery, which is, I mean, in patients with who are having a low albumin, like the patient with a chronic liver disease, or other kind of the chronic patients who are having a persistent low albumin level, should be also subjected for the pulmonary function test before the surgery. And we should find out whether the patient is having a gross pulmonary dysfunctions or mild or moderate pulmonary dysfunctions. Based upon this, we can prognosticate. And uncharacteristic pulmonary disease, that means if the pulmonary PFT has been done in some of the known pulmonary disease patients, and it is the duration of this last pulmonary function test is more than 60 days, then we have to repeat it so that we can know about exact nature of the disease at this particular time. Again, this has emphasized very clearly that pre-operative spirometry, simple spirometry, and chest radiograph should not be used as a routine for the predicting the risk for the post-operative pulmonary dysfunctions. So this is, I mean, again, is emphasizing that X-ray test is not for the assessing the predicting the post-operative pulmonary complications. This can only tell you about the pathological lesion in the parenchyma, not as a function. So what are the contraindications? Contraindications just if the patient is having a recent eye surgeries, recent thoracoabdominal surgeries, or having a painful scar, thoracic or abdominal or recent aneurysm surgeries, active hemoptysis, pneumothorax, unstable angina, and recent MI within a 1 month period of time. And if we have to do this kind of the test and this kind of the patients, then we have to take uh, a proper clearance from the physician for doing this test in this particular kind of the patients. So grossly speaking, the pulmonary function tests are divided into two parts. One is a bedside test, or other is laboratory test. Bedside test is normally when we go for the PAC in the ward or in the PAC clinic, we do a bedside test. These are the rough gross test we can do on the bedside without using any big tools, and we can roughly assess whether the patients are having a pulmonary dysfunctions or not. Another are the laboratory tests. So these are the gold standard test. Here in the laboratory, like many of the institute or medical college or hospitals are having a pulmonary function test per se. So these tests has been done in the pulmonary function lab, and it has a special machine on which these tests has been done, and these muscles are universally standardized so that this the test value should be the as standard as in all labs. So just and as a brief, there is a battery of tests, 8 or 9 tests are there, or for the best bedside test is concerned, and the laboratory tests are the few 3 tests, basically mechanical ventilation function of the lung, residual volume, diffusion capacities. So these are the 3 tests which are the standard test and which has been done in the lab person. So there is a so many battery of the test. Just for a moment. ये बंद कर दीजिए, बंद कर दो भाई। Sandeep, am I audible? Sorry, I'm in some place where routine activities are going on. So again comes to the same. There is a battery of the test as far as bedside test is concerned, and there are 3 standard tests in the laboratories. So first bedside tests are what we call as a breath holding time or breath holding test. It is devised by Sabra Says in 1902. And this is just, we all know, we all routinely do that. We ask the patient to take a deep breath and ask him to hold as long as possible. And if patient can hold more than 25 seconds, we call it as a normal cardiopulmonary reserve of the patients. And if this breath holding is less than 15 seconds, we call it as a poor cardiopulmonary reserve of the patients. And we have to think twice before taking this kind of the patients for the operation. And single breath count, this is a we ask the patient to take a deep breath and just count 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. And if this counting is more than 30 to 40 counts, then patient are having a good vital capacity. Other bedside test, which whistle test, right spirometry, these are the obsolete tests. Now, two tests I just uh, want to brief it. That incentive spirometry, you can see very well in hospital, in the ward. So many preoperative patients are doing the incentive spirometry. You can, if you ask the patients that to take do this incentive spirometry, the patient is able to lift all three balls. That means the patient's respiratory functions are very good. And if he's may not be able to do lift one ball, that means his pulmonary function are not very good. As far as ABG and pulse oximetry is concerned, so ABG, for the ABG, in many the patients who are having a known pulmonary dysfunction, that means we know that this patient is having some kind of pulmonary dysfunctions. Okay, and we have to take these patients. So what we do the ABG on room air preoperatively in the ward. We take a ABG sample on the room air and want to see what PO2 and PCO2 level are there at preoperatively when the patient are comfortably sitting on the room air. So this will actually guide us when the patient after the surgeries are on the ventilator or at just about to extubate, and this PO2 and PCO2 is a guide that this is on this parameter we have to extubate the patient. Just for example, one patient who are having a COPD or some kind of respiratory dysfunctions are having a PO2 is 50 at room air preoperatively, and the PCO2 is around 55 at room air. This is his normal values. So when we want to extubate this patient post-operatively, when this is on ventilator, we should not try to achieve PO2 more than 200 or PCO2 less than 45. So this is the guide in those patients who are having a preoperative pulmonary dysfunctions. So this will give us a rough value that at this PO2 and PCO2 we have to extubate the patient post-operatively. Now comes to the pulmonary function test. This is the main topic. So there is when we go the pulmonary function lab, there's a three kind of the tests they do. One is the mechanical test of the lung function with what is called as a spirometry. I will tell you there is a two kind of the spirometry. Then another is residual volume, and third is diffusion capacity. So these are the three tests. So comes to spirometry. Spirometry is actually devised by the John Hutchison in 2002, and there is a two test. One is static lung volume and capacities, and another is a dynamic lung volume and capacity. We can understand this static lung volume and dynamic lung volume in the way that when we do the ABG, when the patient is lying supine normally, this is some kind of the static lung volume. Patient is not doing anything but taking a normal breath and deep breath normally. Dynamic lung volume test is just like taking ABG when the patient is doing the treadmill. So it will give you the dynamic ECG of the patients or dynamic function of the patients. So the dynamic lung volume is the same kind as a treadmill type, or it is not exactly treadmill, but it is a giving a that kind of the functional lung volumes. So simple spirometry, this is one of the picture from our lab. This is our technician with it. And one patient is sitting who has a pinch on his nose, and he's taking a mouthpiece on his mouth. And when he asked to do taking a normal breath and take a deep breath, all this, the graph has been drawn by the computer on the screen, and later it is given in the printing. And there is these values have been written on the measured by the machine and are written on the computer and are given as a report. So this is a static lung volume. So static lung volume is nothing but it is a screening type of test. Just to remember that when patient goes to the lab and simply they ask that take a normal breath. So it is a normal tidal volume. Take a normal deep breath. Then this is a inspiratory capacity or inspiratory reserve volume. Then expire as much as you can. And this inspiratory lung volume, inspiratory reserve volume, the tidal volume and the expiratory reserve volume is total called as the vital capacities. Since with this spirometer or we can't measure the residual volume, so functional residual capacity and total capacities cannot be measured. So it will only give the tidal volume, inspiratory reserve volume and inspiratory capacity when we add with the tidal volume and the expiratory reserve volume. Just to remind you, this is a screening test. When we do the first test we do in the pulmonary function lab is the normal spirometry. These are the some values based upon the height, weight, gender, and race. So what we do, we registered the patient's data like patient's age, weight, height, and race and gender in the patient's, this PFT computer, and it gives the predicted values based upon this height, weight, and gender. This is the normal predicted value or normal values which patients should be do. And when the patients do its test, there are actual values. And on the side of this test, it gives the ratio between the actual values to predicted value in the form of the percentage values. So we can say the FEV1 of this patient is 65% of the predicted value. That means his test is 65% of the predicted value. That means he can only perform 65% of the, if we can, the ideal values as far as the weight and height and gender is concerned. So this is, now we comes to this slide. This is actually my perception of understanding the pulmonary function test. So this is a lung which I have shown on the left side of the slide. This is a lung, and there is a two part in the lung. One is the airway and one is the lung parenchyma as such. So here I this diagram I made it by myself, and just think about myself so that we can understand the pulmonary function test in better way. So here you can say this is a normal glass, so that this is a just normal lung, and there is a straw. I made the straw in the form of the trachea and bronchus. So here we can say there is we can think that this is a normal caliber of straw. So this is a normal size of straw. So this is if we whole glass water is the total lung capacities, right? The part which can be sucked fully, it is a vital capacities. The remaining amount is a residual volume, which remain after when we suck whole of the water from by our effort. So this volume will still there in the glass. Then we have two diseases. Normally in pulmonary function tests, we try to identify two main subset of the disease. One is restrictive lung disease and another is obstructive lung disease. In restrictive lung disease, why we want to know the restrictive lung disease and obstructive lung disease? We want to know because in restrictive lung disease, there is no chance for the optimization. Whereas in obstructive lung disease, there is always a chance for optimization. So that means if you find out one patient with obstructive lung disease in the PFT, you can give him bronchodilator, you can ask him to do the normal brain exercises, stimulation to clear his secretions, and you can very well optimize this kind of the patients of obstructive lung disease. One is restrictive lung disease, you can't optimize the restricted lung disease by anemia. So you have to take this patient as such. So that means you cannot say no, but you have to tell the patients that this is pulmonary dysfunction, and if we have to take you for this kind of the surgery, this is the risk, and this is a prognostication as far as you is concerned. But if you find the obstructive lung disease, you can send this patient for the physician or pulmonologist to ask him to optimize for certain period of 1 week or so, and send him back. So that if the surgery is not emergency surgeries, then after 1 week and so, you will get a better patient as far as obstructive lung disease is concerned. So that is why we want to know whether the patient is having a restrictive lung disease or obstructive lung disease. So what is the difference in the obstructive lung disease and restrictive lung disease? Here we can see the straw size. That means airway and restrictive lung disease are as normal, as wide as a normal airway, whereas the glass sizes are smaller than the normal glass. That means the volumes are less, but there is no obstruction in the airways concern. Whereas the obstructive lung disease, we can see the lower airway. There is an obstruction in the lower airway. The volume may be normal or volume may be higher, because there will be some trapping because of this obstruction. So you will always find that total lung capacities and the residual volume is higher in obstructive lung disease. So this is a major difference. I can give you this as a comparison. This is a normal lung. This is a restricted lung with this normal caliber of straw and the small size of the glass. Whereas the obstructive lung disease, the glass size may be normal, or maybe normally it is wide, but the straw has some obstruction in the lower airway. So with perception, we want to tell you what is exactly how the pulmonary function test should be interpreted. So when we normally do the static spirometry, we get graph like this. This is the tidal volume. This is a inspiratory capacity, the inspiratory reserve volume. This is expiratory reserve volume. So there's so many graphs, but here by this graph we can't make out what is obstructive lung disease, what is restrictive lung disease. So that is why the simple static spirometry is only the screening test, not the test to diagnose. So what is the test to diagnose? What I told you earlier, this is a dynamic lung test, dynamic lung volume. So what is a dynamic lung volume? In this dynamic lung volume, the patient's breathing is not done by like static lung volume, like normal take normal volume and take a inspiratory volume and then expire normally. But here what we do, we ask the patient or the subject to inhale maximally and forcefully expired within 6 seconds to the last of its residual volume. Just I will show you the example in one of my lab. So why is this not there in this? I don't know why. So what is this? Our technician is asking him to take a deep breath, take a normal breath, take it, कस के सांस लीजिए, कस के सांस लीजिए, कस के जोर से छोड़िए. Now he is taking a जोर से छोड़िए, पूरा जोर से छोड़िए. So we can see there's a loop is forming here. So you can see me, like if somebody asks me to take a deep breath, I will say normal breath लीजिए. फिर वो technician will ask me take a deep breath, जोर से छोड़िए. So what will happen? So what will happen here? What will happen here? When we take a deep breath, it will take my whole of the lung will inflate it, and when we expire, so my this flow will depend whether what will be the caliber size. What is the caliber size of our airway? If the caliber size of the airway is very small, then the flow will be less, and if the caliber of my lung is or airway is good, then the flow is in very good pattern. Secondly, if my lung volume is smaller, the forced vital capacities will be less. And if my lung are not stiff or good compliant, then there is a good the forced vital capacities. So there is a two type of the measurement which take basically the force vital capacities, that is mainly lung volumes, and the force expected volume in the 1 second. What it denote the flows, whether it is going through the small caliber pipe or it is going through the wide caliber pipe. So there is a 4-5 values out there. Force vital capacities, what is the total your how compliant your lung is. Second, force expected volume in the 1 second. That means how much you can expire the within 1 second of your total vital capacities. That means if your airway caliber is very wide, then you can expire most of your tidal volume within 1 second. And but if your caliber is small, I mean the narrower, your airway is obstructed, you cannot expire much much amount of your the vital capacities within 1 second. Then the ratio will tell you whether obstruction is there. And peak expected flow rate, I will tell you the importance of this. Force expected flow in within 25 to 75 seconds, that is a mid flow. Mid flow is basically the flow which is coming from the lower airway, and this will tell you whether the obstruction is there or not. So I will explain you in few slides what are these values. So when we perform this test, there's a two graph are made in the computer, and one is classical spirogram, which is volume versus time, and another is flow volume curve. So first diagram, there's a time which is almost 6 seconds. Within 6 seconds, patient has forcefully expired his whole of the volume. So that means this is a volume. So within a initial first 1 or 1.5 seconds, patient tried to expire most of the started volume. So we can see out of 6 liter, he expired almost 3 liter or 4 liter almost in within a 2 seconds. And rest of the volume is going very slowly later part. So that means his graph is like this. Okay. So initially this graph is much steeper, and later there is a plateau form. So initially the large volume is expired within 1 or 2 seconds, and then gradually the flow is the rest of the air will go slowly. This is a flow volume curve. This is a flow volume curve. This is a flow which is on the x-axis and the volume in the y-axis. So what happened? We can start from this point. Here, patient is asked to inhale properly, fully. So patients try to inhale. So lung volume is increased. The flow is increased inside the lung and the negative side of the graph. And here we ask the patient, kas ke chhodiye. So he expired fully and forcefully. So he expired. Initially, the flow is very, very high. So flow is suddenly become high and gradually. So the flow become lesser and lesser. So in this form, the graph is formed. Here we can see this is a force vital capacities. This is a total volume which can generate the patient, which patient can generate by his effort. This is the peak flow, the maximum flow which he can generate, and this is the most important flow. This is a 75 and 25%. That means the mid part of your patient's, the expiratory part is the part which is coming from the lower airway, or there's a lower airway, which determine whether obstructive lesion is there or not. Okay, so this graph, both graph tell you about the obstructive lesion or restrictive lesion. Okay, so here there is some values. The force vital capacities, we can see the force vital capacities like this. This is a force vital capacities, and these are the single values which can tell you the if force vital capacity is 80 to 120, it is normal. This is the mild reduction, moderate reduction, and severe reduction. Here the force expiratory volume in the 1 second, if it is 75%, then normal, then mild obstruction, moderate obstruction. But these two values, single value has no importance. So what it does, what we do, that force expiratory volume in 1 second oblique force vital capacities. That means how much part of the force vital capacities has been expired in 1 second. That means if the airways are normal, then you can expire most of your vital capacities within 1 second. If the airways narrow, that means you may not be expired much of your vital capacities in the 1 seconds. So this is FEV1 versus FVC ratio, which tell you if the 70 to 75% is normal, and if it is less than 70%, we can say it is abnormal or there is an obstruction. Right. Here's the force expiratory flow between 25 to 75. So I tell you that this is whole of the expression. So between 75 to 25, this is a part from where the lower airway, from where the air is coming, and if this flow is decreased, that means there is obstruction in the lower airway. So this has some value. I will try to clear you in the next few slides. So this is a peak expiratory flow. This is also in the volume time curve. We take a tangential of this steeper part and we get the peak expiratory flow rate. What the peak expiratory flow rate mean? Peak expiratory flow is generated by, depend on the caliber of your airway, number one. What is the strength of your expiratory muscles, and what is the coordination and effort of the patients. We always see this peak expiratory flow rate in our pulmonary function test, because this will tell you how the patient will cough in the post-operative period and clear his secretions. If the peak expiratory flow rate is lesser than 40%, in post-operative period, patient may not be able to cough properly and may not clear the secretions clearly, or clear his secretions, and there will be more chances of atelectasis, and there will be more chances of post-op pulmonary dysfunctions. So interpretation. So when we get all these values, we try to see whether by static lung volume, whether the patient is perform test or not. If the patient is not able to perform the static lung volume, we call this the poor, and we will not interpret any of the dynamic lung test. If the patient is able to perform the static lung test, and then we subject this patient for the dynamic lung test, then we first take the value of FEV1 versus FVC ratio. That means how much of vital capacities, force vital capacities has been expired within 1 second. So if there is no obstruction, then been maximally more than 70 to 75% of this vital capacities has been expired in 1 second. So if it is normal, then more than 75% is there, then it is a normal value, or there may be a high value. So FEV1 versus FVC ratio is low, then we can say there is some obstruction is there. But if it is normal, we can't say this. We can only say this is no obstruction. I just remember the glasses. So in the normal glasses, the straw is normal. So straw is normal in normal glass as well as in restrictive lung disease also. So the straw is normal in the normal lung as well as restrictive lung disease, but straw size is less in the obstructive lung disease. So whenever FEV1 versus FVC ratio is less than 75%, we can say there is an obstruction. If it is normal or more, we can say there is no obstruction. So depending upon what is the percentage of FEV1 versus FVC ratio, if it is less than 50, it is a very severe kind of the obstructive lesion. If it is less than 65, it is a moderate kind. And if it is more than 65 but less than 70%, it is a mild obstructive lung disease is there. As far as this part is concerned, normal or restrictive lung disease, then we have to see what is the force vital capacities. If force vital capacity is normal and FEV1 versus, we have just know that FEV1 versus FVC ratios normal or high, and FVC ratio is also normal, that means the patient is normal. The glass size is also normal, the straw size is also normal. If FEV1 versus FVC ratio is normal, but force vital capacities is low, that means the straw size is normal, but the glass size is lesser than the normal. So this is a restrictive lung disease. So how this we can interpret about the obstructive lung disease, restrictive lung disease, and the normal lung. By looking at the graph, how can we make there is an obstructive lung disease or restrictive lung disease? So this is the volume time graph, and this is the flow volume loop. So this is a flow volume loop. This is a graph of the obstructive lung disease. We can see whenever there is an obstruction, the graph is much steeper because the peak expiratory flow may not be generated. FEV1 versus FEV, the force expiratory volume in 1 second is much lesser than the normal values. So the graph is much steeper, but it try to touch towards the normal value. So it is steeper like this, steeper, and it is not parallel to the normal graph, and this is not looking like a normal graph, right? As far as flow volume curve is concerned, here we can see that the peak expiratory flow is lesser, but if you see the mid flow is suddenly decreased after initial flow, which is coming from the upper airway, like trachea, bronchus, but the flow which is coming from the lower airway the flow is suddenly decreased, and this part of expiratory part, mid flow part, is curve concavely very deeply than the normal. This is the reference normal curve here, and this is the patients who are doing actual curve. So this is patient actual curve, and we can see that saw like हंसी की तरह का होता है. So हंसी की तरह का होता है. So this is a much concave than the normal curve, and the shape of the this actual curve is not exactly at the patient's the ideal curve. And here also this is much steeper, but try to go and achieve to the force vital capacity. So this curve is like this, like slanted curve. So this is one of the graph I have taken a snapshot from the computer. So we can see which is much steeper like this, but try to achieve toward the force vital capacities. And the flow volume curve, we can see there is a concavity on the mid flow part. So mid flow part is suddenly decreased. The flow has suddenly decreased, and there's a concavity. This is a reference curve, and this is a patient's own curve. So this is the printout from the paper. We can see very well. This is a concavity on the lower part. This is a reference part, and this is a much concave. So this is obstructive lung disease. As far as restrictive lung disease, we know that airway size is normal. So that means the mid part is normal. Okay, and also this part is also normal. There's no steeping because the flow is normal. So the flow governed by the tangential of this. The flow is normal, but because of the less vital capacities or force vital capacities, this will not achieve up to the normal values. So there is a the graph is looked like is the same as the normal graph, but it is much lower. And at the same time, here also flow volume loop, the this actual loop is much smaller than the normal loop, but in the smaller size. You can see this is this loop is the same the shape, but is smaller in size. And this you can see that this curve is the mid part is not a concave. This is as steeper as a normal. The flow is not decreased, but the total vital capacity is decreased. So this is a restrictive. So this is one of the graph where the force vital capacity is also decreased, and there's a concavity also. So this is a mixed kind of the disease. So in many of the cases, there is a restrictive lung disease as well as obstructive lung disease. So in the obstructive lung disease, we can see this is a much steeper the volume time curve, and this bit flow is just decreased suddenly. So it is giving a concave shape, and this is not exactly as shape as a normal. In restricted lung disease, it is not going to achieve the normal volume. So force vital capacity is always low, and a flow volume curve, it looked like a normal, but size is less. In mixed part, the vital capacity is less, as well as the curve is also, the mid flow is also low. So here we can see the straw size is less, but the glass size is normal. Here straw is normal, but glass size is low, smaller. Here the straw is also narrow, as well as glass size is also small. So this is something about the obstructive lung, restrictive lung disease. Some of the spotting also has been put, like graph has been some picture has been giving, like a graph is like this. You can identify whether what kind of the disease is there. So this is obstructive lung disease, the restrictive lung disease, the mixed disease. There are some other variable disorders. So this is a variable extrathoracic upper area obstruction. What happened here? There is a tracheomalacia. The trachea is compressible. So during inspiration, it collapsed. So there is a dynamicity. So it collapsed. So we know that this part is inspiratory part. So this become blunt. But during expiration, this is open up. So there is a blunting on the inspiratory part. When there is a variable interthoracic obstruction, so there is a blunting on the expiratory part. I don't know why this is. So there is a in the mixed disorder. This is in the mixed disorder. There's a blunting in the expiratory part as well as inspiratory part. I will tell you, because I don't know what happened into this particular slide. I will tell you in the later part. So in the neuromuscular diseases, where the patient is a very poor weak because of muscular weakness, the poor performance. So it looked like the small curve like this. This is a reference curve, and this is a patient's own curve. So you can see it is rounded shape. So this is a force vital capacity is also less, though there is no obstruction. So but there's the effort is less. So it looked like a very small cavity. So I will tell you about both of the which was not shown in the last two slides. This is, we can say that this is a reference. This is a normal curve. This is obstructive lung disease. We can very well say that mid flow is decreased. So this is obstructive lung diseases. Okay. Here, this is a restricted lung disease because the size is less. The graph shape is exactly like a normal reference curve. So this is the restricted lung disease, we have shown you variable extrathoracic. So the inspiratory part is blunted. So that means during inspiration, there is a collapse. So there is a blunting. Variable extrathoracic, this is a variable extrathoracic. When the tracheomalacia is there, during inspiration, it collapses. So this is blunting of this. Variable intrathoracic, in this variable intrathoracic, what happened? There is a tracheo, the malacia and the airway in the main bronchus inside the thorax. So when patient expired, so during that time it collapses. It collapses the airway. So there is a blunting of the expiratory. So there is a variable intrathoracic obstruction. When there is a tracheal stenosis, when there is a fixed airway disorder, fixed airway obstruction. So there will be the narrowing of the airway during inspiration as well as expiration. So there is a in tracheomalacia. What happened? There is a inspiration. Also, there is a blunting. During expiration, there is also blunting. Right? This is a neuromuscular disorder patients, and this is also the restrictive lung disease patients. Okay. Fixed upper airway obstruction. This is variable intrathoracic. There is a blunting in the expiratory part. There's neuromuscular tension, variable extrathoracic obstruction, and restrictive parenchyma. Okay. Now the second part. So now till now we know that what is obstructive lung disease, what is restrictive lung disease, but we want to know what is the total lung capacities of the patients for the rest of the diagnosis. So to know about the total lung capacities, we have to identify what is the residual volume. So to know the residual volume, there is a 3 types of test has been done. One is nitrogen washout test. Another is the helium dilution test, and the total body plethysmography. So this is obsolete. The other 2 tests has been done in our lab also, in most of the lab. In helium dilution test, what happened? A certain amount, fixed concentration of the helium has been filled in the container, and patient is asked to inhale and exhale. After some time, there is the equilibrium is set up. Okay, once the equilibrium is set up, then we take a sample again from this jar and try to find out what is the total later concentration of the in this jar. So when we put this into the formula, the initial concentration and later what is this concentration. If we put in this gas law, then we can find out what is the volume of this. So because this volume is later is distributed in this, then if it is equal to types of volume, because this gas is inert gas and this is not been reabsorbed. So we can make out by the helium dilution test. Body plethysmography, this is a tight chamber in which the patient has been asked to sit, and there's a mouthpiece. The only air which comes in this chamber is through this mouthpiece. Patient is asked to inhale. When the patient is inhale, his chest is becoming larger, and there is a change in the pressure of this chamber, just like this. When the patient is inhale, the pressure in this chamber is increased, and based upon this make a calculation like this, and this give the value like what is the total lung capacity, the residual volume and total lung capacities of the patient. Then diffusion capacities. Diffusion capacities, we take a gas which is highly diffusible. This is a carbon monoxide, and very small non-lethal amount has been given to the patients to inhale. And when the patient is take within 10 seconds and asked to exhale, so we think that if the patient's the diffusion is normal, most of the gas will be absorbed, carbon monoxide will be absorbed, and when we expire or exhale, then we take a sample and try to find out if the carbon monoxide is in very small traces, that means most of the gases is absorbed, that means this diffusion capacity is normal. If the most of the carbon monoxide has come out in exhalation, that means we can say this a patient is having a poor diffusion capacities. In this, when we interpret about the lung diffusion capacities, we also interpret in the two ways, that diffusion capacities is decrease in the disproportionate to total lung capacities or in proportion to total lung capacity. In many of the cases, there is only one lung, and when or pneumonectomy is there or kyphosis is there, so there is always the total lung capacity is always restricted. So if the diffusion capacities and total lung capacities is a one, that means the diffusion capacities decrease in proportion to total lung capacity. That means the diffusion is whatever the lung is there has a normal diffusion. But if the patient has having a good total lung capacities, but diffusion is decreased, then we say that yes, actually the diffusion is decreased. Like in COPD, interstitial lung disease, the diffusion is low. The chronic pulmonary embolism, the diffusion is low, though the total lung capacities will be okay. Now the interpretation. So interpretation, first we try to see whether the straw size is less or the straw size is normal. So here we take a FeV1 versus FVC ratio. If it is normal, we can say the straw size is normal. Then we have a two limbs. One, we try to find out what is the glass size. If the force vital capacities or total capacity is normal, then we can say the patient is normal. Okay, so here the patient is straw size is normal, glass size is normal, the patient is normal. But here also in some condition, there is some diffusion defect, like in pulmonary vascular disease, there is a diffusion. When the diffusion, here we take a diffusion. If diffusion is normal, then the patient is absolutely normal. If the diffusion in in this glass and straw size, if the diffusion is less, that means there is some pulmonary dysfunctions. Here diffusion is normal. Here everything is normal. Airway size, the glass size, yeah, or vital capacities, and the diffusion, all are normal. But here in this pulmonary vascular disease, these two are normal, but diffusion is less. In restrictive lung disease, the straw is normal, but forced vital capacity or total lung capacity is less, glass size is less. Here also there is a two limb. After confirming the restrictive lung disease, we have to do the diffusion capacities. If the diffusion capacity is normal, then we can say that this restriction is because of chest wall or neuromuscular like rigidity. But if the diffusion is low, that we can see that there is an interstitial lung disease in the patients, like where the restriction is also there, and because of the parenchyma is so stiff, there is a diffusion also bad. So here, along with the restricted lung disease, there is the poor diffusion. Why we want to know? Because we can say that this lung is much worse than this lung. This is less than the normal lung. But if you compare these two, this is having a restricted lung disease as well as a diffusion defect also. And the obstructive lung disease, when we say that FeV1 versus FVC ratio is less, then we can point out this is an obstructive lung disease. Then we go to the diffusion lung capacities. If diffusion is normal, patient may be having a bronchial asthma or chronic bronchitis. But if the diffusion is less, that means corrugation becomes less. Also, there is an emphysema. In mixed disorder, I've already told you the straw is also abnormal, the glass size is also abnormal. So this is up to what about the interpretation of pulmonary function test. Now there is some other test also, cardiopulmonary testing. Normally what we do, what we want to assess that what is the maximum oxygen consumption of the patients. Normally we accept the patient who have a maximum oxygen consumption more than 20 ml per kg per minute. And we patient will have a high risk when the patient's maximum oxygen consumption is less than 10%, 10 ml per kg per minute. But how to assess it? Just for example, the highest recorded maximum oxygen consumption is by the cyclist Armstrong, which is 85. So how we can interpret the what we call as a METs between 4 to 4.5, we just take a 12 to maximum oxygen consumption is 12 to 16. Okay. So up to 20, it is normal. So how can we say that? 6-minute walk test. This is very common test, has been done many of the places where here we ask the patient to walk for 6 minutes as rapidly as he can. And we take a distance, whatever the distance he travel, divided by 30. It will give you the maximum oxygen consumption of the patients. Suppose the patients travel in the 6 minute 450 meters. So if we divide it by 30, that means the maximum oxygen consumption is 15 ml per kg per minute. So this is a rough test. Another stair climbing test. How much flight of the stair he can climb? One flight is around 9 to 13 stairs as a standard. And if the patient can climb 2 flight of stair in one go, this is a 12 ml per kg per minute maximum oxygen consumption. And if he can climb five flight of stairs, it is at more than 20. So in summary, we have to determine what is a FeV1 versus FVC ratio first. So it will show you obstruction or restriction. Then we have to identify forced vital capacities, low or normal. Then obstructive or restrictive pattern. Then what is the grade severity of the abnormalities. Once we identify obstructive and restrictive pattern, we try to find out whether a diffusion defect is there or diffusion defect is not there. And based upon this, we have to make a differential diagnosis. And after that, we can do the simple cardiopulmonary test in the ward or in the your PAC clinic. So thank you so much.
Very nicely explained, boss. As usual, I think this is one of the unique or difficult topic, because this is not a routinely like pre-medication, intra, post-op, induction and all that, because there the things are settled. So this needed a concept, and मैं ये कहूँगा कि आपने बहुत अच्छे से उसको समझाया और लोगों को समझ में भी आया होगा. So we have one question. Please explain asthma flow volume loop and dog tail appearance in flow volume loop.
Okay, so in bronchial asthma, what happened during the normal, there is when there is a no obstruction or there is a no acute spasm. Normally you can find out the normal.
संजय अग्रवाल को बना दो भैया co-host. It's okay, boss. Up continue.
Okay, so whenever there is a bronchial asthma in active state, so in bronchial asthma active state, you know there is a obstruction of the lower airway. So you will find out the flow volume loop in the same way as I explained you. The mid flow will decrease. That means वो हंसी की तरह का होता है, इस तरह से आ जाएगा. तो वो डॉग टेल अपीयरेंस कह देंगे या हंसिया कह देंगे. But for just to remember the mid part of the flow, 75 to 25, this is curve. This is curve like this. And the if the bronchial asthma is more severe, the forced vital capacities will also decrease because of patient may not do much effort to expire most of the volume. So you will get the graph like this. So this is a dog pigtail appearance, whatever you say, but I will say that you just see the mid flow. Mid flow is like this. You give bronchodilator therapy this to this particular patient, and after some time or 1 week or so, you optimize it and you repeat this test. If this flow pattern become normal or try to become towards the normal, you can very well say this is an acute state. This was acute exacerbation of bronchial asthma. Now it is improving.
डॉक्टर संजय आ गए ना. ओके सर, आई थिंक मैं यूट्यूब पे और देख लेता हूँ कोई और क्वेश्चन हो. Anything the chairperson are here, they want to add anything? Dr. Suraj or Dr. Sumit?
No, sir. I think sir has explained very well. It is I think it is the third time I'm listening to sir. Namaste, sir.
नमस्ते नमस्ते सूरज, कैसे हैं आप?
सर ये कह रहा है कि स्ट्रॉ और ग्लास जो है बहुत देर हो गया खाली है, लेकिन सर एक और क्वेश्चन है.
Actually, yeah.
We have one more question, sir. In restrictive disease, the flow volume loop shift to the right side or not?
See, right side और left side आपका interpretation, आप अपने को interpret करना आप सीखिए पहले तो. उसका वॉल्यूम लूप में मिड फ्लो नॉर्मल होगा रिस्ट्रिक्ट लंग डिजीज में. ओके, वो शिफ्ट होगा कि नहीं होगा, आप you just don't go on this. You just see whether the loop is normal shape, mid flow is normal, size is less. This will give you whether this is a restrict pattern or not.
Yeah. So I think with these two questions, we don't have other questions, because I think you explained well. Or now it's time to say thank you to the chairpersons and Devendra Gupta boss. And because Dr. Devendra is not here in Lucknow, he is in ILBS Delhi this time. And he is there for liver transplant anesthesia. And he has taken very right, I will say that from this busy schedule, because maybe he is not free, but he given his time. Thank you, sir. Thank you so much for anything you want.
Thank you, Sandeep, for your great effort. And I always appreciate. Yesterday also I appreciated to Divya that despite all this COVID and all, this program is going on. This is a great achievement of this institute, our institute. And you,
sir, thank you. ये तो आप हम सबका combined effort है. आप लोग देखिए, फैकल्टी ना हो तो ये मैं तो बस संयोजक हूँ. तो आप लोग इतनी मेहनत कर रहे हैं और पढ़ा रहे हैं. Thank you, sir. Thank you so much.
All the best for your rest of the program. Okay, thank you.
Thank you, sir. Bye, sir. Thank you, chairperson.
Thank you. Thank you.
So now it's, thank you, Sumit, and thank you, Suraj. It's time thank you, Sumit. So now it's time to take for another session. This is a session that you get, usually we get a case of thyroid swelling, huge thyroid swelling. And I request Dr. Sanjay Agrawal to please share. You can share your slide, sir. Yeah, we are getting you. We are getting your slides also and your photo also. Boss, जरा कुछ बोलेंगे ताकि हमको पता चले आपकी voice का.
Good afternoon, Sandeep. Am I audible?
Yeah, sir. Yes, sir. So let me introduce Dr. Sanjay Agrawal. Dr. Sanjay Agrawal is a very good senior of mine, and he is a professor and head department of anesthesiology at AIIMS Rishikesh. I think one of the best department in India after the AIIMS New Delhi, any AIIMS have, because you are running DM in cardiac, neuro, and critical care. So this is also like a super specialty department you are heading and making a new department with new dimension. And Dr. Sanjay Agrawal, I know him from my residency time, 2005, when boss came to for his PDCC in neuroanesthesia, although he was already faculty at that time in Jolly Grant. And it is very difficult to come after being a faculty for again the students' times and doing all that hard work that you have done. It's really appreciable, boss. And in this session, we have 3 faculty. Another faculty is Professor Kaji Ehsan Ali sir. Professor Kaji Ehsan Ali sir is a professor and head department. We say the chairman department of anesthesiology at Jawaharlal Nehru Medical College, AMU Aligarh. And we have Professor Veena Asthana. Professor Veena Asthana madam is also professor and head department of anesthesia at HIMS Jolly Grant, Dehradun. So we have 3 head in this session. Besides this, let me introduce the chairpersons. We have Professor Suren Singh sir. Professor Suren Singh sir is a professor and head department of anesthesiology at Ira Medical College. He has been our teacher and ex-HOD at SGPGI Lucknow. And we have Professor Rupesh Kumar and Professor Anshul Jain, who is from MLB Medical College, Jhansi. So meanwhile, the chairpersons joining or there, I should hand over to Professor Sanjay Agrawal, sir, for starting a thyroid case.
Thank
Sir,
you.
you may start.
Thank you, Sandeep, for the nice introduction. And it was a nostalgic feeling. You made me go back to 2006 and the first time that we met.
On the slide. Yes, okay.
Okay. And the topic given to me is an evaluation and approach of a neck swelling. And we all know we have seen cases in a neck swelling which is being presented for examination. And invariably, we just think that this case may be a thyroid swelling. But before really coming down to the diagnosis of thyroid, there are certain things that we have to think of before labeling that swelling as a thyroid swelling. So the two main considerations that we have to do in this condition is the swelling a midline swelling or it is a lateral swelling? And depending on that, we can make a diagnosis of the type of swelling that it may be. And this is a picture of few of the swellings which are usually given to in the examination, both as a long case and a short case. So we have to, not all the swellings are thyroid swellings out here. It may be a branchial cyst, it may be a cystic hygroma, it may be an infected cyst, submandibular abscess, deep cervical abscess, lymph nodes, or thyroid swellings. So before, whenever we see these sort of a cases, for the residents, it is very important that we should know to come down to the diagnosis, we should know how to proceed in this type of scenario. And this is a very small algorithm which can tell us how we come down to the diagnosis of a swelling. So depending on whether the swelling is a solitary swelling or a multiple swelling, and the position of the swelling in the neck, whether it is present in the posterior triangle or it is present in the anterior triangles, the swellings can be divided. It may be right from cystic hygroma to a subclavian artery aneurysm to lymph nodes to thyroid gland to the thyroid isthmus elongation to a thyroglossal cyst, a carotid body tumor, salivary gland tumor, dermoid cyst, a cold abscess, branchial cyst, or lymph nodes. So this small chart gives an idea how to come down to a diagnosis whenever we get a swelling in the neck. This is for the residents to note. Please never and never always say a neck swelling will be a thyroid swelling for you, because few of these cases may be presented to you in short cases. So what about these cases? So these cases, as per the first criteria, whether are there a midline swellings or are they lateral swellings, or they are the swellings which is having both a midline and a lateral approach or a lateral extension. So again, we have to think of what are the type of swellings that these may be. And whenever we get these sort of swellings, yes, these swellings could be a thyroid swelling. But if we are thinking of them as a thyroid swelling, then the next question we should come into our mind is, what is the functional status of the swelling? If it is a thyroid swelling, if it is something which is present in the midline or it is extending into the lateral triangles, and there are certain characteristics which I'll be talking about which will tell us whether this is a thyroid swelling or not. So what is the functional status? Whether it is a euthyroid swelling or there is any hormonal imbalance which will be there in form of a hyper or a hypothyroidism. And the third thing that we should think of is this swelling causing any compression on the soft tissues? So this is another considerations which may have a bearing for us during anesthesia, which we have to evaluate preoperatively. So whether are there any compressive signs because of this swelling? So these are things that we should know. So coming down to the history, you have to see what is the onset of the swelling, what is the growth, the progress of the swelling, whether the swelling moves with swallowing or tongue protrusion. The swelling moves with swallowing, may be a thyroid swelling, but not all thyroid swellings move with swallowing. In a case where there may be a carcinoma, this swelling may be fixed. Secondly, if a midline swelling is present which moves with tongue protrusion, it may be a not a thyroid swelling, but it will be a thyroglossal cyst. Then again, we have to see for any difficulty in breathing, swallowing, or speech. This will tell us about the compressive signs. This will tell us whether there is an involvement of any of the cranial nerves. Is there again a feeling of shortness of breath on lying down? This is another sign which tells us about the compressive sign. Is there any sudden increase in the size or pain in the swelling? This may go more towards the malignancy, that the swelling may be a malignant swelling. Any history of palpitation or vision loss, this will again show that this may be a case of hyperthyroidism. Again, you have to take a history of the weight loss or a weight gain, or menstrual disturbances in females. This will again give a history of the functional status. So the things that from this history point, what we can know of, we can make out what is the functional status of this thyroid swelling. And some of the important symptoms and signs which are present in different hormonal imbalances, I'll be just talking about. Please remember one thing, both hyperthyroidism and hypothyroidism affect the same organ system. The only thing which is different is the manifestation in that particular system. So in a hyperthyroidism, it may be a heat intolerance to increased sweating to weight loss, to palpitation, shortness of breath or tiredness. The patient may be agitated, irritated, emotional lability, insomnia, depression, excitation. Patient may have undergone a number of psychiatric treatments. There may be a presence of mild diarrhea. There is oligomenorrhea or amenorrhea in females, and there may be some small muscle wasting of the hands or the face and the shoulder. While in hypothyroidism, if we go, the patient will be tired, weak, mentally lethargic, cold intolerance, weight gain despite a normal or a poor diet. They may again be breathlessness, but it may be associated with an ankle swelling, difficulty in thinking and speech clearly and quickly, dementia or hallucination. This is totally different. The neuropsychiatric manifestation is totally different from what is there in hyperthyroidism. Here there may be a progressive constipation. Menstrual disturbances may be in form of menorrhagia in females. There it was oligomenorrhea or amenorrhea. Here it may be a menorrhagia. In hands, there may be again muscle weakness or wasting may be present, and there may be an association of carpal tunnel syndrome in this hypothyroidism. So again, this chart again tells us what are the different manifestations. These are the different, all these points you have to take up whenever we are evaluating the patient and taking the history. So we have to take the history and all these points that are being shown out here. And again, the same thing that I want to show, almost the same sort of an organs may be involved in both hyper and hypothyroidism. The only difference is the manifestation may be different. So we have to think of all these things and then we have to take the proper history. After taking a proper history, then the next stage comes, that is the examination. And what are the relevant points for a general physical examination is, if the patient has a facies, which is the mass-like facies, this may go more towards hypothyroidism. If there is a presence of protuberance of eyes and exophthalmos, this may again go towards hyperthyroidism. A moist skin will suggest thyrotoxicosis, while a dry skin is a feature of mixed edema. An anemia may be a sign of malignancy or thyrotoxicosis. And the sleeping pulse rate is taken because this may tell us about the severity of the thyrotoxicosis which may be there in this group of patients. Coming down to the examination and the inspection, a normal thyroid is not visible. And if there is a small thyroid swelling, then a procedure known as a Pizzulo's method is done, where the hands are clasped behind the occiput, and then the resistance is given so as to make this small swelling prominent. The swellings move up with deglutition. The question asked is why? And by the end of my talk, I think the resident should be able to give me an answer why this swelling moves up with deglutation. Is there any extension of this thyroid swelling into the retroexternal area? And a retroexternal goiter is usually depicted by two things on inspection. One is there may be presence of dilated veins over the upper thorax. And secondly, the lower border of thyroid is not seen when we ask the patient to deglutate. So that is this is something which is known as a getting below the swelling. So if we are not able to see the lower border of the swelling, then yes, there is a chance that the swelling may be extending into the retroexternal area. Examination has to be done. It can be done both from the front as well as back. So it has to be examined both from the front and from the back. Usually the neck is slightly flexed. When we are examining from the back, what are the things that we are seeing? Basically, what we are seeing is the lobes and the isthmus portion. We are seeing the consistency, we are seeing the extent, we are seeing the nodularity, we are seeing the skin. All these things are usually palpated from the back. And if we are sitting in front, so what we are doing is, then the palpation method is known as a Leahy's method, where we sit, we push the gland to one side, and from the opposite hand, we palpate the gland again for all these features. We see for the firmness of the swelling, we see for the nodality, whether there are any nodality in these swellings, skin over these swellings, all these things can be seen. Consistency and mobility can be seen in this case. Now, getting below the swelling, I have said you should be able to insulate one finger between the lower border of the swelling and the supraesternal notch. If you are able to do that, so that tells us that there is less chances of the swelling having a retroexternal extension. We have to do a Pemberton signs, which I'll be talking about. Other test that we do is a Kocher test. Kocher test is we give a slight pressure on the lateral lobes, and because of this pressure, this will compress the trachea, and there may be a respiratory obstruction, a partial respiratory obstruction, which may produce stridor. So you do this test. This again tells us the whether this is causing compression or not. And tracheal position, if feasible in small swellings, can be confirmed. In larger swellings, it is not possible to palpate the trachea in these conditions. For percussion over the manubrium sterni again gives an idea whether there is a retroexternal extension of the swelling or not, because if there is a dull knot which is present, that means that there is some body which is there, and usually it is a thyroid which may be there. And on auscultation, a groove may be present over the carotids, and this is because of the increase over the lateral thyroid lobes, and this is because of the increased vascularity of the thyroid gland. Other things that we have to see, especially in cases of hyperthyroidism, is the eye signs. And eye signs that is usually seen is exophthalmos, Stellwag sign, which is a white palpebra, which is seen. There is a decreased blinking. Dalraffi sign, which is there where there is a lid retraction. Von Graff's sign, where there is a lid lag. Mobius sign, where there is an inability to converge. Griffith sign, where there is a difficulty for the lig eversion. And Joffrey's sign, that is due to loss of wrinkling. The questions usually asked at this portion is, why is there presence of exophthalmos? How will we know that there is a white palpebral which is there? And how will you do a converging test in this patient? So these are other things that you are supposed to solve. Examiners usually ask you. This is about ask the patient there may be a distended or there is an increased JVP, and this is indicative of SVC syndrome, and it is presence of due to the compressions of vessels against the thyroid at superior mediastinal inlet. So this is the reason why this retrosternal quarter. This criteria for hypertension depend science and
बस आपका डिस्कनेक्ट हो गया है। हाँ, कुछ नेटवर्क इशू है या वी विल टेक ओवर, नो प्रॉब्लम। हाँ, मैं शेयर कर दे रहा हूँ, उनको करने दें।
Dr. Sahu, am I audible?
हाँ बॉस, अब ठीक है, आपका नेटवर्क चला गया था, लेकिन नाउ यू कैन डू, शेयर कर लीजिए।
So from where do I have to start?
Again, back slide, one slide backwards.
One slide back. Trying to share my screen. This will stop other screens.
आप दोबारा शेयर कर लीजिए बॉस। हाँ, अब आपकी फोटो दिख रही है, आप शेयर कर लीजिए दोबारा। हमारा आउट कर देते हैं, हमारा आउट कर दीजिए।
So
ठीक है,
यहाँ
हाँ
से
पेम्बर्टन साइन से एक बार बता दीजिए बस, ठीक है।
So this is a Pemberton sign. This is Pemberton sign. This is usually done. This was usually done to know about the retroesternal extension of the thyroid. And here what we do is we ask the patient to lift the hands up above the head, very close to the ear. And we see the face of this patient. And what is usually noticed is there is a facial flushing. The patient may have a feeling of inspiratory stridor. There may be presence of distended neck veins. And this is indicative of SVC syndrome. And this SVC syndrome usually occurs because of the compression of the vessels against the thyroid at the superior mediastinal inlet. This is usually avoided nowadays because there are chances where this patient may even lose consciousness because of this decrease in the blood flow in the upper areas. The historically, one other science which was done was a Wayne's criteria, which was used to diagnose hypothyroidism, where the score was taken both on the basis of the signs and the symptoms that the patient showed. And because of that, a score was there which ranges from plus 45 to minus 25. And more than 19 implied that there is a presence of toxic hypothyroidism. Less than 11 implies euthyroidism. Had a diagnostic accuracy of 85%. Again, no longer used, but just for a completion sake, I'm talking about these two criteria. Another is Zubrisky's clinical score for hypothyroidism. Again, every symptom and sign was given a score and ranged from 67 to 47. And highest weightage was given to sluggish ankle jerk and slow movements. Again, score of plus 25 or more suggested hypothyroidism, and a score of minus 30 or less excluded the diseases. So these are certain scores which was used previously to diagnose the hyperthyroidism and hypothyroidism. Now coming down to something about the physiology, what is the function of the thyroid gland? The thyroid gland is responsible for the growth in the body, the bone maturation of CNS, controls the BMR, controls the metabolism, has cardiovascular effects. So these are different things that are being controlled by thyroid. And we should know what are the cardiovascular effects of thyroid hormone. It has an increased sympathetic activity, increases the heart rate, improves the contractility, improves stroke volume and blood, increase oxygen consumption, decreases SVR but increases PVR, increases the automaticity and the excitability of the tissues, and increase systolic blood pressure with wide pulse pressure. So these are certain effects which the thyroid hormone have on the cardiovascular system. Regulation of thyroid hormones, we all know it is controlled through the pituitary, through a thyrotropin releasing hormone which acts on the anterior pituitary, hypothalamus, from which releases the thyrotropin releasing hormone, acts on the anterior pituitary, which secretes the thyroid stimulating hormone, and which acts on the thyroid and is responsible for the thyroid hormones, peripheral thyroid hormones. And this T3 and T4, which is produced in the blood, has a negative feedback mechanism by which the thyroid secretions of TSH and TRH and TSH is controlled by the peripheral concentration of T3 and T4. Few words about the thyroid hormone synthesis. It undergoes 4 steps. The 4 steps are iodine trapping in the thyroid gland, oxidation of iodine, and binding to tyrosine, the coupling, and the release and the cycling. These are the 4 steps which are responsible for a thyroid hormone formation in the thyroid. We are supposed to know this because in the examination this is usually asked. And why this is also important is the thyroid drugs, the anti-thyroid drugs that we are using, that the anti-thyroid drugs that we are using is also acts on particular areas on this very mechanism, so as we are supposed to know where these particular drugs act. Few words about thyroid function test. These are the normal values of T3, T4, free T3, T4 and TSH that we are supposed to know. We have to learn them, and it is this functionally important. Free T3 and free T4 is important for us for the normal functions to occur in the body. 95% of the thyroid problems can be diagnosed with these 3 hormones, that is the TSH, the free T3, and again we have how to treat them. All of these are not thyroid.
बॉस फिर से नेटवर्क चला गया आपका लग रहा है. फिर से बॉस अनम्यूट कर लीजिए अपनी तरफ से. Yeah, it's okay.
Again, I have to share the screen.
Yeah. इनका फिर लिंक हाँ शेयर करिए सर. आपका शेयर ना हो रहा तो हम कर दें. वॉइस भी नहीं आ रही बॉस आपकी. हाँ ठीक है. कोई नहीं करने दीजिए आपकी.
Again, we coming down to this value where there is a low value of TSH but a normal free T3 and free T4, and few of the conditions where this occurs is when the patient is already taking thyroxine, where there is a subclinical primary hyperthyroidism, patient is on a high dose of steroid or inotrope infusion has been given. In this condition, repeat a thyroid function test after 6 weeks. Other condition is where there is a low or normal TSH with a low free T3 and T4. And the common causes is a patient who is unwell with a non-thyroid
ऐसे करता हूँ मैं, अपना शेयर करता हूँ। चलो मेरा को शेयर को अलाउ करो। हाँ कर सकता हूँ, तो मैं कर रहा हूँ। देखो मेरा शेयर हो गया। Your share sharing is paused. Okay. Now, so there is some problem with the Dr. Sanjay Agarwal side. So I have shared the slide, and if he is not able to continue, I can speak on the slides. So to know a primary hyperthyroidism, we know that we should have a high, okay? We should have a high FT3, free T4 and T3 level and low TSH level. फिर से करवाओ।
Are my slides visible, sir?
आवाज ठीक है।
I'm sorry for the connectivity problem which is there. Now coming down to some anti-thyroid medications and where do they act? The anti-thyroid medications that is usually done are of these 5 varieties. Drugs which may causing an inhibition of hormone synthesis, drug which may cause the blockade of hormone release, a radioactive iodine, and ion inhibitors and beta blocker drugs. The most common drugs which is usually used is inhibition of hormone synthesis, which is usually propylthiouracil or methimazole. And where do they act? So it is important, as I showed, this is the pathway of formation of the thyroid gland, and the various drugs act at these levels to cause their effect, pharmacological effect. So we are supposed to know where these drugs act. Coming down to the 2 main drugs, that is propylthiouracil and methimazole, which are under the group of thioamides. They inhibit the hormone synthesis by inhibiting the peroxidase enzyme, which is responsible for binding of iodine to the thyroglobulin. Propylthiouracil also causes the peripheral deiodinization and conversion of T4 to T3. The methimazole is more potent and long-acting than propylthiouracil. These are few things that you are supposed to know. And you have to give their treatment at least for 4 weeks before taking up any of these patients for surgery, because they are usually slow in onsets and take at least around 4 weeks for the effect to come. These drugs are used for the treatment of mild thyrotoxicosis and in preparation of surgery. And propylthiouracil is relatively safe and preferred in pregnancy. These are few things that you are supposed to know. And now, sorry. Yes. Few differences between thiopropyluracil and methimazole, which is important and which are usually asked. Absorption, both are rapidly absorbed from GI. Protein binding, propylthiouracil is around 80 to 90% protein bound, while methimazole is most of the drug is free. It is not protein bound. Both get accumulated in thyroid gland. Excretion, propylthiouracil is excreted within 24 hours by kidney as inactive metabolite, while methimazole has a slow excretion and 60 to 70% of the drug is excreted unchanged over 48 hours. So half-life of methimazole is long. It's approximately around 6 hours, while from propylthiouracil it is around 1.5 hours. So it needs to be administered, propylthiouracil needs to be administered every 6 to 8 hourly, while methimazole is a single drug administration that needs to be done. Both crosses the placenta and goes up to the fetal thyroid, but the proportion of the drug crossing the placenta is less in propylthiouracil, and that is the reason why it is recommended in pregnancy. And even in breastfeeding, this drug is recommended because it is less secreted in the breast milk compared to methimazole, which is more secreted. So these are few of the differences between these two drugs. Some adverse effects from these two drugs is they may cause cutaneous reactions like urticaria, maculopapular rash, arthralgia, GI upset, hepatotoxicity, which is usually seen with methimazole and form of cholestatic jaundice. And agranulocytosis is the most common side effect, which may occur anywhere within 90 days of the treatment. So this is one of the most common adverse effects that we have to look for in a patient who is on antithyroid medication. So now another question from the postgraduates is, what is Lugol's iodine and what is its use? This Lugol's iodine is used for because it blocks the organification and release of the thyroid gland. So this is something which is used for a preparation of a patient who is hyperthyroid, and we want to do the surgery at an early stage. It also decreases the size and the vascularity. There's a rapid and usually it used to be given in previously, but now it is not very commonly used, but still this is one of the questions that is being asked. What is the constituent of Lugol's iodine? Radioactive iodine is alternative to surgery, where iodine 131 is usually given. It is easy, effective, low cost, there's no pain, but it is not advisable in pregnant patients. Anion inhibitors, these are monovalent ions like perchlorate, pertechnate, thiocyanates, which competently block the uptake of iodine. They are not commonly used because of the increased chances of aplastic anemia, which is associated with these drugs. But they are effective in those patients where the patient is suffering from iodine-induced hyperthyroidism. So again, this blocks the uptake of the iodine by the thyroid gland. Propranolol is used for the management of the cardiac symptoms of thyrotoxicosis. Lithium is another drug which was used to inhibit the synthesis and release of thyroid hormone. And one thing you have to remember, that amiodarone also results in hypothyroidism. So I'm leaving with this. What are the preoperative investigations? How will we manage the airway for these patients will be talked about by my subsequent speakers. But two things, yes, how will we investigate this patient? What are the different points in history that we have to take in? How will we examine this patient? How will we prepare these patients? What is Lugol's iodine? And another thing is, in hyperthyroidism, some examiners are very fond of asking what is primary and secondary hyperthyroidism. So these are a few of the questions that are usually asked by examiners, and postgraduates are supposed to know the answers of this. And I think so we can discuss these questions, or they can find the answers themselves. With this, I close my talk and over back to Dr. Sahu.
Thank you, boss. Thank you so much regarding discussing the thyroid anatomy, physiology, hormonal function, and drugs to optimize. Do we have Dr. Veena alive there? I think.
Madam has not joined.
Madam, you can share from your side, or I have to play your slides because she is busy in OR in transplant. So if she has time, then she can share. Otherwise.
Hello, Dr. Sandeep.
Okay. So before going,
now.
Yeah. Yes, sir.
It's my turn, I suppose.
Yes, sir. It's okay, sir. Before going to Dr. Veena, we have Professor Kaji Ahsan Ali, sir. And yeah. Let me introduce, sir, yourself. Share हो रहा है? Okay, let me introduce Professor Kaji Ahsan Ali, sir. Sir is a professor and chairman, Department of Anesthesiology and Critical Care, Department of Anesthesiology and Critical Care at Jawaharlal Nehru Medical College, AMU, Aligarh. And he has achievement like trained in fellowship in trauma, and he has been awarded fellowship of National Fellowship of India and Medical Scientist. And he has a lot of work in airway, especially is a lot of publication in that. And his publication has been being in the top 20 in domain of airway management. And he has more than 55 publications, and he has delivered a lot of lectures and in CME. So I hand over for especially because thyroid have a difficult airway. For difficult airway management in thyroid patient, it's over to Professor Kaji Ahsan Ali, sir. Sir, please share your slides.
Yeah.
Yes, sir.
Is it okay, Sahu?
Dr.
Sahu, is it okay?
आपकी स्लाइड्स विजिबल हैं, विजिबल हैं, और आप भी, आपकी आवाज भी आ रही है, आप दिख रहे हैं सर, आराम से प्रेजेंट करिए. थैंक यू सर.
Well, I have been given a very important and relevant topic, that is difficult airway and thyroid. When you talk of thyroid management, anesthetic management especially, then you have to talk about the airway as well. So it's very important to know about the difficulty that you might encounter during the management of thyroid, especially the anesthetic management, what the problems are to be there for the airway management. You can yourself see that this is a huge thyroid. If you start managing this or start your anesthesia, of course, anybody would be shocked to see that how to manage the airway in this patient. So for that, I have to have a proper investigation, proper preparation, and of course, proper gadgets and proper expertise. To begin with, I would like to say the size of the goiter depends on level and duration of the hormone insufficiency. Thyroid swelling has been considered a risk factor for difficult direct laryngoscopy and intubation and respiratory complications, in fact. Therefore, preoperative detection of any difficulty in managing airway or intubation during induction of anesthesia and airway control during the thyroid surgery is essential. So preoperatively, you have to be prepared very well. You have to have an idea of what the problem might be in future. Let's talk something about the incidence. The incidence of difficult endotracheal intubation, defined as inadequate exposure of the glottis by direct laryngoscopy, it has been shown to be as high as 8.5 to 11%. Talking especially about the thyroid swelling is not only associated with distortion of airway, but also carries the risk of hyper or hypothyroid function, leading to generalized endocrine disturbances and metabolic effects. Let's see what are the problems that you might encounter during the management. There are three levels at which you can find the problems. The levels can be supraglottic, it can be glottic level, it can be below the glottic, that is infraglottic level. Difficulties in airway control are expected at 3 different levels. That's what I have just made it red: supraglottic, glottic, and infraglottic. Mouth opening, tongue size, submandibular space, and of course head and neck movement, neck circumference, and BMI. There are the supraglottic ones. These are the factors which are going to contribute to the problems. They are not going to contribute to the solution. They are going to contribute to the problem. The direct laryngoscopy, of course, in patients with Mallampati grade 3 or 4 and restricted mouth opening are also again the factors which are going to create problems. One more important thing that you must notice before managing these patients is, of course, a thyromental distance. If it is less than 6 centimeters, be it any patient, of course, what to talk about the thyroid, be it any patient, if it has got a thyromental distance of less than 6 centimeters, it's going to pose problem. It's for the general patients, in fact. Similarly, if you have a business angles of less than 80 degrees, it's going to create problem, be it a thyroid patient, be it a normal patient, be it a routine patient, in fact. Similarly, if the thyroid is compounded with obesity, obesity itself is dangerous and difficult to manage as far as the airway concerned. But if it is combined with the hyperthyroid or the, say, large thyroid swelling, then it's going to create further problem. It's going to square the problem. Similarly, another factor is neck circumference. It plays an important role in all the patients, especially in the obese patients. And of course, if the patient has got a thyroid in addition, more than 50 centimeters of neck circumference is going to create problem. Now let's talk something about the glottic airway factors. What could be they? We have to do the indirect laryngoscopy, which is advised, and to look for the vocal cord movement and evidence of cord palsy, we have to do a direct laryngoscopy. Indirect, sorry. This will serve the problems of the medical legals, as well as it will give you a guide to plan for intubation. So you should do an indirect laryngoscopy. Now let's talk something about the infraglottic airway factors. There are different factors at different levels. For example, supraglottic, glottic, and now we'll talk about the infraglottic airway factors. We are talking about the factors which are going to compound the problems. What are they? The deviation and compression of the trachea and tracheomalacia by the long-standing thyroid swelling. If the thyroid swelling is for quite some time, then obviously it's going to create problem. How? Because it deviates the trachea, and of course it compresses the trachea as well. So it's going to create problem. Transient recurrent laryngeal nerve palsy, which is commonly unilateral generally, but intrathoracic extension of the thyroid also may create problem. There are different tests. Patient body weight, height, body mass index, BMI, protruding maxilla, these are all going to create problem in this region. Similarly, marked forward protrusion of the upper incisors beyond the lower incisors, mouth opening and submandibular space, Mallampati test graded in an upright sitting position. It should not be in the lying down position. So Mallampati test should be graded, of course, not in the thyroid patient, in all the patients, it should be graded properly, and it should not be in the lying down position. It should be in the sitting upright position like this. The thyromental distance is, of course, measured from the thyroid cartilage, up to the mentum. So this distance should be measured in centimeters. That's what we call is thyromental distance. In an achievable head and neck position desired for direct laryngoscopy and intubation, a distance of less than 5 centimeters is associated with difficult grades of laryngoscopic view, even after external laryngeal manipulation. This must be noted that a distance of less than 5 centimeters is going to pose problem for the patients in general. What to talk about the patient with the thyroid swelling. The factors concerning glottic level are related to cord paresis or paralysis due to recurrent laryngeal involvement, which is diagnosed by indirect laryngoscopy using the mirrors. Position of the vocal cord can be a factor for the difficult intubation, especially if the cords are in abduction or edematous. It may present resistance to tube passage as well. So accommodate a smaller size endotracheal tube, be it 7 to 7.5 for the adult males. The infraglottic assessment mainly concerns with thyroid swelling. That is important. Now let's talk about the infraglottic assessment. The size of the goiter measured in millimeter, of course not in centimeters, measured in millimeter, along the main straight line of the goiter with the head fully extended like. Compressive symptoms, it could be like dyspnea, it could be dysphagia, it could be hoarseness, it could be a change in voice quality, and restricted neck extension should be looked for. So these things should be taken care of in the infraglottic assessment. For this, we have to have proper assessment of the neck. Of course, not the neck, not the muscle of the neck, rather an AP view of the AP or the lateral view of the X-ray neck. What do you confirm it? We confirm the tracheal position. What is the position of the trachea? If you get X-ray done, you will have an idea about the position of the trachea, whether it's deviated or not. The tracheal deviation of more than 1 centimeter from the median line in X-ray neck is considered significant to cause respiratory problems. That's why we get an X-ray done. Of more than 1 centimeter is of course going to lead to problems. That's why we get an X-ray done. The tracheal compression or stenosis, that too should be diagnosed beforehand, so that we should have an idea of what type of tube, what size of tube will be of course introducible. Tracheal compression, a significant tracheal compression with the goiter causing more than 30% of tracheal lumen narrowing is going to create problem. In that case, do not sit quietly. What do? You should go for CT scan. You should go for CT scan in suspicious cases. Infiltration by the tumor should be confirmed by the CT scan, which is more informative than the simple neck X-ray. Simple neck X-ray may not be that much informative as the CT scan is, because it will give you an idea about the infiltration and the extent of the thyroid or the retroesternal goiter. Radiological evidences of deviation increases difficult intubation by 6-fold. That you must remember. This might be asked in your exams, that how many folds the difficulty might be increased with the deviation of the trachea. So it is 6 folds. Note it down. See, this is a trachea, deviated trachea in a huge thyroid swelling. So you can imagine how difficult it would be. So you have assessed. See, now you are loaded with the problems. You have got the idea about the problems. So of course, just knowing the problem may not be a solution. So you should be able to understand the problem and you should be able to tackle the problem. So to tackle the problem, you have to have a plan. You cannot do it arbitrarily. So among different plans, I am going to present before you a plan that is a standard plan. That is the airway assessment. How do you assess it first? So if you keep it in the top, like airway assessment, so you can divide into 2 parts, this assessment. The trachea, depending upon the deviation of the trachea. The trachea could be either central or the trachea could be deviated. I will take this part later on. I will take it now. Trachea deviated may again have 2 problems. What are they? There is no retroesternal goiter. Trachea is deviated, but there is no retroesternal goiter in CT scan. But if the trachea is deviated and there is a retroesternal goiter too, then the problem will be different. Let's talk about that, how to proceed. The retroesternal goiter is there, and there are 2 possibilities again. Goiter is there retroesternally, and the compression is not there. There is no compression. And another problem could be that there is a compression as well. So it's an emergency. There is a deviation of the trachea, there is a retroesternal goiter, and there is a compression of the trachea. So of course, you are left with no choice than to go for awake fiber optic intubation. Just a minute. Just a minute. Just wait, sir. Yes. So we will go for awake. Am I audible? Am I audible?
Yes, sir, you are audible, sir.
Okay. Okay. Then we will go for the awake fiber optic. If it fails somehow, then we are bound to cancel the patient or regroup the patient. Now the second limb, retroesternal goiter is there, but there is no compression. Then we can go for the inhalational or induction agents and fiber optic intubation, of course. It may not be awake intubation. Of course, again, it might fail. Then again, the cancel and regroup. So this part is covered. The retrocell goiter is there, trachea is deviated. Now let's talk about the no retrocell goiter, but the trachea is deviated. This part. What will happen? No retrocell goiter. There can be signs of tracheal compression. There may not be signs of tracheal compression. If there is a goiter retrocellally, of course, there are chances that the patient might have signs of tracheal compression. If it is there, then you have to proceed in a different way. If it is not there, then you have to proceed in a different way. What is that, by the way? So what is that? I'll just see. Signs of tracheal compression is there. Again, go for the awake fiber optic. If somehow fails, of course, generally it does not fail in expert hand, like us. In fact, I can tell you. But if it fails, then you of course you're compelled to cancel the patient, or if needed, tracheostomy below the thyroid can be done, because there is signs of tracheal compression and there is no retrocell goiter there. But if no tracheal compression is there, no retrocell goiter is there, but there is a tracheal deviation, then how will you proceed? You will proceed like IV or inhalational induction agents with fiber optic intubation, maybe even the laryngoscopy intubation. If somehow fails, then again the same protocol, cancel or tracheostomy below the thyroid. So this is a good chart. So it's a good chart that leads to tell you how to manage a patient who is having retractional goiter, or who is having a tracheal deviation, or who is having a tracheal compression. So all these things need to be known beforehand and how to proceed. So I have given you a plan how to proceed. Now you have decided the things. Now tube selection is very important. Which tube to select? What to the size of the tube to be selected? If there is stenosis, of course, you would like to know about this, the stenosis, the level of the stenosis, the percentage of the stenosis. Accordingly, you will select the tube size, and of course, the flexometallic is the choice. Post intubation amount of air required to make adequate seal is noted. That is very important. Monitors. As usual, you can monitor with pulse oximeter, capnometer, blood pressure monitoring could be invasive, non-invasive, both can be tried. ECG monitoring should be there. Temperature regulation is of course important in patients with thyroid surgery. Then PNS, of course, for the status of the nerves. Now let's talk about the airway management. What are the factors in the goiters? Factors in goiter. Direct laryngoscopy and intubation. The direct laryngoscopic view influenced by the patient. Head positioning, very important. If the patient head cannot be properly placed, it cannot be extended, it cannot be properly flexed, of course, it's going to pose problem for the laryngoscopy. Lifting laryngoscope, then making fulcrum over the upper teeth. It's very important to note. You should lift the laryngoscope rather than making a fulcrum over the upper teeth. Experienced laryngoscopists would do better compared to the non-experienced ones, isn't it? Similarly, force used to visualize the glottis, very important how much force is being used. Besides position, some maneuvers have also been used to improve laryngoscopic view. There are many maneuvers, but for example, backward, upward, rightward pressure on the thyroid cartilage by an assistant to improve laryngeal view at laryngoscopy. It's very important. Aids like external laryngeal manipulation, required pressure, and alternative aids like change of blade, gum elastic bougie has also been suggested in patients with thyromental distance of less than 5 cm. That in fact improve the Cormack and Lehan laryngoscopic view by 1 grade. So very important aid. If laryngoscopy fails and ventilation possible by mask, then very simple. Laryngeal mask airway with positive pressure ventilation can be used for surgeries except in case of subglottic obstruction. If there is subglottic obstruction, then of course you are unable to make a laryngeal mask airway say useful. Because obstruction is there, it's not going to give you proper ventilation. So, useful armamentarium, what are they? Useful armamentariums. Can anybody tell what is this, by the way? This? Anybody? I think hardly anybody can. Are you audible? Hello?
हाँ सर, ऑडिबल है आप.
Okay.
ऑडिबल है सर.
Okay. The first
और बाकी
figure is
लोग अगर जवाब देना है तो उनको अपने आप को अनम्यूट करना है, देन दे कैन स्पीक. अगर फैकल्टी पूछ रही है और आपको जवाब देना है तो अपना आप अनम्यूट करिए और जवाब दीजिए या टाइप कर दीजिए चैट में. थैंक यू सर.
okay, sir, no problem. The first figure is the air track. That is the pink colored. It's for the pediatric one. This is one of the aids to intubate a patient. Of course, this is the smaller one. We have the blue one for the adult males and the green one for the adult females. So we have different range of air tracks. Yes, you are talking something.
जवाब आ गया है. इंट्यूबेशन एलएमए एयर ट्रैक.
अच्छा, इंट्यूबेशन एलिमेंट नहीं है वैसे. That is air track. And second is the King Vision video lens scope. This one, King Vision. It's one of the newer devices. It has got a monitor and a handle. The handle can have a channel or it could be a non-channel. Once it is a non-channel King Vision laryngoscope, then we have to use stylets. So accordingly, we have to manage that. And then we have a video stylet as well. Stylet itself is a video stylet. So that may help you. Similarly, we had the old one, the McQuire laryngoscope blade that can lift the epiglottis. That's going to help. Fiber optic, of course, everybody knows that is the gold standard. Yeah, just wait. Now let's talk about the approach in different obstructions. For example, airway approach in glottic factors, for example. Glottic factors related to vocal cord palsy, mainly infiltrating malignant tumor lesions, might lead to this problem. Stridor and voice changes are likely to be present, and a warning signal in these patients. Airway approach in infraglottic factors. Let's talk what happens in the infraglottic factors. Infraglottic factors, size and duration of the swelling is very important. Their awake fiber optic intubation is the choice. Loss of the airway due to compression on the trachea is very uncommon at the time of induction of anesthesia than after tracheal extubation and recovery room. Why? Patients without breathing difficulty, securing airway will be determined. Patient without breathing difficulty, securing airway will be difficult or will be determined by the infraglottic airway. Just a minute.
No problem, sir. No problem.
Anyway, patient without breathing difficulty or with difficulty, they have different problems. For example, without breathing difficulty, securing airway will be determined by supraglottic than infraglottic factors, isn't it? Now, in airway approach in infraglottic factors, size and duration of the swelling, awake fiber optic, I have talked about that. Slightly there is a mingling of this, yes. Now, leak test very important for thyroid management, airway management. In fact, if there is a huge thyroid swelling and you are managing the airway, the leak test is very important. Note the amount of air required for cuff inflation to seal the trachea after intubation. Prior to extubation, suck the oropharynx and deflate the cuff on ETT. Note if leak is present by positive pressure ventilation, possibility of tracheal collapse around the ETT is there. So note all these three important points because they will be asked in exams. What is leak test? Leak test will definitely be asked if you get a thyroid swelling. Defer the extubation for a few hours to next days if there is a problem like this. Rarely, tracheostomy is needed. Endotracheal tube exchange with LMA, fiber optic visualization of vocal cord is very important when you are talking about the extubation. I will give you an idea about the regional anesthesia for thyroid surgery, though it's not generally given. It is for theoretical purposes. But once you are given a case like this, you may be asked for the regional anesthesia for thyroid surgeries, and of course, when you give it and how you give it. Cervical epidural anesthesia is very important. Cervical epidural anesthesia, that is how it is done. Take 10 ml of 1% lignocaine, 0.25% of bupivacaine, and 0.5% of ropivacaine that can be used and mixed. What are the indications? When you have a difficult endotracheal intubation as anticipated, or in those where alterations in thyroid function make then vulnerable to cardiovascular complications under the conventional general anesthesia. When you do not have the option of conventional general anesthesia, you can go for this regional anesthesia for thyroid. So, of course, it has an indication, but remotest. COPD patients are cardiomyopathic patients, valvular heart disease patients, where you are restricted, where your hands are tied, then you may go for the regional anesthesia for thyroid surgery with cervical epidural anesthesia. Airway pollution is avoided with this. If you, of course, you are going for the regional anesthesia for the thyroid surgery, then the air pollution in the OT is, of course, avoided. It's not that, of course, at this juncture, it's not that important. Cost is minimized. There's no problem in that. Post-surgical respiratory complications could be there because the patient had a huge thyroid swelling. You have managed him. You have taken out the swellings. Now you are talking about the post-surgical respiratory complications. There are significant factors which are associated with this complication. What could be they? Thyroid swelling of at least 5 years duration. It is going to pose problem. Of course, the duration is very important in a huge thyroid swelling. Larger size of a swelling, of course, smaller size of swelling is not going to create that problem as the large size. Similarly, a swelling of a shorter duration is not going to create problem as a swelling of the larger duration. Associated with the tracheal narrowing is there, then of course it's going to pose problem. It's very simple. It's very simple to understand that all these factors are going to create problems. If the swelling was malignant, then of course it might create problem post-operatively. Similarly, preoperative recurrent laryngeal nerve palsy can be there. Retrosternal extension might be there. So these are there, which might lead to problems after surgery, even respiratory complications. What is tracheomalacia? Very important. This will definitely be asked in your exams. Once you are given a thyroid patient, this is one of the questions which is out right now. What is tracheomalacia? The incidence of tracheomalacia has been reported from 0.001% to as high as 1.5%. Tracheomalacia, in fact, leading to tracheal collapse, results from prolonged compression of the trachea by a huge goiter, particularly within confines of the thoracic inlet, having rotational extension. It is very important to underline two things. Within the confines of the thoracic inlet, having retroexternal extension. This is very important. It is a life-threatening complications which must be taken care of before extubation. Tracheomalacia is not, do not take it lightly. It might take your life, the patient's life, in fact, because it might get collapsed even after extubation, then the patient won't be able to respire. Then again, there will be an emergency and you have to make the emergency arrangement. Tracheal collapse mostly takes place after surgery as the thyroid tissue supporting the trachea is excised. The tissue which was initially supporting the trachea has now been excised. So of course it's going to create problem. It's going to get collapsed. Criteria to diagnose the tracheomalacia: soft and floppy trachea on palpation by the surgeon after withdrawing endotracheal tube for a short distance, obstruction to spontaneous respiration during gradual withdrawal of the EGT after thyroidectomy. These are the things which will lead you to a diagnosis of tracheomalacia. Soft and floppy trachea, palpated by the surgeons taking the tube slightly out. Difficulty in negotiating the suction catheter beyond the EGT after gradual withdrawal. Absence of peritubal leak and deflation of EGT cause. Loss of volume pressure loop on ventilator. This is, of course, one of the important things that you must note, an examiner might ask you. Loss of volume pressure loop on the ventilator. Development of respiratory stridor along with the falling hemoglobin oxygen saturation on pulse oximeter despite oxygen by face mask. The respiratory stridor will be there. Post-extubation airway obstruction, it could be partial airway obstruction. Commonly related causes must be looked for. Do not go for the rare ones. That the tracheomalacia is a must. No, there could be simpler things that you should rule out first, like mucus plug. That might create the problem like that only. Post-operative. There could be blood clot. So these things should be of course ruled out first. Or even there can be incomplete recovery from anesthesia, especially muscle relaxant effect. So that you should first of all confirm that these problems are not there. Hematoma or reactionary hemorrhage with sudden increase in neck swelling or laryngeal edema. If there is a laryngeal edema, if there is a neck swelling, if there is a sudden increase in neck swelling, or there is a reactionary hemorrhage, then all these problems might be there. So better you suspect the commoner ones first. So in exams, you reply in that way only, that you should talk about the mucus or the blood or the incomplete recovery or hematoma due to reactionary hemorrhage or sudden increase in neck swelling, maybe because of the
आज भी
laryngeal
बॉडी से
edema.
कुछ हमें लग रहा कोविड
Recurrent
बढ़ता जा रहा, लोग ड्यूटी में फंसे हैं.
Recurrent laryngeal nerve injury and tracheal collapse could be there. Stridor is suggestive of partial airway obstruction and may be related with upper airway edema and transient abductor vocal cord palsy. Except for tracheomalacia and nerve injury, mostly obstructed breathing is transient and reintubation may be required till patient is fully awake. Approach to tackle airway obstruction after extubation. After extubation, there is a problem. Of course, we have to tackle it. There should be proper backup airway present. Monitored for airway obstruction or breathing difficulty after extubation should be there. There should be preparedness for intubation. It's very important. That should be ready with persons and with the gadgets, both. The first attempt should be to ensure oxygenation and ventilation with oxygen supplementation by well-fitting face mask. Face mask should not be loosely fitting. It should be well-fitting. A quick review must be done to assess adequate recovery from relaxant effects. It should be known, of course. Respiratory parameters may be misleading in this condition due to obstructed respiration. A small dose of sux can help in the cases of laryngeal stridor. If there is a laryngeal stridor, a small dose of sux may be helpful. Reintubation with a smaller size of endotracheal tube is recommended in case it is indicated. IV methylprednisolone can also be used to reduce laryngeal edema if it is there, likely to develop after extensive neck clearance in malignancy. It could be there. The LMA has also been reported to be useful in management of stridor. So by now I talked everything about the related, specifically about the airway management, the thyroid, huge thyroid swelling, and related problems, the factors, the supraglottic, the glottic, the infraglottic, and of course the preparedness, the flow chart, how to manage it, and accordingly how will you proceed for the post-operative. Thank you very much.
Thank you, sir. Thank you so much for very detailed. What should be the actual approach, and this is proven well in clinical settings. So I request Professor Suren Singh sir, being the chairperson for this session, to expert comments or intervene if he wants. Sir, you have to unmute. You have to unmute yourself.
Myself?
ना प्रोफेसर सुरेंद्र सिंह सर टू अनम्यूट, उनको अनम्यूट करना पड़ेगा अपनी तरफ से. ओके,
नमस्कार.
Okay. Unmuted from my side.
Done, sir.
Yeah, it was very well spoken. I could only, because of traffic reasons, I could only attend the tail end of Dr. Sanjay Agrawal's talk. But whatever I could attend, he had done it well, and Dr. Saab has done very nicely, very well covered. Very well covered, and your flow chart of what to do, what not to do, that flow chart is really informative. If that chart itself shows anything about your talk today.
Thank you.
I think both the clinical aspect and from exam point of view also, all
Yes.
the final point has been touched, and these are important for day-to-day management of thyroid airway management, and even in exam all the questions, even theory part also, it can be asked in theory also some parts. So anything else anybody want to ask, because we don't have like questions in the chat box. Only one thing is asked, what should be that, like we put the endotracheal tube, we inflate the cuff, but in thyroid cases the cuff pressure means it should be like usual one, or it should be put a less or different from the routine one?
Depending upon the size of the thyroid, in fact. Let us see what is the size of the thyroid. If it's small nodular swelling, you may not be increase the cuff pressure. Rather, you can do the proper normal pressure, whatever it is. But if it is a huge thyroid, there's a compression, the pressure should be less comparatively.
Okay, sir.
Why should cuff pressure be of importance here? Should it not be just the sufficient quantity of pressure inside the cuff to barely prevent the capillary flow, blood flow? So why
Yes,
should
I think you are right, sir.
why should it be dependent upon the size of the thyroid, the cuff pressure?
In fact, the duration of the thyroid swelling might lead to compression or say the softness, the floppiness of the trachea. If the trachea gets floppy, and of course, if you extubate it or you go for the peritubal leaking, it's not advisable to have a peritubal leaking during the operation.
They say in case of pre-existing tracheomalacia.
Yeah, that's what I'm saying.
Yeah. So now it's clear. So I request Professor Veena Madam to please share the slides. Thank you, sir. Thank you, Kaji Saab, for very nice and wonderful talk as usual.
Thank you.
Thank you, sir. Dr. Veena, you can share your slides from your side.
So can you play my slides from your side?
Yeah, I can do that if you want that.
Yeah,
I will
because
try.
I'll have to go.
That's not a problem. It's okay. मैं शुरू करता हूँ मैडम. मैं कर रहा हूँ ये.
Zoom वाले में गया ना.
So Dr. Veena has done the wonderful work. He has given me slides with the voice. So I am running that slides, and if any issue, she can join anytime. Not shared. Huh? Okay. Sharing is paused. Stop share. Share. We are sharing. Duplicate. Okay.
So what are the
Okay, यहाँ से ये वाली स्लाइड चलानी है. Okay.
So I will be starting my talk with a 55 years female presented with history of neck swelling for last 10 to 15 years. The swelling was insidious in onset, gradually progressive, increased in size tremendously over last 5 to 6 months. The swelling was associated with difficulty in breathing, swallowing and hoarseness of voice at present. So what are the anesthetic concerns in such a case? Our concerns are to see the functional status of the thyroid, whether the patient is euthyroid or non-euthyroid, to see whether the patient is undergoing elective or any emergency surgery for thyroidectomy or any other incidental surgery. What is the extent of airway compromise, whether it has got a tracheal deviation or compression or retrosternal extension, or there is no such airway compromise in this patient. What are the concerns of intraoperative positioning, blood loss, intraoperative monitoring, what is our extubation strategies, and perioperative and postoperative complications. Our concerns are to see the functional status of the thyroid, whether the patient is euthyroid or non-euthyroid, to see whether the patient is undergoing elective or any emergency surgery for thyroidectomy or any other incidental surgery. What is the extent of airway compromise, whether it has got a tracheal deviation or compression or retrosternal extension, or there is no such airway compromise in this patient. What are the concerns of intraoperative positioning, blood loss, intraoperative monitoring? What is our extubation strategies and perioperative and postoperative? Anesthetic aims in such a patient is optimization of the functional status of the thyroid and associated comorbidities, continuation of the thyroid medications as per endocrinologist advice. Airway management plan should be done in the preoperative phase. Whenever we have a small swelling, coming to the role of the supraglottic airway device and front of neck access in this patient, because there is a risk of displacement because of the huge thyroid swelling and associated with tracheal deviation and compression, the role of supraglottic device is questionable. Even the front of neck access is debatable due to the distorted anatomy. So our patient has to undergo total thyroid.
मैडम इस वजह से नहीं आ रहा है, अभी आ गया आपका।
So what's going on, मैडम आप शेयर कर रही हैं क्या?
I am trying because your slides are not moving.
हाँ वो तो प्रॉब्लम है वीडियो, मैंने कहा था आपको, अगर आप शुरू कर सकती हैं तो कर लीजिए।
चलो।
Video is not working ना, यही तो प्रॉब्लम है।
No, I have sent a PPT along with voice also.
कुछ भी हो मैडम, all is not working.
Okay, not a problem.
अच्छा, तो आप यहाँ शुरू कर लीजिए फिर एनेस्थेटिक एम्स। ठीक है, वी आर सीइंग योर स्लाइड्स, इसको बड़ा कर लीजिए, प्रेजेंटेशन मोड पे आ जाइए नीचे से।
So our anesthetic,
yeah, it's okay.
पीछे नहीं आ रहा।
स्लाइड विजुअल है, आपकी वॉइस भी क्लियर है, प्लीज।
So our anesthetic aims are to optimize the patient for the functional status of thyroid and associated comorbidities, continuation of the thyroid medications. Airway management plan should be done in the preoperative itself. Whenever we have a small swelling with no evidence of compressive symptoms, one can go for conventional video laryngoscopy or with endotracheal intubation. But in a case with large swelling and evidence of compression and deviation, like in our case, awake fiber optic intubation is the preferred choice of airway management. One should always anticipate tracheal collapse by a huge swelling or loss of the muscle tone, and should avoid giving muscle relaxants and inhalation agents at the time of induction. Sometimes even lifting of the swelling is required for the ease of intubation. Swellings with retrosternal extension may require sternotomy.
स्लाइड शो शुरू कर दीजिए, हम स्लाइड शो, बाकी दिख तो रही है हमको स्लाइड, फुल स्लाइड शो पे आ जाइए। ठीक है, गुड। आपको अपनी वॉइस बोलनी पड़ेगी। मैडम आपकी वॉइस नहीं आ रही है, आप जब बोल रही थी वो बोली, आप बोल नहीं रही ना, आप स्लाइड को मत चलाइए, आप खुद बोल रही थी वही करिए। ठीक है, स्लाइड 7,
Okay. So
plan
plan
of anesthesia.
in a patient which has to undergo total thyroidectomy is general anesthesia with endotracheal intubation and controlled ventilation. In a case with hyperthyroidism, thiopentone is the preferred agent of choice because it prevents peripheral conversion of T4 to T3. Although propofol can also be used because of the faster onset of action and recovery, and it also prevents post-op nausea and vomiting. It is better to avoid ketamine and vagolytic agents because of the sympathetic stimulation. Hyperdynamic circulation is present in these patients, so induction should be done slowly. So what is the preferred endotracheal tube in patients who are undergoing huge thyroid swelling? The preferred tubes are definitely flexometallic endotracheal tube because they do not kink and they do not get compressed. They should be fixed beyond the compression or swelling to prevent any difficulty in ventilation in the intraoperative period. Tubes should be fixed properly to prevent any accidental extubation or pull out during the surgical manipulation. Other special tubes, which are known as NIM EMG tubes or neural integrity monitoring electromyogram tubes, they are used to assess the integrity of the recurrent laryngeal nerve or supralaryngeal nerve intraoperatively as they measure the evoked potentials from the vocalis muscle. Conventional thyroidectomy requires head and up and neck extended position, which is known as rose position. The advantage of this position is that it makes thyroid prominent and decrease the venous congestion, but it has some disadvantages, which are there are more chances of tube dislodgement, increased risk of air embolism because of the negative pressure which is created in the neck veins. Arms are usually adducted, so one should ensure extension tubing with IV lines. Eyes should be protected, especially in patients who have exophthalmos. All the pressure points should be padded to prevent the nerve injury. Adequate depth of anesthesia is to be maintained using the supplemental narcotics like fentanyl, inhalational agents, sevoflurane, isoflurane. Muscle relaxants, atracurium, vicuronium, rocuronium can be used, but if there is possibility of myopathy with these patients, then it will prolong the neuromuscular blockade effect, and one should keep this in mind. Pancuronium is avoided as it increases the sympathetic activity. There should be meticulous fluid replacement along with the blood loss. Normothermia, normoxia, normocabia should be maintained. Reversal is usually done with a glycopyrrolate and neostigmine in the usual doses. Intraoperative monitoring is as per the standard ASA monitoring, ECG for heart rate and arrhythmias, non-invasive blood pressure monitoring, temperature monitoring, which is of utmost importance in these patients, SpO2 monitoring, and tidal carbon dioxide monitoring, respiratory gas monitoring, and neuromuscular monitoring is although optional, but it is neuromonitoring can be done either by the direct visualization of the vocal cord function, which is difficult,
And it can also be done by the NIM tubes, which have the embedded several electrodes above the cuff. And one should be very particular in positioning of these tubes, because these tubes should directly lie on the vocal cords to track the EMG activity of the laryngeal muscles. And these laryngeal muscles activity is transmitted to the motor, this monitor, which can provide signals either in the audible form or in the visual form to the surgeons for the superior laryngeal nerve and recurrent laryngeal nerve injury. There should not be any axial rotation or lateral displacement of endotracheal tubes, because it may affect the signal quality. There is controversy regarding the use of inhalational agents, that halogenated agents and nitrous oxide, they depress the IONM signals. TY is usually preferred as it increases the better intraoperative signals due to the muscle relaxation. Intraoperative complications in patients who are undergoing thyroidectomy are very challenging. Bradyarrhythmias because of the carotid body stimulation can be there, and the management includes stopping of the surgery, lignocaine infiltration around the carotid body, and avoidance of atropine. Excessive bleeding, because thyroid itself is a vascularized gland and it lies in the vicinity of the major vessels, is a problem, and one should always arrange blood in these patients. The bleeding can also lead to acute hypotension, which may require direct sympathomimetics like phenylephrine in hyperthyroid patients, and one can require indirect sympathomimetics like ephedrine, dopamine, or epinephrine in hypothyroid patients. There is always risk of damaging recurrent laryngeal nerve or superior laryngeal nerve along with the surrounding structures. Air embolism is also one of the known complications in the patients, because the surgery is usually done above the level of the heart. There can be accidental extubation, disconnections, or kinking. There are more chances of thyroid storm in patients who are not prepared properly in the preoperative phase, and there can be difficult ventilation intraoperatively due to the surgical manipulation in huge thyroid especially. Pain management is usually done in these patients using a multimodal approach with the use of shorter acting opioids, non-steroidal anti-inflammatory drugs, paracetamol. One can go for infiltration of the operative site with local anesthetics, or one can also use ultrasound guided superficial cervical plexus block. Post-op nausea vomiting using traditional antiemetics and dexamethasone is used, and it should always be done, because whenever there is a retching and vomiting, it can lead to hematoma post-operatively. There are extubation concerns in this patient with a huge thyroid swelling, and they are tracheomalacia, vocal cord palsy, hemodynamic instability, concerns of prolonged muscle paralysis, and laryngeal edema. Tracheomalacia, it leads to post-extubation stridor and respiratory distress due to the airway collapsibility post-operatively. Sir has already talked about tracheomalacia in detail, and it usually occurs in long-standing goiter with tracheal narrowing. The diagnosis is usually made by the surgeons intraoperatively, and they can feel for the soft and floppy trachea. There are other two tests. One is cuff leak test and another is pull-out test to diagnose tracheomalacia. Cuff leak test measures and auscultate cuff leak after deflating cuff when tube is within C-tube, and the cutoff values for cuff leak volume is less than 110 ml or less than 10 to 15% of the delivered tidal volume. It is important to remember that lesser the leak volume, higher are the chances of the post-extubation stridor. Pull-out test is done when one is trying to extubate the patient on the fiber optic bronchoscope, and the patient may lose the spontaneous respiration during the gradual withdrawal of the endotracheal tube. And this also predicts the tracheomalacia. With the availability of ultrasound in the operation theater these days, laryngeal ultrasound can be done to predict the post-extubation stridor. One can go for laryngeal air column width, measure it before and after the endotracheal cuff deflation, and can measure the air column width difference at the vocal cord. Management of tracheomalacia includes intraoperatively artificial tracheal support, and post-operative, one should plan for elective ventilation. Now, coming to the steps of extubation, before extubating, ensure complete reversal of the neuromuscular blockade, followed by the assessment of the vocal cord using direct laryngoscopy or video laryngoscope. One can also go for fiber optic visualization of the vocal cord through LMA. There are many methods to assess vocal cord movement by the ultrasound guided assessment of the vocal cord movement. Before extubation, the key question to be answered is it safe to remove the endotracheal tube? If the answer is yes, then awake extubation should be planned in a huge thyroid swelling, and our aim is always to extubate smoothly without bucking and cuffing. Extubation strategies using advanced techniques are there. One is ballet maneuver, another is extubation over fiber optic bronchoscope, and the third is extubation over the airway exchange catheters. Ballet maneuver is substituting a LMA for the endotracheal tube while patient is still paralyzed, which is followed by the endotracheal tube cuff deflation and tube removal. When spontaneous breathing is resumed, LMA is removed. Thus, it leads to very smooth extubation. Flexible bronchoscope is advanced to the LMA to visualize the anatomy of the vocal cord movements, and it has the advantage that whenever we require re-intubation, it can be facilitated through the flexible bronchoscope. Extubation over the airway exchange catheters is preferred usually in huge thyroid swelling with difficult intubations. It is introduced through the tracheal tube. It can lead to spontaneous breathing through it, and oxygenation and respiratory monitoring can be done with the airway exchange catheters in situ. It also serves as a conduit for re-intubation. Coming to extubation in ICU, is always planned when one is not sure of the immediate airway patency after extubation. Regional anesthesia for thyroidectomy is usually not practiced routinely because it requires cooperative patients and expertise. It is indicated in patients with severe cardiac and respiratory compromise. The techniques include cervical epidural, bilateral superficial and deep cervical plexus block, which can be performed under monitoring. One should know about the complications of regional anesthesia. In thyroidectomy, they are risk for spinal and epidural injections, vertebral artery puncture, and bilateral phrenic nerve block. Emergency surgery in hyperthyroidism is usually done when we have a life-saving, limb-saving, or organ-saving procedure. The management includes intravenous dexamethasone 2 mg 6 hourly, which reduces the hormone release and peripheral conversion of T4 to T3. Beta blockers like propranolol, esmolol is used to titrate the heart rate, and which can also go with antithyroid drugs via the NG tube. Removal of the thyrotoxic gland does not mean immediate resolution of the thyroid toxicosis. One should always use beta blocker therapy in the post-operative period. Antithyroid drugs can be discontinued after the endocrinologist advice. Now, coming to the anesthetic concerns in hypothyroidism, these patients, they have increased sensitivity to neuromuscular blocking agents. They are sensitive to the depressant effects of the inhalation agents and opioids. They have a slow metabolism and excretion of drug. They are in the state of hypometabolic state. So always we should go for slow IV induction. Hypodynamic circulation is there. So chances of hypotension are there in these patients while induction. There is always pre-existing myocardial depression depending upon the severity of the hypothyroidism. They are more prone to go in hypothermia and GI hypermotility. They sometimes have a prolonged anesthesia recovery, again depending upon the severity of the hypothyroidism. Coming to myxoedema coma, it's a rare life-threatening complication of long-standing and neglected hypothyroidism. It includes triad of altered mental status, which is abrupt in onsets. There's a risk of hypothermia, hypothyroidism, and other abnormalities like hypoventilation, hypoglycemia, hypotension, hyponatremia, and hypomotility of the gut. These patients should always be considered high risk, and they should be stabilized before taking further surgery, especially for this emergency surgery. Elective surgery is not indicated in these patients till they are stabilized. Supportive measures and treating the precipitating cause is of utmost importance. Airway protection and ventilation, treatment of hypotension, hypoglycemia, and hypothermia is must. Thyroxine administration, oral or IV in the dose of 300 to 500 micrograms per day should be started in the preoperative period, which is followed by the maintenance dose of 50 to 200 micrograms per day along with the steroids. Endoscopic thyroidectomy is performed in few centers in India. It can be done either by the cervical approach or by the extracervical approach. Cervical approach is usually preferred via videoscopic assisted thyroidectomy in the case of smaller thyroid swellings. Extracervical approaches can be by your axillary route, oral vestibular approach, or by the natural orifice transilluminal endoscopic surgery. These are the two pictures of extracervical approach. One is ipsilateral breast axillary approach on the left side, and one is axilla bilateral breast approach on the right side. On the left side, we have a transoral approach picture, and on the right side, we have a post-auricular approach picture. So coming to the post-operative complications, thyroid surgery is not without complications, and usually the complications which occur, they usually occur in the post-operative period. So there should be intense monitoring in this phase. The complications can be early complications like neck hematoma, laryngeal edema, recurrent laryngeal nerve injury, superior laryngeal nerve injury, tracheomalacia, pneumothorax, especially in case of a large thyroid where we also go for radical neck dissection, thyroid storm. Late complications includes hypoparathyroidism, hypocalcemia, and hypothyroidism. Thyroid storm is a life-threatening complication and has a high mortality of 20%. Although it is rare due to the widespread use of antithyroid drugs and beta blockers, it may occur intraoperatively or postoperatively 6 to 48 hours later. It is usually precipitated by the inadequate preoperative treatment, sudden release of the T4 or T3 into the circulation. And the causes under anesthesia are inadequate depth of anesthesia, hypoxia, hypovolemia, or surgical manipulation. The clinical presentation under anesthesia includes increased bleeding, increased end-tidal carbon dioxide, early exhaustion of the soda lime, increased temperature, tachycardia, hypertension or tachyarrhythmias or bradyarrhythmias, CHF or shock. But when the patient is awake, the patient may present with restlessness, extreme irritability, delirium, seizure, coma, tachypnea, vomiting, abdominal colic, or increased sweating and dehydration. Management of thyroid storm is supportive as well as definitive. Supportive treatment is done by increasing the depth of anesthesia, increasing the oxygen delivery, treating the pyrexia using cold IV fluids and using the cooling mattresses, ice packs, correction of the fluid and electrolytes and acid-base imbalance. It's a state of a circulatory shock. So IV administration of the direct vasopressors like phenylephrine is needed. Atrial fibrillation using beta-adrenergic blockers and digitalis is done. Dexamethasone in the dose of 2 milligram 6 hourly or cortisol 100 to 200 milligram 8 hourly is given. Antithyroid drugs is a definitive treatment which includes propylthiouracil in the dose of 200 to 400 milligram 8 hourly. Tachycardia is treated by the beta blockers, esmolol infusion 100 to 300 microgram per kg per minute or propranolol 0.5 to 1 milligram IV every 1 to 5 minutes. Neck hematoma is another complication which occurs usually after 6 hours post-operatively. The symptoms are neck swelling, dyspnea, stridor, leading to acute airway obstruction, and the management includes removal of the sutures immediately. So there should always be a suture tray besides the patient's bed. It may require securing airway, or patient may be taken to OT for the evacuation and hemostasis. Difficult airway cards should always be available in the post-operative area. Laryngeal edema is another complication, and it occurs because of the multiple intubation attempts and because of the traumatic intubation. Large hematoma causing venous obstruction to the laryngeal vessels can lead to stridor or airway obstruction, and the management includes humidified oxygen, steroid, adrenaline nebulization, and it may also require intubation sometimes. Nerve injury like recurrent laryngeal nerve injury or superior laryngeal nerve injury can be transient or permanent. The incidence is more in large goiters, especially with malignancy or where we have reoperations. The cause is due to traction, transection, entrapment, or nerve injury and ischemia. Bilateral recurrent laryngeal nerve injury, the incidence is 0.4%. And the nerve injury, they follow the Siemens law. That is, in partial injury, abductor fibers are the first to be affected as compared to the adductor fibers. In unilateral incomplete palsy, only abductors are paralyzed as shown in the figure on the left side, and the vocal cord assumes median position. Voice is unaffected and the patient may remain asymptomatic. In the complete palsy, both abductors and adductors are paralyzed. Vocal cord assumes paramedian position and there is hoarseness of voice which is present. In complete palsy, recurrent laryngeal nerve palsy, it could be either partial or complete. In partial injury, both vocal cords assume median or paramedian position with severe respiratory dyspnea and stridor. And in complete injury, both vocal cords assume cadaveric position, inspiratory stridor, along with a high risk of aspiration. So management includes immediate endotracheal intubation with a smaller tube, followed by the emergent tracheostomy. Superior laryngeal nerve palsy, the incidence is 3.5%, and external branch of the superior laryngeal nerve is the commonest injury, leading to the paralysis of the cricothyroid muscles and resulting voice alteration, which is of significance, especially in the professional singers. Injury to the internal branch of the superior laryngeal nerve results in dysphagia due to the deranged swallowing reflex. Coming to hypocalcemia, the incidence is around 6 to 30%. Signs and symptoms, they usually develop after 24 to 96 hours post-surgery. The cause is because of the vascular spasm to the parathyroid muscle or due to the inadvertent surgical removal of the gland. The presentation of the patient depends upon the severity of hypocalcemia. It could be either laryngeal stridor or in the form of tetany, depending upon the severity. The two signs, Trozier sign and Chevostek signs, can be elicited bedside. Trozier sign includes the carpopedal spasm, which is precipitated by the B peak of inflation 20 millimeter Hg above the systolic pressure, and Chevostek sign is elicited by the facial nerve twitching in response to the tapping over the facial nerve. The management of hypocalcemia depends upon the serum calcium level. If the serum calcium level is more than 2 millimoles per deciliter, we can go for oral calcium and vitamin D supplementation. If the serum calcium is less than 2 millimoles per deciliter, intravenous calcium supplementation can be given along with the serial monitoring of the serum calcium levels. So coming back to my case, my concerns in my case were functional status of the thyroid, intubation concerns, perioperative blood loss, nerve injuries, tracheomalacia, vocal cord palsy, our extubation plan, hypocalcemia, thyroid storm, and hematoma, which I have already covered. Thank you very much and best of luck for your exams.
So thank you, ma'am. We are finally able to have your lecture in your voice. We know that you are busy and we are trying to have the video, and video was not playing well. So thank you so much for your time, and because you are already in the OT. So we have Professor Suren Singh to please conclude the session.
Thank you, Dr. Sandeep.
Thank you, and thank you. So we have Professor Suren Singh, sir. Okay. So after this ending of thyroid case, we have another case that is very common case and very important case in day-to-day practice, is approach to a case of diabetes mellitus. And for this session, we have Chairperson Dr. Amit Rastogi, who is Associate Professor, Department of Anesthesia at SGPGI IMS. We have three professors from KGMU, Professor Sobhna Jaffa Madam, and Professor Rajni Kapoor Madam, and Professor Jyotsna Agarwal Madam. Madam, all you are here?
Dr. Sandeep Sahu, can you hear me?
Sir.
Dr.
Yeah, sir.
Sahu. Dr.
हाँ सर बोलिए.
Can you hear me?
हाँ सर, आपकी आवाज आ रही है सर. सुरेंद्र सिंह सर बताइए सर.
हाँ जनाब, ऐसा है कि of Dr. Veena, I would like to ask one question.
Sir, please.
If she is still online, I like her to answer this. She mentioned that in bradyarrhythmias, atropine is to be avoided. For treatment of bradyarrhythmias, atropine is to be avoided. Then what is to be used?
Dr. Veena is there? Yes. Dr. Veena ma'am?
I think she is offline right now.
आप ही आंसर दे दीजिए सर, सही क्या है?
Maybe I will answer this myself. Maybe what Dr. Veena meant was that instead of atropine, glycopyrrolate would be a better choice for treating bradyarrhythmias.
Definitely, sir.
Okay, now I am going off. Thank you.
Thank you, sir. Thank you, sir. Thank you so much. So I request chairperson to open their mic and let me introduce the speakers. We have Dr. Vansh, who is working here with us at SGPGI as assistant professor, and he will take the approach to a case of diabetes mellitus, especially the preoperative part. And after that, we have Professor Uma Srivastava Madam. Everybody knows Professor Uma Srivastava Madam because he has been associated with quite long from SN Medical College, Agra, and now presently she is also the president of ISA UP, and now she is working at professor and I think head at FI Medical College, very near to Agra. So okay. So chairpersons, are you here? So it's over to Dr. Vansh.
Good evening, everyone. I'll be discussing very common and very commonly asked and very important topic, an approach to a case of diabetes mellitus. I'll be dealing with the preoperative assessment part, and the intraoperative part would be dealt with Professor Uma ma'am. So, a patient presenting to you with for a elective or an emergency surgery if he happens to have hyperglycemia, the preoperative hyperglycemia, it can be due to a type 1 diabetes or type 2 diabetes. But most importantly, one other cause is stress-induced hyperglycemia. Of all the three causes, like type 1 diabetes, type 2 diabetes, stress-induced hyperglycemia carries much more adverse prognosis. For example, if a patient is an undiagnosed diabetes, and on listing he has on preoperative assessment he has increased blood sugars. So this is known as stress-induced hyperglycemia. It carries a much more adverse prognosis. And more so if a patient has a normal preoperative HbA1c, and on preoperative blood glucose charting his blood sugars are high, that also carries a adverse prognosis. Type 1 diabetes is encountered in found in 10% constitute 10% of the diabetics, and type 2 diabetes constitute majority of the rest of the diabetics. So you more often than not you will be encountering type 2 diabetics. This is the diagnosis of dysglycemia according to the ADA and WHO criteria. All these things are available in the standard textbooks. Please go through it. Nothing much new about it, but please go through it. It's important. What is the pathophysiology behind perioperative dysglycemia? It's an imbalance caused by increased glucose output by the liver, caused by increase in stress hormones like catecholamine, glucagon, cortisol, growth hormones, and increased insulin resistance. Perioperative period is a phase which is marked by increased insulin resistance, because free fatty acids, they inhibit this action of insulin. They inhibit glucose uptake. So this results in a relative insulin resistance. So this imbalance results in hyperglycemia and is associated with, most importantly, with free radical generation, superoxide generation, and endothelial, which this endothelial dysfunction and superoxide generation are primarily responsible for all the macrovascular and microvascular complications associated with diabetes. It's not only the hyperglycemia which causes the problem, it's the glycemic variability. Hyperglycemia as well as hypoglycemia are responsible for endothelial dysfunction and damage, and responsible for microvascular and macrovascular complications. So why patients with diabetes have higher perioperative morbidity and mortality rates? First, they are associated with multiple comorbidities. Second, surgical site infections, hyperglycemia and hypoglycemia, which more often than not are iatrogenic. Then diabetic ketoacidosis. It can be even hospital acquired also. Insulin misprescription and maladministration, very commonly found in hospital setups. IV insulin infusions and complex polypharmacies. So whenever a diabetic patient is listed for an elective or an emergency surgery and presents to you for a pre-anesthetic evaluation, a thorough and a focused preoperative assessment is required. Few pertinent questions which needs to be questioned are these. First is, you should know type of diabetes mellitus, which is very important. Secondly, it's the duration for which they have been having this ailment. But please mark that there is a difference between detection and actual onset of the disease. On which medications this particular patient is, whether he's on OHA or he or she is on insulin. What is the adequacy? What is the adequacy of glycemic control? You have to look at the HbA1c and blood sugar chartings. You don't have to ask for a repeat HbA1c which has been done in the last 3 months. You have to look for the presence or absence of whatever of microvascular and macrovascular complications and their current status, whether it is compensated or decompensated. And you also have to look whether the patient has other comorbid conditions like hypertension or any other comorbid conditions like asthma and all. So you have to see that whether, apart from diabetes, whether they are in controlled state or not. And also you also inquire about any previous hospitalization because of diabetes, like DKA or non-ketotic hyperosmolar coma. You have to also ask these pertinent questions. And most commonly is asked this during airway evaluation is this prayer sign and palm print test, because diabetes and long duration diabetes particularly associated with glycosylation proteins. It can result in fixation of these atlantoaxial joints and all. So by doing this prayer sign and palm print test, you can assess whether neck mobility is there, whether it will hamper intubation during the induction time. And more so, since hyperglycemia and particularly uncontrolled diabetes, it is associated with the glycosylation of proteins. It's a frozen shoulder and frozen knees. They are common ailments. So you have to ask the patient about the range of movements of the shoulders and knees and other joints. So because it is important for during positioning of the patient. These are the major complications of diabetes, the macrovascular and microvascular. All of you must be knowing about this. Of all the complications of diabetes, the two which are of most important for an anesthetist, most of our perioperative phase, is diabetic nephropathy and neuropathy. Neuropathy can be peripheral neuropathy and autonomic neuropathy. Peripheral neuropathy has patient will complain of tingling, numbness, paresthesia. Please ask about the medications which he or she is taking. And it has importance for positioning implications during operative procedures. And second one is the autonomic neuropathy. So two important complications of diabetes which need to be looked into are neuropathy and nephropathy. Please do focus on this during preoperative evaluation. So what are the basic preoperative investigations? Blood glucose concentrations, HbA1c and blood glucose charting, urine analysis for albumin and ketones, hemoglobin, blood urea, serum creatinine and electrolytes, and ECG. Rest of the investigation course is decided by the history, physical examination, and clinical evaluation. But these are the basic ones which definitely have to be done. Now, one of the complications out of the two which we need to look into is diabetic nephropathy, now known as diabetic CKD. Now, diabetic CKD occurs in 30% to 50% of diabetics. Diabetes is an independent risk factor for development of acute renal failure in the perioperative period. This may even develop in the absence of previous renal dysfunction or in patients with diabetic CKD. Microalbuminuria, macroproteinuria are ominous signs. 24-hour urine microalbumin is unreliable and cumbersome. Instead, now, what they prefer is urine microalbumin to urine creatinine ratio and an estimated GFR. Whereas apps are available, you can calculate the GFR. These are essential during major surgery or poorly controlled glycemia. So if a patient presents for a major surgery as a poorly controlled glycemia, please do go for these tests. And now what we commonly known as microalbuminuria is known when this ACR ratio is between 30 to 300 milligram per gram. It's labeled as moderate albuminuria, previously known as microalbuminuria. The lethal triad is microalbuminuria, hypertension, and renal dysfunction. So if in preoperative assessment, if you find microalbuminuria, hypertension, renal dysfunction, you need to investigate the patient further before heading for the surgery. Now coming to the central dysautonomia. Dysautonomia is actually affects commonly two systems. Most commonly, one is the GI autonomic system and then the cardiovascular system. If GI system is most commonly manifested by gastroparesis. It is present in 30 to 50% diabetics. Duration and degree of glycemic control have an important bearing on this. Patient usually complains of anorexia, nausea, vomiting, abdominal pain, bloating, and early satiety. So during preoperative evaluation, please definitely ask about these symptoms. Such patients should be considered as full stomach, and rapid sequence induction should be the preferred modality. I'm telling you this because any damage to one of the autonomic part of the autonomic nervous system is accompanied by damage to the other, like this. Like the heart disease. When I talk about diabetes and heart disease can be broadly here, it refers to silent myocardial infarction, diabetic cardiomyopathy, and cardiovascular autonomic neuropathy. During preoperative assessment, you should look for the following risk factors: smoking, hypertension, dyslipidemias, duration of diabetes, glycemic control, and more importantly about microalbuminuria, macroproteinuria, and renal dysfunction. Approximately 75% of diabetic patients die from complication of atherosclerosis. Silent myocardial ischemia can be found in 30 to 50% of asymptomatic diabetics. Risk of congestive failure is 2 to 3-fold higher in diabetic patients. And mortality after an episode of CHA is 10 times higher in diabetic patients. Prevalence of cardiovascular autonomic neuropathy increases with the duration of diabetes and if glycemic disequilibrium is long-lasting. Most commonly, it is manifested by baroreflex dysfunction and disturbed heart rate variability. It's the parasympathetic innervation which is involved in the initial stages and is marked by respiratory variations in heart rate. So during a pre-operative evaluations, if certain, you don't go for assessment of cardiovascular autonomic neuropathy in all the patients. It's not possible. It is cumbersome. It has a battery of tests to be performed. But definitely, if risk factors, as mentioned in the previous slides, are present, please do assess the patient. And most earliest test is, which can be done, is respiratory variations in heart rate. Patients, because of cardiovascular autonomic neuropathy, they get symptomatic only in the advanced stages. These are marked by resting tachycardia, orthostatic hypotension, postprandial hypotension, and recurrent hypoglycemia. So please do ask about these symptoms. Risks linked to cardiovascular autonomic neuropathy include silent myocardial infarction, an increase in cardiovascular events, risk of sudden cardiac death secondary to cardiac rhythm disorders like prolonged QT more than 400 milliseconds, and absence of nocturnal dipping in blood pressure. Ambulatory BP monitoring can be done in certain patients. And these events are associated with adverse perioperative hemodynamic conditions, and they require intense perioperative monitoring, extending into the post-operative course also. This is the Ewing and Clark criteria for testing this cardiovascular autonomic neuropathy. 3 tests are linked with the parasympathetic nervous system, which involve the heart rate variation to Valsalva maneuver, standing, and deep breathing. And 2 are blood pressure responses to standing and sustained hand grip. Please go through them. They can be asked in Viva or in your exams. How will you assess the adequacy of blood sugar control, and when you will define whether the blood sugar control is adequate or whether it is inadequate, and whether you should postpone a surgery, most when elective surgery. The Joint British Diabetes Society guideline, they advocate postponement of elective surgery if HbA1c is more than 8.5. While the SAMBA guideline, they advocate postponement of elective surgery if HbA1c is less than 7%. At first sight, it might appear that there is why there is so much variation, but you should look into the society which is giving this guideline. SAMBA is for Society for Ambulatory Anesthesia. They are for ambulatory procedures. So they recommend much more tighter sugar glycemic control so that the patient can be discharged on the same day. So they have stuck to HbA1c more than 7%. They have as a cutoff. But Joint British Diabetes Society guidelines, it's a more generalized guideline, and they are much more liberal with the HbA1c values. And so they have advocated on 8.5%. Higher the HbA1c value, higher will be the more difficult will be the blood sugar control in the perioperative phase. More adverse effects of inappropriate blood sugar control will be encountered. So it is important for risk quantification and prognostication. And NHS diabetes guidelines suggest that optimize preoperative HbA1c if it is safe to do so. It's an important statement. What should be the goals of perioperative management? These are very important, and there's a recent change in the recent by recent meta-analysis and studies. But what should be the goals of perioperative management? We should minimize the period of fastings of diabetics. We should minimize interruptions of domiciliary regimen. Whatever regimen they are taking at home, we should try our best to minimize their interruption. We should go for early post-operative resumption of oral intake. We should prioritize the operative list. The diabetics should be listed in earlier half of the day. That's what I mean to say. And we should minimize the use of GIK infusion of VR, or we call it as variable rate IV insulin infusion. Because if you are prolonging the period of fasting, that is, if it's going for more than 6 to 8 hours, you'll have to give a glucose substrate or an insulin substrate to a diabetic. So that would, if you are prolonging the fasting, you have to use IV infusions, IV insulin infusion, which naturally are associated with adverse events like hypernatremia, hyponatremia, hypoglycemia, even hypoglycemic coma or death have been reported to them. What should be the consideration for designing an optimum preoperative glycemic management plans? Type of diabetes patient has, what is the domiciliary medication, what is the frequency of its intake, nature of surgery, invasiveness of surgery, what will be the duration of preoperative fasting and postoperative fasting, and current metabolic state of the patient. Diet, and how will you go for a preoperative optimization glucose? It involves dietary management, and along with that, we can either go with OHAs, so subcutaneous insulin, or even IV insulin. This is the classification of oral hypoglycemic agents. Please go through it. The recent drugs are these DPP-4 inhibitors, sitagliptin, temigliptin, saxagliptin, and another one is the SGLT, sodium glucose cotransporters 2, that can be asked because these are the latest drugs. Others, common power horses of OHAs are the metformins, glimiprides, and all. Please go through this mechanism of actions, half-life, and adverse effects. This is the classification of insulin and pharmacology. We all know this is either short-acting insulins, like short-acting and rapid-acting insulins. Then there is the intermediate-acting insulins. Then there's the long-acting insulins. Please remember that short-acting insulins and rapid-acting insulins are known as prandial insulins or correctional insulin. Prandial insulin means to be taken along with meals, before meals. And intermediate insulins like NPH and long-acting insulins like glargine and determin are labeled as basal insulins. Basal insulins are basically peakless. They don't have a peak. Intermediate acting, they have a peak, but long-acting ones, they don't have a peak. And then there are the mixed formulations. Now, these are the non-insulin injectables. Please go through them. Exenatide is the most commonly used one. These are GLP-1 like glucagon, like peptide. Please go through their pharmacologies. These are the subcutaneous insulin regimens which are commonly administered to the patient. Basal insulins with OHA, basal plus insulin. Basal insulin is usually taken once in a day or twice in a day. And along with this, correctional insulin, if blood sugars goes out of on a reading above 180, then you give a correctional dose of insulin. And then there is a basal prandial correctional. This is the most commonly one. Basal insulin, prandial insulin is given before meals, and correctional, if it other than this, if it goes out of range, you can go for correctional insulin. Now, this is how the OHA should be given on the day and the day before surgery. Out of all these, word of caution for this SGLT2 inhibitors. Now, this is a new class of OHAs. This canagliflozin and repagliflozin. These have to be stopped. Now they are being commonly prescribed, and they have to be stopped 24 to 48 hours prior to surgery, because they have, if they are continued right up to the day of surgery, they have been found to be associated with euglycemic diabetic ketoacidosis. Other drugs are thiazolidinediones, metformin, secretagogues, and DPP-4 inhibitors. Metformin has to be stopped 24 to 48 hours prior to surgery, and DPP-4 inhibitors, they can be taken right up to the day of surgery. This is the insulin prescription on the day before surgery. So, as far as insulin glargine is concerned, it can now on the night before, 80% of the usual dose can be administered, and other than that, this intermediate acting insulin, 80% of the usual dose, and Lispro short-acting insulins, they have to be taken in the usual dose. And this is the insulin prescription on the day of surgery. On the day of surgery, glargine, 80% of the usual dose has to be given. Intermediate acting insulin, 50% of the usual dose if blood glucose, fasting blood glucose is more than 120. And short acting has to be stopped. Thank you.
So we will continue. Madam, can you share the slides?
Should I share my slides or you will present my?
आप अपनी तरफ से स्लाइड शेयर करेंगी तो आप अपने हिसाब से चला सकती हैं आगे पीछे।
अच्छा, ठीक है, लेकिन वो वहां पे आ जाएगी, आई डोंट नो, मैं कर देती हूँ अपनी तरफ से।
हाँ, आप शुरू करिए, मैं बताऊंगा ना आपको। हम यहाँ से देख सकते हैं। आप अपना माइक ऑन करिए और अपना वीडियो ऑन करिए पहले तो।
हाँ, माइक ऑन कर दिया।
तो जी, स्लाइड आपकी आ रही, परेशान ना होइए।
आ गई?
बस आप तो पेठा भेज देती हैं आगरा से, तो वो भी आ जाएगा मैडम।
एक तो डायबिटीज पे बुलवा रहे हो, ऊपर से पेठा मांग रहे हो।
शुगर फ्री पेठा। बात है कि टेक्नोलॉजी इतनी एडवांस हो गई है कि आपने वहां से पेठा दिखाया और हमको लगा हमने खाया।
थैंक यू सो मच। कैन आई स्टार्ट नाउ? कैन आई स्टार्ट नाउ? ऑन कर दिया और पता नहीं क्या क्या ऑन कर दिया, वीडियो और ऑन कर दिया, सब कुछ कहाँ से आ गया।
Everything is done. Just stopped.
Hello.
Madam, please.
Can I start now?
इधर कुछ हो गया है आपकी उनसे कभी बात हुई है कुछ हैंग कर रहा है
बोलेंगे ना
हाँ शुरू करिए आप शुरू करिए आवाज आ रही है
हाँ ठीक है ओके थैंक यू डॉक्टर संदीप and the team and Dr. Vansh also. Good evening to everyone. I think you can hear me now. I think Dr. Vansh has very beautifully covered the preoperative part. Just to summarize again, the acute adverse consequences of hyperglycemia are osmotic dehydration and hypovolemia, acidemia and electrolyte imbalance. Consciousness may be altered, especially in type 2 patients. There is increased proteolysis and lipolysis due to deficiency of insulin. There is worsening of post-traumatic CNS injury, and this is basically due to intracellular acidosis and hypoxia-induced neuronal edema. There are increased chances of infection due to impaired immune response, and it has been seen that the infective complications contribute about 60% of all the post-operative complications in diabetic patients, and about 25% post-operative deaths are due to these infective complications. Some special problems related to anesthesia in diabetic patients are that the physiological age of these diabetic patients is more than the actual age. And the stress response to surgery or anesthesia and very much leading to endocrine response leading to release of many hormones, cortisol, glucagon, all anti-insulin hormones, so leading to hyperglycemia. There are problems due to comorbidities, which are very common, and problems are due to autonomic neuropathy, problem of difficult intubation, and post-operative infection and poor neurological outcome. Nerve injury is common in patients with peripheral neuropathy, and this is more obvious during positioning and regional anesthesia. You all do PSE of the patients when you get the patient for elective surgery, but you must consider some special points in these patients. First, you must know the duration and type of diabetes, medication and history of hypoglycemia attacks or any history of hospitalization. Now, secondly, level of glycemic control and need of any preoperative intervention in the treatment strategy, type and duration of surgery, whether there is a minor, major, elective, emergency. It is what are the comorbidities? What is the status of airway? Will the patient have a difficult airway? And the complications, especially cardiovascular, renal, and autonomic. And you must also think that will the patient require ICU care in the post-operative period? And can the patient manage glycemic control after discharge? There are many, actually Dr. Vansh has given many things about this, but just for our postgraduate students, you should have a definite answer to, you don't quote so many things. So usually elective surgery is postponed when the HbA1c is more than 9%. And if the patient is in compromised metabolic state, you should definitely postpone the surgery. The ideal blood glucose level on the morning of surgery should be less than 180 milligram per deciliter. If morning blood glucose level is more than 270, delay the surgery and you can achieve rapid control with IV insulin if you want to conduct the surgery. The target perioperative blood glucose level for most surgical patients is between 120 and 180 milligram per deciliter. Ideally, the HbA1c of the diabetic patients for elective surgery should be between 6.5 and 7. as if it is increases, the chances of complications are more. But it has been seen that less stringent levels may be accepted in patients with chronic long-standing diabetes or elderly patients or with multiple comorbidities. But because in those patients, the chances of hypoglycemia are, they usually have attacks of hypoglycemia in the past. So they can, the less stringent level may be accepted. Otherwise, 7.5, 6.5 to 7 is the optimal level. And blood glucose between 120 and 180 is the optimal. What should be the choice of anesthesia? Actually, there is no evidence that the choice of anesthesia affects the outcome of our diabetic patients. And it actually depends upon the site of the surgery, duration surgery, patients and anesthetist choice, and also the institutional practices or individual practices. But there are some advantages of central neoexit block. They block the stress response to some extent. There are less chances of aspiration if the patient is of gastroparesis, has gastroparesis, less PONV, so oral resumption is earlier, hypoglycemic awareness is there, and difficult airway is avoided. But the few disadvantages are that these patients have more hypotension after giving spinal because there is failure of the cardiovascular compensatory responses. So there is more hypotension. So you should be careful. And you should reduce the doses of local anesthetics. The chances of infection are high. So you should be very careful, especially after epidural. How to manage diabetes type 2 patients for minor outpatient surgery, who is well controlled on OHA. The patient should take his or her normal dose in the night before surgery, in the night before surgery, and don't know OHA in the morning of surgery. And after surgery, oral intake should be started as soon as possible along with OHA. But if the patient is not able to eat properly, then reduce the doses of OHA. And at any stage, if the blood glucose level goes above 200, it is better to give subcutaneous short-acting insulin with monitoring, frequent monitoring. Ideally, the diabetes type 2 patient requiring major surgery should ideally be switched over to insulin, because often the oral intake is delayed, especially after GI surgery or other surgery, abdominal surgery. So it's better to switch over to insulin. Now, which patients require insulin in the perioperative period to control the glycemic control? Here, all type 1 patients should receive insulin. All type 2 patients who require major surgery and delay in oral intake is expected. The patients who are on multi-drug therapy, the patients who are poorly controlled, and the patients who may require ICU admission in the post-operative period. What should be the pre-operative orders? First in the operation list, that is very important, so that the period time of NPO is reduced and the stress is also reduced. Longer times of NPO, about 8 to 10 hours, are usually prescribed in patients who have gastroparesis. As Dr. Vansh already said, that 30 to 40% patients have gastroparesis, so the NPO period should be prolonged in these patients. Obtain fasting blood glucose in the morning of surgery. And these patients should be pre-medicated with SU blockers, anxiolytics, and gastric prokinetics. I think this he has covered, but few words about metformin. Metformin should be stopped 1 to 2 days before surgery, as it can cause lactoacidosis. Although it is rare, but the chances are high, or risk is high in patients whom you expect to have a more prolonged period of hypotension during surgery, or patients who are to be used, who are to be given IV contrast dye. In these patients, the chances of lactosis is high, and the patient who are alcoholic or have hepatic and renal dysfunction. In these patients, should be stopped for 1 to 2 days before surgery. And the metformin should be started only after the normal renal function has been restored. And especially in patients where IV contrast dye has been given, it is better to start metformin only after you obtain a normal creatine level and normal urine output. Thiazolidine, these all are stopped in the morning because the chances of cardiac events are high in patients who are receiving rosiglitazone, pioglitazone. Sulfonylurea should also be stopped because they block potassium ATP channels, which are responsible for ischemia and anesthesia-induced preconditioning. GLP agonists delay the gastric emptying, so they should be also stopped. GPPU fermenters can be continued till morning of surgery. What about the patients who are controlled on insulin? Ideally, the patient receiving long-acting insulin should be switched over to intermediate-acting. And if the patient is receiving separate injection of short-acting and intermediate-acting or long-acting, then in the evening before surgery, the usual dose of short-acting insulin should be given, but reduce the dose of long-acting by 20%. And in the morning of surgery, omit short-acting and reduce the dose of long-acting by 50%. Patients who are receiving pre-mixed 30-70 or other preparations, reduce evening dose by 20% and omit morning dose. Patients on insulin pump, reduce overnight dose by 30%. Though covered by Dr. Vansh, still I just to summarize or I'll go for a few points. Consider IRSI, rapid sequence induction in patients with gastroparesis. Avoid linger-rectate solution for food management as it is a substrate for neoglucogenesis. Careful positioning is very important in patients with peripheral neuropathy, and padding of the pressure points must be done. For example, heel should be should be positioned in a very nice way. And with patients on with autonomic neuropathy, there is increased hemodynamic liability in response to induction of anesthesia, in response to positive pressure ventilation, in response to positioning after spinal anesthesia and blood loss. So you have to be very careful. And the patients who have absent or heart rate variation, who have absent or deranged heart rate variation, have very high chances of developing ventricular arrhythmias, silent MI or sudden death. So you should be careful. There is a possibility of difficult airway. Lower doses should be used in central venous blocks, and frequent monitoring of blood glucose is very important. For intraoperative hyperglycemic control, there are there are many methods, but 2 or 3 are most commonly used. One is Alberti regime, Velo regime, and continuous separate infusion of glucose and insulin. This Velo regime was developed in our own country and is very good. For this, you obtain fasting blood glucose at 6 a.m. on the day of surgery, omit OHA or insulin, and mix 5 units of regular insulin in 5% dextrose in water and start at the rate of 100 ml per hour. If blood glucose is less than 100, stop insulin infusion and give measured volume of 100 ml of dextrose in water, 5% dextrose in water by a burette. And for every 1 to 50 milligram of blood glucose above 100, add 1 unit of insulin to 100 ml of 5% dextrose in water in a measured volume burette and give at the rate of 100 ml per hour. And during this regime, blood sugar should be measured every hour, and this regime is continued till patient leaves PASU. The advantages of this regime are that is simple, user-friendly, and no need of infusion pumps. Burette is enough for this giving. The Albertese regime, I think the oldest one, still used at some places. Omit morning dose and obtain fasting blood glucose. Mix 10 units of short-acting insulin and 10 millimole of potassium chloride to 500 ml of 10% dextrose in water. This is called a 10-10-10. Just to remember how to make 10-10-10. And start this infusion at the rate of 100 to 150 ml per hour. Measure blood glucose every 2-3 hours. This is safe, simple, and no need of infusion pump. But the problem is that this fine control of blood glucose is difficult by this. Now coming to continuous infusion of insulin and glucose by separately. To make the infusion of insulin, 100 units of insulin are dissolved in 100 ml of normal saline, thus making 1 unit per ml. To calculate initial hourly rate of insulin, total daily dose of insulin is divided by 24. Or you can use another thing, find out the morning blood glucose level divided by 150. Or if the patient is for CABG, is on steroids, or is pregnant or requires neurosurgery, then you may divide this morning blood glucose level by 100. Or most simple is that 0.02 units per kg per hour, or 1 to 1.4 units per hour in most patients is very good for this, for majority of the patients. And regular insulin sliding scale, RISS, can be added to maintain target blood glucose that you all know between 120 to 180. Or alternatively, you may reduce the insulin infusion or increase the ideal continuous infusion of insulin should be initiated at least 2 hours before surgery, along with infusion of 5% dextrose in NBI2 saline at the rate of 100 to 150 ml per hour. You must have heard about tight control regime or intensive insulin therapy. What is this? This refers to control of blood glucose level within narrow range of 70 to 110 milligram per deciliter. There has been some evidence for better outcome in CABG, pregnancy, or neurosurgery or ICU patients, but hypoglycemia was very common in this technique, and it requires frequent monitoring and is difficult to continue in the post-operative period. So this technique is not generally recommended. Some points you must remember for a diabetic patient, that 1 unit of insulin lowers blood glucose level by 25 to 30 milligram per deciliter. 1 unit of insulin neutralizes 3.25 grams of glucose, and 1 ml of 50% dextrose in water increases blood glucose by 2 milligram per deciliter. Minimum 5 to 10 grams glucose per hour, minimum 150 grams, is needed to prevent hepatic production of glucose, lipolysis, and proteolysis. Minimum 150 gram glucose must be given. Insulin requirement is higher in patient undergoing CABG, receiving steroids, hyperalimentation, vasopressors, having infection, or when the BMI is more than 35. And level of glucose in capillary and arterial blood is 7% higher than venous blood, and whole blood glucose is 15% lower than plasma or serum. Coming to the post-operative management, insulin glucose infusion should be continued at least up to 2 hours after surgery. And OHA and normal insulin regime the patient was following in the preoperative period can be started with first meal. But one thing is important, that 1 hour overlap is essential between stopping IV insulin and starting subcutaneous insulin. For insulin, and what should be the dosage of insulin? Either you can use the patient's own regime, which was followed initially before surgery, or it can be calculated by dividing patient's previous day total insulin dose by 3 and give it subcutaneously with meals. That means before breakfast, before lunch, and before dinner, after measuring blood glucose level. Adequate anesthesia is important for these patients. PONV treatment is mandatory because it may delay oral resumption of fluids of diet. Now coming to, you may often get a patient of diabetes for gangrene foot or debridement of a ulcer with a diabetic patient. Usually these patients may be in a decompensated state, the patient may be in DK or HHS, or may not be in the condition. But for those patients, what we will do quick PSC with special point related to DM, as already told by Vansh. And you should know the type and doses of anti-diabetics, whether patient is on insulin or patient is on oral OHA. And when did the patient take last meal and the medication? You must find it out. You should also inquire about any other concurrent illness or medication. Hemodynamic status of the patient should be known. Is there any fever? Find out the urine output and level of consciousness. And find out current blood glucose level, urinary ketones, electrolytes, bicarbonate, pH, etc. And if the patient is in the decompensated metabolic state, then surgery should be delayed at least for 4 to 6 hours for management. This is a clinical finding, I think you can see from the book. Basic difference between DK and HHS is that patient of DK is absolute deficiency of insulin, leading to hyperglycemia, ketonemia, and dehydration. And in HS patient, hyperglycemia, mental status may be disturbed, and this the patients has a very viscous blood and high osmolality of the blood. This is a biochemical criteria you all can see from the book. What is the principle of management of DKHHS? Confirmation of diagnosis by clinical findings and laboratory findings, correction of dehydration, hyperglycemia, electrolyte imbalance, and acidosis, and frequent monitoring. Finding and treating the cause which has precipitated this condition. Surgical patients, most likely the gangrene foot, and the medical patient, usually the cause may be pneumonia, myocardial infarction, pregnancy, any other cause may be there. In the surgical patient, most likely the cause is diabetic gangrene. It is important that delay of surgery until complete correction of DKHS is unwarranted, as surgical condition can further lead to metabolic derangement. So do not wait for complete remission of the condition. Once a stable level is achieved, then you can go for surgery. For management, IV fluids are the most important. Give 1 liter of normal saline over first 30 minutes, then 1 liter over 1 hour, then 1 liter over 2 hours, then 1 liter over 2 to 4 hours, followed by N/2 saline at the rate of 250 to 500 ml per hour. When the blood glucose is less than 270, then start 5% dextrose in water at the rate of 1 liter 8 hourly. Monitor blood pressure, urine output, and CVP if necessary. The IV insulin, short-acting insulin is used, usually 0.1 unit per kg as bolus, followed by 0.1 unit per kg per hour as infusion. If blood glucose does not fall by 10% in first hour, then give 0.14 units per kg as bolus and continue infusion at the same rate. Blood glucose usually decreases by 75 to 100 milligram per deciliter per hour. Continue same treatment till the patient is stable and blood glucose is in the range of 150 to 200. Then reduce insulin infusion to half. That means 0.05 units per hour. The replacement of potassium is of importance in these patients because of osmotic diuresis, serum potassium falls, and when and due to acidosis, the potassium from cells moves out into the serum. So the potassium level may be normal or even raised. And as soon as the acidosis is corrected, potassium level starts falling. So it is important to know about this condition by then. And if serum is less than 3.3 milliequivalent per liter, do not give insulin until serum potassium is corrected. Give potassium at the rate of 20 milliequivalent per liter. And if serum potassium is more than 5.2, do not give potassium unless acidosis is corrected. You must remember those things. Monitor blood glucose every 1 to 2 hours. pH, electrolytes, bicarbonates, anion gap every 4 hours. Bicarbonate should be given. There is controversy in bicarbonate therapy, but should be given only if pH is less than 6.9. You have managed the patient, then when to, the surgeon is asking, when will you get my case done? So, when to go for surgery? For DK, blood glucose level should be 250 or less. pH should be more than 7.3. Bicarbonates more than 18. And decrease in ketones 0.5 millimole per hour. Calculated anion gap should be less than 12 millimoles per liter. For HHS, patient should improve mentally and blood glucose level should be 300 or less, and osmolality, serum osmolality should be less than 320 milliosmol per liter. For NSIC management, there is nothing very special, especially lower limb surgery, gangrene or low extremity block may be given or spinal anesthesia may be chosen depending on the patient or your ability, but you have to reduce the doses of local anesthetic for spinal anesthesia and should be careful that extreme precautions are taken that no infection there. Or avoid, if you are giving a block, avoid addition of epinephrine to local anesthetic because it increases chances of ischemic and injury due to edema. So do not use epinephrine. Additional management in the patient, put nasogastric tube if patient is unconscious or semi-conscious, or if vomiting is protracted, put a urinary catheter, CVP if required, and antibiotics if infection is suspected. Just a few lines about diabetes and pregnancy. The chances of hydramnios and hypertensive diseases is common in pregnant patients. Insulin requirement in pregnancy is high, but it dramatically falls after delivery of baby. So you should be very, very careful. Liver anesthesia can be provided very good, but avoid infection. Single shot spinal for cesarean delivery is very good. Risk of large-sized baby, macrosomia, and neonatal hypoglycemia is high. Should be careful about these things. Now, some questions that are asked, frequently asked, you may say. What is insulin resistance? Insulin resistance is less than normal or delayed biological response to insulin and is usually related to response to receptors. This insulin resistance increases in the perioperative period due to counter-regulatory hormones, FFA and cytokines. What is hypoglycemic unawareness? It is failure to have conscious recognition of low blood glucose level. It is usually seen in long-standing diabetes mellitus with frequent bouts of hypoglycemia, where due to sympathetic block, due to this autonomic neuropathy, or where the patient, when the patient is on beta blockers or is taking alcohol. It is also not seen in patients sedated or who are anesthetized. But be careful that hypoglycemic unawareness may also be seen in awake patients. And it is due to loss of sympathetic response to hypoglycemia. What is hypoglycemia? Clinically significant hypoglycemia is defined by Whipple's triad, which has symptoms of neuroglycopenia and symptoms of adrenergic excess and blood glucose level less than 50 milligram per deciliter in adults and less than 40 in children, and relief of symptoms with glucose administration. Symptoms of neuroglycopenia are headache, mental sluggishness, blurring of vision, drowsiness, coma. And symptoms of adrenergic excess are palpitation, sweating. Treatment is sugar cubes, glucose tabs or juice if the patient is conscious. But if the patient is unconscious, then give 50 ml of 50% dextrose in water intravenously. And if the symptoms do not improve or blood glucose does not improve, then you may give the infusion also. If veins are not available, then you may give 0.5 to 1 milligram glucagon by intramuscular injection. I think symptoms suggestive, then I think Dr. Vansh has covered it well. Some tests. This is important that tests should be done only if the clinical history and examination are not conclusive. They are not, you are not supposed to do every test in every patient. Only if you are not sure of the diagnosis. This has been also well covered. This has also been well covered. Now, a few words about HbA1c. It is a measure of percent of hemoglobin that has been non-enzymatically glycosylated by glucose on beta chains and indicates blood glucose control over preceding 8 to 12 weeks. Level of HbA1c of more than 8.6 corresponding to average blood glucose level of 200 milligram per deciliter is considered as poorly controlled. The value of HbA1c is not accurate and not reliable in patients with hemoglobin abnormalities and after massive blood transfusion or with rapid RBC turnovers, for example, in hemolysis. Raised HbA1c in surgical patients is associated with increased morbidity, mortality, MI, infection. Each increase in HbA1c by 1% increases risk of complications by 40%. Optimal HbA1c for surgical patients, as I already told you, is between 6.5 and 7. Now, just to conclude, just to have key points, long-standing hyperglycemia has macro and macrovascular complications. Maintain near normoglycemia, blood glucose between 120 to 180. Prevent hemodynamic instability, metabolic derangement, and hypoglycemia. Frequent blood glucose monitoring is the mainstay in management of surgical patients. Patients with diabetes type 1 must receive some basal insulin, even blood glucose is normal. Otherwise, ketosis may be there. General anesthesia must sign of hypoglycemia, so frequent blood glucose monitoring during general anesthesia. Hypoglycemic unawareness can also be seen in awake patients. Tight perioperative glucose control no longer recommended. High risk of hypoglycemia is in patients who are taking long-acting insulin and long-acting OHA. Ideally, there is no cutoff blood glucose level to cancel the surgery, but blood glucose less than 180 milligram per deciliter is optimal, and if it is more than 250, it leads to impaired leukocyte function, so high risk of infection. Perioperative hyperglycemia increases risk of stroke, ILS, infection, and longer hospital stay and death. The chief aim of our management is to achieve outcome equivalent to non-diabetic patients. Thank you so much. Any questions?
Thank you, ma'am. Thank you so much. There are some questions. So I have on insulin therapy that I have answered while in the chat box. So after that, we don't have new questions.
Okay.
It was nicely simple, sober, and I think crisp thing about diabetes that one should know the preoperative. Dr. Vansh has covered how to optimize, how to investigate, and what should be the treatment goal in this patient. Madam has covered point wise, and this can come in long case or in theory paper as a diabetic patient, and like complication can be asked, that also been covered in this lecture by madam. So thank you so much, ma'am, for your time, because we have bothered you every time. A video banaiye, now PPT banaiye.
Most welcome. Most welcome. Thank you so much. It was a nice program.
So, yeah, ma'am. Thank you so much. So we are going. Ji, ma'am.
Okay. Thank you so much.
Okay. Now we are going to last session of today's program, and this is approach to a case of pneumectomy or lobectomy, and also the patient for one lung ventilation. So before going this, I will like to thank all the chairperson for the diabetic session, Dr. Josna Agrawal madam, Dr. Shobha Jaffa madam, and Dr. Rajni Kapoor madam, and Amit Rastogi, and Dr. Vansh for their help to conduct the diabetic session. So the chairperson for the next session is Professor Sanjay Dhiraj. Professor Sanjay Dhiraj sir is a professor here in Department of Anesthesiology at SGPGI, and we have thank you Os visual. So his special interest in pain and palliative medicine. Besides, he is working with us in transplant for quite long, and he is very humble, I will say one thing. तो उनका जो नेचर है वो क्राइसिस में भी हम लोग को मदद करता है. And
thank you.
we have Professor Pallavi Ahluwalia madam. Professor Pallavi Ahluwalia madam is a professor and head Department of Anesthesiology at TMC Muradabad. Welcome, madam. And let me read the CV of madam. He is from TMC Muradabad and is special interest in critical care, obstetrics and pediatric anesthesia. She has been an active member of almost all Society of India, and she has been the editor-in-chief of Journal of Anesthesia and Analgesia, and she has been awarded by IMA and Indian Society and the UP State Coordinator for Padam Singh Research and Development Scheme. So welcome, chairpersons, and I request Sanjay Dhiraj boss to please introduce our speaker, Professor Puneet Goyal.
Yeah, so no introduction needed for Dr. Puneet. He's a professor in our department, and he has done his DM in cardiac anesthesia, and he's an astute anesthesiologist and always keeps calm, and he has done many cases in one lung ventilation. So let us start the session and get knowledge from him.
Thank you, Dr. Sanjay.
Slide visual है आपकी और आपका फोटो भी आ रहा, वॉइस भी आ रहा, बॉस. Please continue.
Okay, thank you, Dr. Sanjay, for nice introduction. And I'll just start with the learning objectives. So what are the things that we will learn after this presentation? So my focus will be on the pre-operative assessment, which is specific to a patient who is requiring pneumonectomy. Then challenges which is posed because of changes in the pathophysiology associated with pneumonectomy, and then approach to anesthetizing a patient for pneumonectomy, like how to conduct a one lung ventilation, what are the various techniques and methodologies by which one can achieve one lung ventilation, and then common complications which we encounter after pneumonectomy surgeries. So 1933, the first pneumonectomy was performed on an obstetrician and gynecologist. He was a doctor and he presented for a lobectomy for lung cancer. But the findings during the surgery were such that the extent of the surgery was increased and he landed into pneumonectomy. But the good thing was that Dr. Gilmore continued to practice medicine for 24 years after this surgery. So that was the first thing. Then why we are so much worried about the pneumonectomies? The important thing is that there is increased risk of perioperative pulmonary complications and long-term respiratory complications following lung resection. That's why there is so much of debate. We can see that 30 days survival is 92% and 1 year survival is 74% after pneumonectomy. Whereas if we go for a limited resection like lobectomy or sleeve resection, this survival is like crosses 98% and 1 year survival crosses 89%. So the minimum resection, minimum loss of lung parenchyma, better is the outcome. What are the risk factors? First thing is ASA class of the patient. If it is belonging to class 3 or more, age more than 75 years, history of smoking, high BMI, presence of COPD, and one should remember that most of the patients will have a history of smoking and COPD in common. And the literature suggests that 75% of the diagnosed patients will have both COPD and lung cancer. So if the patient is coming for pneumonectomy for carcinoma lung, you have to deal with the problems of COPD also along with that. So double issues. So most common indication for which the patient comes for pneumonectomy is bronchogenic carcinoma, where the anatomical lesion is not amenable to alternate resection, as I suggested earlier, that lobectomy is not possible. And this happens when the tumor is arising from mainstem bronchus, proximal to bronchus intermedius, or tumors which are having involvement of lung hilum. Then other non-malignant diseases like traumatic injury of the lung with uncontrolled hemorrhage, which has got a potential to spill to the other lung, and it can damage both the lungs. Before that, one lung needs to be controlled or the hemorrhage needs to be controlled. And chronic infective disorders like tuberculosis or fungal infections, which have got considerable lung destruction. So in those patients, the pneumonectomy is performed. The best assessment of respiratory function comes from the detailed history of patient's quality of life. It can give you a detailed idea how the patient would have the quality of life, how much his meds are. And baseline simple spirometry, if done preoperatively, can also give you a valuable information. Then objective measures are done for the pulmonary function assessment. That provides the information in a format which can be easily transmitted between the members of the healthcare team. So that is important. So the respiratory functions can be divided into 3 related but independent areas. One is respiratory mechanics, second is gaseous exchange, and third is cardiorespiratory interactions. So first thing is respiratory mechanics. So most important and simple test is forced expiratory volume in 1 second, or FEV1. Then second is forced vital capacity. And then third is maximum voluntary ventilation. And then residual volume to total lung capacity ratio. And these values are usually expressed whenever you performed a PFT. Then they are presented with respect to the patient's age, gender, height, and weight. And most valid single test for post-thoracotomy respiratory complications is predicted postoperative FEV1, commonly known as PPO FEV1. So how do we predict the post-operative FEV1? So we should know the normal anatomy and physiology. Like we have got 42 total subsegments of the lung. Right upper lobe has 6, right middle lobe has 4, and right lower lobe has 12. And on the left side, upper and lower lobe each has got 10. So if we are going to remove right lower lobe, then how to calculate the post-operative FEV1 decrease will be 12/42. That is 29% reduction will be there in the FEV1. That's how we can calculate and we can predict the post-operative FEV1. And based on this predicted post-operative FEV1, if it is more than 40%, then the patient is considered a low risk. And these patients, most of them can be safely extubated in the operating room if they fulfill the other criteria. If they are less than 30%, then they are high risk and they should be planned for staged weaning from mechanical ventilation. They should be shifted to ICU. And in these patients, you have to be very careful. And then if the post-operative FEV1 predicted one is between 30 to 40%, then these are borderline cases, and in which in these patients, the decision has to be taken based on the other parameters like exercise tolerance and diffusion capacity of the lung for carbon monoxide and ventilation perfusion scan. Then second category of tests are lung parenchymal functions. Lung parenchymal functions is basically the ability of the lung parenchyma to gaseous exchange, that is exchange of carbon dioxide and oxygen from the pulmonary vasculature. So ABG preoperatively can give you a valuable information in the form of PaCO2 and PaO2. And other thing is diffusion capacity of the lung for carbon monoxide. So DLCO correlates with the total functioning surface area of the alveolus and capillary interface. And thus, the way we predicted FEV1, in the similar manner, DLCO can also be predicted. And if the DLCO is less than 40%, then it correlates with the increased risk of respiratory complications. And one should also remember that if the patient has received preoperative chemotherapy, then he's going to have further negative effect on the DLCO. So he's going to have a reduced DLCO. So preoperative chemotherapy, you have to specially subject these patients for various kinds of pulmonary function tests. Then the final and the third important group of respiratory function is the assessment of cardiopulmonary interaction. This cardiopulmonary interaction can be done with in the form of formal laboratory exercise testing, or as I said, with the clinical parameters. So maximal oxygen consumption, or VO2 max, is derived by these laboratory testing, and it is the most useful predictor. And the risk of morbidity and mortality is high if the preoperative VO2 max is less than 15, and it is considered a contraindication to pneumonectomy if it is less than 10 ml per kg per minute. So how do this maximal oxygen consumption is calculated? This is calculated by cardiopulmonary exercise testing, or commonly known as CPET. This CPET is can be done either with a cycle ergometer, or commonly it is done with a treadmill. And we can calculate peak oxygen consumption and anaerobic threshold. These are the two important parameters that we derived from the cardiopulmonary exercise testing. And what are the indications of doing CPET? First thing is to evaluate the dyspnea. So why it is important? Because we are able to distinguish the cardiac from pulmonary from peripheral limitations of dyspnea. And then detection of exercise-induced bronchoconstriction can be done, and detection of exertional desaturation. If the patient desaturates during exercise, he is a high risk for pneumonectomy surgery. So these are the other indications like preoperative evaluation and risk stratification, prognostication of life expectancy, disability determination, and so on. So if the VO2 max is more than 15 ml, it is a good physiological function. And if it is more than 20, the patients can be safely subjected to pneumonectomy. But if it is less than 10 ml per kg per minute, it is usually regarded a contraindication. So one should remember as an MD student these values, because examiners would be interested to know what is the post-operative FEV1. You can safely conduct the pneumonectomy surgery. What is the VO2 max values? So one should remember all these things. So as I said, if you are not able to perform cardiopulmonary exercise testing, then you can do a 6-minute walk test that can correlate with the VO2 max. If the VO2 max, if the distance of 6-minute walk test in the meters if divided by 30, that can give you a value of the VO2 max. So if the CPAT is not available, you can ask the patient to walk for 6 minutes, calculate that, measure that distance in meters and divide it by 30. That will give you a VO2 max value. And then decrease of oxygen saturation more than 4% during exercise is also considered a risk factor for pneumonectomy. Traditional exercise testing in the ambulatory patient is stair climbing. If the person is able to climb 5 flights of stairs, it correlates with the VO2 max of more than 20. So remember this, 5 flights of stairs, 20 ml per kg per minute. 2 flights of stairs corresponds to 12 ml per kg per minute. And then right ventricular dysfunction is also associated with these patients, which is also contributing to the pulmonary vasculature problems. So if there is a clinical evidence of the hemodynamic problems in the patient, then this patient should be subjected to transesophageal echo and evaluate for the right ventricular dysfunction in this patient. Then last investigation is ventilation perfusion scintigraphy, or commonly known as VQ scan. So if the lung region to be resected is non-functioning or minimally functioning, that can be identified by VQ scanning. So it gives you an idea, like if you are going to, if that lung segment is not functioning, then you know that this is not contributing to the functional capacity of the patient, and this can be safely removed. So this gives you an idea. And if the VQ scan should be considered in those patients who have got a preoperative FEV1 less than 80%. So this will give you a valuable information. So whenever you are going to assess a patient in a holistic manner, then no single respiratory function will give you a valid preoperative assessment. You have to have a battery of tests, and from all the 3 category of investigations like lung mechanics, parenchymal function, and cardiopulmonary interaction. And these 3 aspects, they form the 3-legged stool in the foundation of respiratory assessment. Then other concomitant medical conditions, they also have a profound effect on the perioperative management of these patients. Frequently, cardiac diseases are commonly associated with these patients, and this is second most common cause of perioperative morbidity and mortality in the thoracic surgical population after the pulmonary complications. So majority of the pulmonary resection patients would have a smoking history as a risk factor, and pulmonary resection itself is an intermediate risk procedure in the terms of perioperative cardiac risk factors. So incidence of post-thoracotomy ischemia is 5%, which peaks on 2nd and 3rd post-operative day. So in all these patients, standard history, physical examination, and ECG should be a routine screening test for all patients in pre-thoracotomy period. Non-invasive testing should be done in those patients who have got major clinical predictors for myocardial ischemia like unstable angina, recent MI, severe valvular heart disease, or significant arrhythmias. And they should be therapeutically optimized in the form of medical therapy or coronary angioplasty or CABG surgery. Timing of lung resection after myocardial infarction is always debatable. Delay of 4 to 6 weeks in a medically stable patient who is fully investigated and optimized is acceptable. After a coronary stenting with a bare metal stent, 4 to 6 weeks delay. And if the drug-eluting stent has been put, a minimum of 6 months delay is required. Then arrhythmias are also common with pulmonary resection surgeries. They occur in 30 to 50% of the patients, especially in the first week postoperatively. And incidence of atrial fibrillation is the highest. And they correlate with the extent of lung resection and intraoperative blood loss. And so these patients can be treated with a preoperatively putting these patients on various drugs like digoxin, other atrial antiarrhythmics like beta blockers, verapamil, diltiazem, or amiodarone. Then age-related factors. If the patients belonging to higher age group, then the risk of respiratory complications are going to be double as compared to younger population. And risk of cardiac complications become triple than the younger population. So if the patient is elderly, then you are going to be more careful. Postoperative outcome among older patient after lobectomy is more acceptable than the pneumonectomy. So as a proportion of all lung cancer resections, pneumonectomy has decreased to approximately 1/3 as it was used to be done 15 years ago. And in older patients, as a minimum cardiac investigation, transthoracic echocardiography should be done to rule out pulmonary hypertension. So look for the PRVSP, look for the pulmonary hypertension and RV dysfunction in these patients. This will have an independent risk factor for the postoperative outcome of these patients. Then what is the physiology of one lung ventilation when we are putting these patients under anesthesia? So one lung ventilation, the patient is put in the lateral position with the lung which is going to be performing, on which the surgery is going to be performed would be in the non-dependent position, and the other ventilated lung will be in the dependent position. So perfusion to the dependent lung will be increased because of the effect of the gravity, and it will cause VQ matching in a dependent lung because of the adequate oxygenation till the patient is awake and breathing spontaneously. But as soon as you anesthetize the patient, the mediastinal shift will cause circulatory and the reflex changes similar to that of the tension pneumothorax, because there is a downward mediastinal shift of the non-dependent lung in the non-dependent hemithorax. And also the compliance is reduced. So if we see the pressure volume loop, the compliance of the non-dependent lung will be shifted from this position to this position, and that is one step down, and as well as the dependent lung would also come down on the compliance curve. So because the induction of anesthesia causes loss in the lung volume in both the lungs, thereby reducing the compliance. So the anesthetized patients in the lateral decubitus position would have less tidal ventilation in the dependent lung, where there is more perfusion. Thereby, there is a natural shunting of the blood without getting oxygenated. So it is producing a kind of shunt. That's why you get a problem when oxygenating the patients or removal of CO2 during one lung ventilation. So I want to give you one concept of hypoxic pulmonary vasoconstriction. This is a normal physiological response to hypoxemia, and it is because of a reflex contraction of the vascular smooth muscles in the pulmonary vasculature in response to low partial pressure of oxygen. So because of this protective physiological mechanism, the one lung ventilation is possible. So if HPV is not there, it will not be possible to perform one lung ventilation, because it is a protective mechanism which diverts the blood flow away from the hypoxic areas to the lungs, to the areas which have got a better oxygenation. So as you are able to maintain the oxygenation as well as normal CO2 during one lung ventilation. So you have to avoid all those factors which reduce the HPV, and all the volatile anesthetics at a MAC value of more than 1, they inhibit HPV. And IV anesthetics have got a little effect on hypoxic pulmonary vasoconstriction. That's why the IV anesthetics like propofol are preferred to maintain anesthesia during one lung ventilation. Then there is a biphasic nature of hypoxic pulmonary vasoconstriction. There is rapid onset, which phase, which is lasting for 20 to 30 minutes. And then there is a delayed phase, which starts after 40 minutes and plateaus at 2 hours. And offset also occurs in a biphasic manner when you discontinue one lung ventilation. So major problem comes during one lung ventilation is when you are unable to maintain saturation of the patient. So how to improve oxygenation when there is a problem of low SpO2? First thing is to perform a recruitment maneuver to lungs, ventilate with 100% oxygen, then apply a little PEEP of 8 to 10 centimeters to the ventilated lung. PEEP will raise the end expiratory volume of the ventilated lung to near the FRC, and thereby you will be able to achieve oxygenation. And then you can put CPAP to the non-ventilated or collapsed lung, and it can be easily applied through a double lumen tube or a suction channel of a bronchial blocker. Then in extreme circumstances, you can ask the surgeon to directly compress the blood flow to the pulmonary artery of a non-ventilated lung if the surgeon has got the access. This will divert the blood flow to the ventilated lung and you will have improvement in the oxygenation. But this is rarely required and sometimes it is not possible also, but if it is possible, you should remember this. And then PA catheter, if can be positioned in the pulmonary artery and balloon can be inflated at the induction of the anesthesia, and it can also be used to block the blood flow to the pulmonary artery, but this is rarely required. But in the textbook, the technique has been described. Then how to perform the collapse and positioning of the patient. So the one thing one should remember is whenever you are going to initiate the one lung ventilation, don't before collapse of the lung, don't ventilate with 100% oxygen. Denitrogenate the patient with operative lung with 100% oxygen, because if you will ventilate with the air, it will have got a low blood gas solubility and it will delay the collapse. So if you ventilate with 100% oxygen, then it will facilitate the collapse of the lung on which the surgery is going to be performed, and you will have less problems with the surgical team complaining again and again that the lung is not collapsed. So ventilate with 100% oxygen before starting collapse. Then patient positioning, always recheck the position of the DLT or a bronchial blocker after the patient has been positioned. And we should remember the various injuries which can happen during positioning. In the dependent arm, basically compression injuries. In the non-dependent arm, stretch injuries are common. And hypotension can occur when you put the patient in lateral position because of the loss of the vascular tone. Then comes the various techniques. This is the most important aspect of the one lung ventilation, because if you are not familiar with the techniques and the gadgets, you will not be able to achieve one lung ventilation. So mechanical separation of the two lungs is needed to allow one lung to ventilate, and while the other lung is being compressed by the surgeon and allowed to passively deflate and perform the surgery. This is an important prerequisite. Indications of one lung ventilation. Absolute indications are to avoid the spillage or contamination whenever there is an infection or massive hemorrhage, or for the control of distribution of ventilation like bronchopleural or bronchocutaneous fistula, surgical opening of a major conducting airway, or if there is a giant unilateral lung cyst or bulla is present. And then if there is a unilateral bronchopulmonary lavage has to be performed. Relative indications are those surgical exposures which are of high priority, like thoracic aortic aneurysm, pneumonectomies, and upper lobectomies. And surgical exposures with low priority are esophageal surgery and minimally invasive cardiac surgery like mid-cap. Contraindication for one lung ventilation is if the patient is dependent on both the lungs for mechanical ventilation, or if there is an intraluminal airway mass that is restricting the access to tracheobronchial tree. So to achieve lung isolation, one has to know the tracheobronchial anatomy of the patient. So always try to review the imaging like chest x-rays and the CT scans, which otherwise would also be done by the surgical team. You don't need to order them separately, but just review the various imaging which the surgeon has obtained and you will understand the tracheobronchial anatomy. Whenever possible, use the fiber optic bronchoscopy. Various anatomical facts one should know, which will be helpful in positioning the DLT and bronchial blockers. First thing is that all of us know that right mainstem bronchus is shorter, straighter, wider than as compared to the left. Origin of the carina is at an angle of 25 degrees, and while at the left mainstem bronchus, it is 45 degrees. And the right upper lobe bronchus takes off very quickly after the origin of the right mainstem bronchus. And in many patients, you have got a very short right mainstem bronchus. And it is usually easier to intubate the right mainstem bronchus than left. But it is very easy also to obstruct the upper lobe bronchus also. Because you can see that right upper lobe, right mainstem bronchus, it is so short and it is got more in line with the trachea. So it is easier to intubate. But the thing is that you can easily block the right upper lobe of the right lung. So you will further obstruct the flow. So that's why the right sided DLTs are less preferred as compared to left sided DLTs, because the margin of safety is more in the left mainstem bronchus, is because the left mainstem bronchus is more long and the origin of the upper lobe bronchus is after a considerable distance. Then various methods, most common are double lumen tubes. Now the availability of bronchial blockers has also increased. Various companies have launched their blockers in the market and we are using quite a few of them. And then in the pediatric patients, when these things are not available, then you can usually advance the single lumen endotracheal tube to achieve one lung ventilation, or you can use a balloon tipped catheter like Fogarty or other things. I'll tell you about the double lumen tubes now. They are designated. Basically, these are two single lumen tubes which are bonded together and they are designated as left or right. The various types which were used earlier were the Carlins and Robert Shaw. In Carlins, it was a presence of carinal hook that was the distinguishing feature. And in the Robert Shaw, it is a D-shaped lumen and without the presence of carinal hook. But nowadays, we are using mostly the disposable DLTs, which are made up of PVC. The other improvements in the design of the DLT is the radiological marker, which has been placed near the endobronchial or endotracheal cuffs. And these disposable tubes are supplied with a stellate, connector, suction catheter, and sometimes even a means to supply a CPAP to a non-ventilated lung. So these are coming in a comprehensive package and they are easier to use. Important thing to remember is resting volume and the compliance of the bronchial cuff varies between the various DLTs and the brands. Blue marking on the pilot balloon is for the bronchial cuff, and bronchial cuff for the right-sided tube is again variable in shape. Sometimes it gives you an entry hole for the right upper lobe bronchus also. Fewer DLTs now have got a carinal hook, but it was there earlier, which was helpful in proper placement and minimizing the tube movement. And as I said earlier, right-sided DLTs have got a modified slot for the ventilation of the right upper lobe bronchus. This is also asked in the practicals as well as in the theory, how to select the size of the DLT. So in general, a largest DLT that can be atraumatically introduced into the bronchus should be chosen. Adult DLTs are coming in the size of 35, 37, 39, and 41 French. While for the younger patients, they are also available in 26, 28, and 32 sizes. The outermost acceptable position of the left-sided DLT is the bronchial cuff. It should be just below the level of the carina. And right-sided DLT tubes, it is acceptable when there is a upper lobe ventilation is possible with the right upper lobe orifice. There is no absolute accurate method for selecting the correct size tube. Age, gender, height, and weight are poor predictors. Direct measurement of the bronchial width by imaging is a good method, and diameter of the left mainstem bronchus is directly proportional to the tracheal width. So if you are able to measure the tracheal diameter, you can easily measure or calculate the left bronchial width. So this is the formula for the measurement of the left bronchial width. It is 0.45 into tracheal width in millimeter on chest X-ray plus 3.3. So that should be the size of the or the diameter of the left mainstem bronchus. And then this is a rough estimate based on the height and the gender. Female patients less than 160 centimeters, 35 size tube. More than 160 centimeters, 37 French tube. Male patient less than 170 centimeters, 39 French, and male more than 170 centimeters, 41. And depth of insertion is equal to 12 plus patient side divided by 10. So these are the various formulas. Tube choice, right versus left. As far as incidence and severity of complications are concerned, they are the same. Right-sided DLTs, right-sided surgery, left-side DLT should be used. During left lung surgeries, whenever possible, again use left-sided DLT. Right-sided DLT should be used whenever it is important to avoid left-sided manipulations, like if there is a distorted anatomy of the entrance of the left mainstem bronchus, like external or intraluminal tumor compressions, descending thoracic aortic aneurysm, or site of the surgeries involving the left mainstem bronchus, like left lung transplant, left tracheobronchial disruption is there. The surgeon has to perform left pneumonectomy or left-sided sleeve resection. So in most of the cases, preferred type is left-sided DLT. Placement, it's basically a practical topic. I can just tell you one point is that when introducing the DLT, the distal curve, that is the bronchial curve, is facing anteriorly. And once you have advanced it through the glottis, you rotate it to the 90 degrees to the side of the tube in which you are going to insert. Like left DLT, you rotate it 90 degrees and advance it till you feel a resistance. And then inflate the bronchial and tracheal cuffs and then ventilate both the lungs separately and check. And if you have to check the position, introduce the fiber optic bronchoscope through the tracheal lumen, not through the bronchial lumen. It is better to advance it through the tracheal lumen where you can visualize the carina, and then you can easily see on which side of the left or the right the bronchial lumen of the or the bronchial portion of the DLT has gone in. So fiber optic bronchoscope is the most accurate method to guide double lumen tube. More time is required. You need to be familiar with the gadget, and one should not overinflate the bronchial cuff. Overinflation may cause herniation of the cuff into the trachea or the bronchial segment and can obstruct the ventilation. Confirmation, I told you. Then problems that are there with the DLTs are size selection. They are unsuitable in difficult airway situation. They are not optimal for post-operative ventilation. So one has to change it to single lumen tube, malpositioning during the surgery, and airway trauma. So the second type of gadgets after DLT are the bronchial blockers. So bronchial blockers, if they are enclosed with a modified single lumen tube, they are known as univent tubes. And then bronchial blockers which are coming independently, they are of 4 types: Arndt bronchial blockers, Cohen bronchial blocker, Fusey, and Easy blocker. So this is the univent tube. You can see this is a single lumen tube. And then there is a bronchial blocker. It can extend 8 to 10 centimeters beyond the tip of the endotracheal tube. And it can provide isolation, lung isolation on whichever side you want to block, you can do easily. And then you can put CPAP or gent ventilation or oxygen or suction can be applied through the central lumen. Problems with this is they are of fixed shape and there is an incidence of bronchial rupture with the balloon. Then second is a most common bronchial blocker is Arndt bronchial blockers. It was invented by Dr. Arndt, who himself is an anesthesiologist, and they are available in 3 sizes, 5, 7, and 9 French, and 2 lengths, 65 and 78 centimeters. There are side holes at the distal end for the deflation, and they have got a high volume, low pressure balloon, which is spherical or elliptical in shape. And then inner lumen contains nylon wire, and which can be passed through the bronchoscope. You can see this is a nylon wire and it can be entangled with the tip of the fiber optic bronchoscope, and it can be advanced into the desired left main or right main stem bronchus, depending upon the site of blockage. Then second bronchial blocker is a Cohen tip deflecting bronchial blocker, which is similar to Arndt. It comes with a 9 French size and 65 centimeters length. It has got a high volume and low pressure cuff. Side holes are there between the tip and the balloon to evacuate the gas. And there is a proximal control wheel to adjust the tip deflection. You can see that the distal tip is pre-angled and there is a torque grip at 55 centimeters mark, which allows for the rotation. And you can rotate to the left or to the right and then advance it to block the particular bronchial blocker. And then you can check through the fiber optic bronchoscope what is the position. Then third is a Fuji uni blocker. It is again an independent blocker. It has got a high volume balloon made up of silicon and which has got a gas barrier property to reduce the diffusion of the gases into and out of the cuff. So during prolonged one lung ventilation, the cuff pressure will not change. There is a fixed distal hockey stick angulation to facilitate the insertion. So you can see this is a Fuji uni blocker. And then last and the most recent is a easy blocker, which is a Y-shaped distal bronchial blocker, and it is available in the 7 French size. It has got a Y-shaped bifurcation and it can be inserted only with the endotracheal tube of more than 8. This end of the Y sits on the tracheal carina, and then you can inflate the balloon and you can block either of the main stem bronchi. Other methods, I told you earlier itself, in pediatric population, you cannot use double lumen tubes or bronchial blockers. Then you can use Fogarty catheter or Foley's catheter or Swan-Ganj catheter, especially in the children less than 10 kg body weight. And if there is an endobronchial intubation, it can be performed with the advancement of single lumen endotracheal tube also. Problems with the bronchial blockers are when inflated, they may dislodge above the carina. They can cause hypoxemia, airway injury, and may move during the surgical procedure. The various pros and cons between the DLTs and the bronchial blockers. We can easily achieve 2 lung ventilation with both of them. Then independent lung ventilation is possible with DLT, whereas with bronchial blockers, it's not possible. And then either lung can be recruited separately. If you are using bronchial blocker, collapsed lung cannot be recruited separately. And it needs to be replaced by DLT needs to be replaced by single lumen tube at the end of the surgery. This is a major disadvantage. And whereas bronchial blockers, you can simply pull it out and the single lumen endotracheal tube, which is there, will remain inside. Then few words about the postoperative management. I already described this slide, and if the preoperative FEV1, which is predicted for the postoperative period, is the major predictor for the outcome of the patient. If it is more than 40%, the patients are going to have a good outcome, and if it is less than 30%, they will have a poor outcome. Postoperative pain control is extremely important, and it can be delivered with various techniques, including epidural analgesia, paravertebral block, erector spinae block. Various techniques now have been used. Especially, one has to use multimodal analgesia to give adequate pain control. Various postoperative complications, one has to remember acute CO2 retention in the post-operative period, prolonged mechanical ventilation, infections, atelectasis, bronchospasm, pulmonary embolism, cardiac arrhythmias, MI, and post-operative mortality. These are the various things that can be there in one can expect in the post-operative period. I think I have covered most of the major areas, and if there are any questions or comments, I will be happy to answer them.
I think there is no more questions from the audience, even on YouTube and chat box. But you have very well nicely covered and compared all the fine-tuned points on the given topic. And it's very useful also not only for the exam, but also the clinical point of view for a management, any patient, when anyone is doing. Very good, boss. Very good. Thank you. Any comment from the chairpersons? Any comment from the chairpersons?
So excellent presentation, and Dr. Puneet was able to cover all the points regarding one lung ventilation. So any questions from the audience are most welcome.
And boss, please send the PDF of your at least presentation so that we can circulate to the participant.
Okay, I'll do that.
Okay. Yeah. So I think with permission of chairperson, we can conclude the session. If there is, bronchial, one question. Bronchial balloon volume for Fogarty catheter.
See, Fogarty catheter is available in various sizes. So usually you are inflating it with the 2 to 5 ml of air. So this is basically an embolectomy catheter, which is used to perform embolectomy, like that is clot removal of the venous or the arterial vessels. So this is available in various sizes like 5 French, 2 French, 3 French, 4 French. So depending upon the size, there is a balloon, the volume of the balloon. It varies from 2 to 5 ml.
Okay. I think they can get a table also where it is written the size and volume. They can understand in the books. Any other question? So no other question was with permission of the chairperson, we can conclude the session. Thank you so much.
Okay, thanks.
Thanks.
Thank you.
Okay, boss. Bye. Thank you. So I am ending.